because that burns maximum calories. So in short, by failing to prepare, we are preparing to fail. So it's a nice time to start thinking about your own body, whether you are really fit. I define fitness as an ability of a person to live a healthy and well-balanced life, which involves physical, social, as well as emotional aspect of life. There are two types of fitness, so I'm going to talk only about the health-related component today, which involves cardiovascular, muscular endurance, muscular flexibility, and the right body composition. Just for all of you to understand, we deal with a lot of musculoskeletal system. And vitamin B12 plays an important role for our muscle and nerves. And vitamin D3 plays an important role for the bones. And most of your patient that comes with a complaint, okay, they have a pain here, they have a pain there, please check their B12 and D3. Just normalizing the B12, D3, most of the pains will go away. And these tests are not on a normal blood test. So when a normal blood test has come, B12 and D3 won't be there. I feel more than 60% of Indians have a deficiency in B12 and D3, both. My PhD student had done a study on 8 football teams. All the 8 football teams had deficiency in D3 and B12. So we took our parameters of kicking the ball, how much it travels, jump, speed, everything. And when we did the blood test, it was deficit. When with injection we brought it back to normal, everything improved, including the lung capacity. Again, the 5S of fitness. Nothing is impossible. 280 kgs reduced in 2.5 years. So whenever you plan, yes. So I believe that impossible also means I am possible. But for fitness, we prefer using shortcuts. We are always finding whether there is any medicine that can make you fair, any tablet that can reduce the pain, anything that can reduce your weight. Sauna was one of the things that came that everybody thought taking sauna bath will reduce your weight. It reduces the body fluid, which comes back as soon as you start drinking water or any fluid. Then came aerobic. We thought aerobic will reduce weight. People started doing yoga, not knowing that we have therapeutic yoga, we have a spiritual yoga, we have a breathing yoga. So you should understand which yoga you are doing, just not looking at the television. Then the health farms all over. Started from Bangalore, health farm. People started going to health farm to be fit. Leaving a person confused, okay, yes, they want to be fit, whether they should go to a gym, aerobics, slimming pills, or yoga. It left them confused what to do. We believe that success is very demanding. You need to work hard if you want to be fit. Just a simple example, in 1990s, the televisions were fat and people were slim. But by 2023, the television became slim and people went fat. Because one reason, remote control, nobody wanted to walk up to change the channels. Best way to get fit is learn to say no. See whether really the body needs food. Don't have it just because when you see food. An example is of ants. They are walking around the lollipop. They decided not to have it. So if ants can, why can't we? We should be committed to a fixed diet. Giving a very simple example, you have a two-wheeler or a four-wheeler, you go to a petrol pump, you fill petrol. When you come out, you see another petrol pump. Do you go in again? No. You say, okay, my scooter says when I need petrol. Car has a meter which shows. Same thing is the body. So in us, whenever we see food, we feel like eating. We say that we need to eat because you saw food. Just to break up, understand 7,000 calories equal to 1 kg. 1 gram of protein is 4 calories. 1 gram of carbohydrate is 4 calories. But 1 gram of fat is 2.5 times more, 9 calories. And the sources of fat comes to butter, ghee or oil. There is no difference between oil, ghee and fat, oil, ghee and butter. So please, whatever you use, the calorie content is same. So what you have to see is calories, not what you are eating. Again, fats are two types. The visibles are ghee, butter, oil, cheese, whatever you see, and what is added in the food. And the non-visible one comes in non-veg. All non-veg have got fat with it. And of course, with cereals and pulses, there are some extent of indirect fat. Our enemies are all the things that we love: pizzas, burgers, ice cream, kulfi. So in short, I say anything that is tasty is high in calorie. So one of the way when you feel it's tasty, you should understand it has to be high in calorie. Very simple example I give: 2 potatoes, 100 gram. When you boil it, it is 100 calorie. Same potato, when you fry it, whether in butter, oil or ghee, the same 100 gram potato becomes 380 calories. So the 280 calories have come from oil, ghee or butter. So that is where, but because it is tasty, we will have 1 kg of French fries also, but we cannot have 50 gram of potato that is boiled. So the taste increases the calorie content. And yes, studies have shown that if you bring down your cholesterol by 10%, you reduce the risk of heart attack by 50%. So next time when you are checking your parents' cholesterol level, see that they reduce it by 10%. Our friends are vegetables and fruits, but we don't like them. We should keep having our vegetable and fruit seasonal, because each vegetable and fruit has got different minerals and different vitamins. Just to break up how we have these calories, roughly all the fruits are around 100 calorie. See that watermelon, if you can see at the center, if you have the full, it's going to be 50 calorie, but a mango is 250 calorie. But taste-wise, the mango is much tastier. You can have 5 of it also, but you cannot complete a watermelon. Maximum you can have half a watermelon. So the calorie contents are very important. Giving an example, a boiled egg is 50 calorie, but once you make it into omelette or fried egg, it goes up to 250 calories. So that 180 to 200 calorie comes from the oil, butter or ghee. A plain cake, if you see, it's 150 calorie, but if you have a chocolate cake, it's 250 calories. So the 100 calorie comes from the chocolate in the cake. And see the difference between kulfi and ice cream. 150 gram, a scoop of ice cream is 380 calorie, but a scoop of kulfi is going to go to up to 780 calories. A simple example, a milk is 100 calorie, but if you make a tea out of it, putting sugar, it's going to become 100 calorie. But if you make that milk into curd, that 60 calorie remains 60 calorie. A spoon of sugar is 20 calorie. But a tea of honey is going to be much more, 48 calorie. But honey has its own medicinal value. So it's going to be any day better than the sugar. All pulses have high protein, so those who are vegetarian should have pulses, because source of protein is going to come from the pulses. We need to be committed to some exercise every day. Exercises can be done at home also. It starts from home. We have lovely beaches in Mumbai to do your exercise or go for a walk. We need to run to lose weight and remain fitter. Even Swami Vivekananda said, you will be nearer to heaven through football than through the study of Gita. You will understand Gita better with your bicep muscles a little stronger. Whether you run in your colony or a ground, whether you run indoor on a machine, on a treadmill or on a beach, whether you're running in your own building, classical dancing. So one of my studies on PhD was doing a study on deaf and dumb with classical dancing. You burn almost 500 calories for a session of 45 minutes to 50 minutes of classical dancing. But we love this dancing. And of course that also burns 400 to 500 calories per hour. But this burns much more when you see your knee, hip moving. So a man's health can be decided with what he takes or she takes, climbing the steps or taking 2 tablets, whether you take 2 steps at a time or 2 tablets at a time to keep yourself fit. So climbing step is burning maximum calories, that is 2,500 per hour. Not necessary you do it in 1 hour. Even if you do it 10 minutes a day, by the end of the month, at least you have not increased your weight. We need to work our muscles, whether we breathe, whether we wink, whatever we do, we are burning calories. So minimum a person can burn calories is 100 per day because you are breathing. Even if you don't do anything and you are only breathing, you are burning calories. Whether you go to a 5-star gym or a Gautan gym, what you do in the gym is important. Yes, I believe that sports is medicine, so we should play some sports to burn our calories and remain fit. Whether we play football, whether we play soccer, tennis, squash, basketball. But how much to play or till how long you can do any exercises, we have to remember we should be doing exercise in a safe zone. You must have read in paper many sportsmen, they were playing and they fell dead. It's because the heart rate was increasing more than required. So the best formula is 220 minus your age. For a physiotherapist, I feel 200 minus your age. So if you are around 20 years old, you can take your pulse rate up to 180. You are in safe zone, right? But if you are 40 years old, you have to take up to 160 only, whether you walk, run, or play any sports. So we have a safe zone, how much to exercise. So checking the sportsman or patient's pulse rate after the exercise is important to give a guidance how much they can do. And I strongly believe that the physician will add years to the life, but it's a physiotherapist that will add life to the years. So the quality of life is given by the physiotherapist. So it's high time now, going through Fit India, the role of physiotherapists have increased to see that our patients are also fit. So we said how we put on weight by calories. Now, burning of calories. The first one is using mobile. You use 50 calories if you are sitting and talking, but if you are walking and doing gestures and talking, the calorie can go up to 100 per hour. Gardening, we have forgotten what it is. Eating is 50 calories. Dusting, we don't know what it is. And bathing is 100 calorie per hour. So card playing was 50 calorie per hour, but nowadays when they go to play card, there is a stick kept. They bring the card also in before them with the stick. So it has come down to 25 calorie per hour. Walking leisurely is 200 calories, so don't go in the evenings for a walk. You may burn 200 and end up eating an ice cream which is 380 calorie. So instead of reducing, you are putting on weight. So when you walk for 1 hour, and then go for an ice cream or a juice, you are increasing your weight, you are not decreasing. So usually I always say after exercises for 1 hour not to have anything. Only you can have is room temperature water or lukewarm water. Walking briskly, brisk walk, yes, 500 calories. Cycling is 500, dancing I said 500 calorie. In short, if you want to remain fit, this is the chart you should follow. Lot of exercises, cereals, vegetable and fruits, and then nuts, non-veg, milk, and the least should be the milk products. The dairy products should be the least. But today, the chart has become like this. There is no exercises in our program, and what we have is maximum dairy food, ice cream, cheese, chocolate, which all has dairy product, and there is no exercise with us. So in short, the simplest test is, if you can run over a hurdle, you are definitely fit. That's a sign that you are fit. The second part about fitness, I want to say what we are lacking and pandemic taught us was our lung capacity. Most of the Indians have less than 2 liters. The lung was made for 4.5 to 5 liters air could be taken. And we do breathe only for the 20% oxygen that is in the air. The rest is nitrogen. So no food, injection can replace and give your body oxygen. Oxygen can only come through breathing. When you breathe, you take oxygen, and why you take that? To purify the blood which comes on the base of the lung. The blood becomes pure when it gets oxygen, goes to the heart, and again the heart pumps it all over the body. So that is what we show. The lung capacity is 4.5 to 5 liters, but normally all of us have less than 2 liters. In Mumbai, they charge you 50 rupees per month when you want to go and breathe fresh air. That's a spirometer, how we measure the lung capacity. So all of you all must be having in college spirometer. Check your vital capacity. The base of getting fit is having a good lung capacity. Just a slide to show your muscles don't come from outside. You have to exercise. You have to do resisted exercises. So the muscle fiber requires more blood. So the blood flow increases in this muscle fiber, and each muscle fiber increases by in girth measurement. So the number of girth increasing gives you the bulk of muscle. You don't get muscles by eating. You have muscles. Each muscle fiber's girth measurement has to increase. And increase, if you are doing exercise, this too shows person doing exercise and not doing exercises. By doing exercises, automatically the lung capacity increases. Just for the girls to understand why they are wearing a earring. Our ear is in the shape of baby in the fetus of the mother, and the earring point is the eye point. We want the girls to have beautiful eyes. But most of the time the jewelers does a mistake. Just close to the eye point is the tongue point, which we can hear now. So it's wrongly stimulated, that causes problem. But all our points are in the ears. A study was done on 48 people who had got stroke. 24 of them were made to see humorous movies, comedy movies, and other 24 serious movies. All those who were with serious movies and crying serials, they got an attack again. So please, one of the way to be fit is select your friends. If your friends depresses you every time you meet them, or you hear the same story every day from your friend needs treatment. So let's all laugh together and not laugh at each other. Yes, sir.
Thank you very much, sir, for the amazing presentation. I have gone through few of the points which you have narrated. 63% of people, if you test, they have D3 and B12 deficiency, which are related to the bone, muscles and nerves. So everybody should take care of it. You have to test D3 and B12 to find out the deficits which you are having. Early get-up is very much essential if you want to get vitamin D. So before sun comes, you have to welcome the sun. Yoga, pills and other aerobics are there, but your fitness is more important. Physio is more important. Tasty food gives trouble, more cholesterol. Whenever you are opening the fridge, don't take the tasty foods. Then calories are more important rather than the food which you are taking. Frying is not good. The cooking is okay. Then the food pyramid, which is upside down now, you have to make it to the upright one so that you can be more fit. Then we talked about the lung fitness. Most of the people won't think about the lung fitness. So take care of your lung and smile. You should take care of the ear point so that you can take care of your health. Sir, amazing points. These are the home take messages which I feel everyone will take care of it. Thank you very much for the wonderful presentation. Thank you, sir.
Thank you.
Thank you, sir. I request the chairperson to present a token of appreciation to our speaker. I request Dr. S. Rajshekhar, Dean, Institute of Physiotherapy, Srinivas University, to present a token of appreciation to our chairperson and moderator for the session. Thank you, sir. For the second talk, I invite on the stage the chairperson, Dr. M.R. Shivkumar, Associate Professor, Enapaya Physiotherapy College, and the moderator, Dr. Krishna Prasad, Assistant Professor, Nitte Institute of Physiotherapy. Our speaker for this session is Dr. G. Arunmaya, Dean, Manipal College of Health Professions, Mahe, Manipal, who has left a professional mark on the international platform. He has robust knowledge that he has gained in the last 3 decades. He is our walking encyclopedia. Today, Sir will be sharing with us his abundant wealth of knowledge on the topic, exercise as a medicine in clinical practice.
Very good morning all. So, happy World Physiotherapy Day. I would like to introduce Dr. G. Arunmaya sir. Dr. G. Arunmaya sir is a renowned expert in physiotherapy and diabetic food care. Currently he is serving as the professor and dean at Manipal College of Health Professions, Manipal Academy of Higher Education. He has done his PhD in diabetic food care. With a wide range of professional background, he excels in diabetic food care, tissue healing and low-level laser therapy. Chronic pain management and cardiopulmonary respiratory therapy are his expertise. He has actively engaged in professional organization, including serving as president of the Indian Podiatric Association of Karnataka and membership director for the World Association for Photobiomodulation Therapy. Dr. Maya sir contributed including patent and copyrights for pain relieving, laser shoes and for diabetic peripheral neuropathy. With over 150 publications, numerous national and international grants and leadership and 14 projects, Dr. Maya is dedicated his career for research. He has mentored 15 PhD candidates and with 6 students currently undergoing under his guidance. Thank you.
Very good morning to all of you. The respected chairpersons for the today's session, all the renowned speakers, my seniors, all the delegates from various parts of the country. First of all, a World Physiotherapy Day greetings to each and every one of you gathered here. At the outset, I would like to congratulate and compliment the Mangalore Physicon organizing team for organizing a very prestigious international conference as part of the South Canara Physiotherapy Teachers Associations. Once again, greetings from Mangalore to each and every one of you. My topic of my presentation is exercise as medicine following cardiac surgery. In the previous session, Dr. Ali sir have highlighted about the importance of exercise in the sports populations as well as a preventive strategy, how exercise can be used in the other populations. When we say exercise as medicine, that is not just restricting only to an healthy individual performing exercise for a minimum of 30 to 45 minutes in a day to prevent or to reduce the various comorbidity. Even exercise play an important role when an individual is immobilized in a critical care unit or when an individual is undergoing a surgery, post-surgery, the mobility, the function, the quality of life, all these play significantly reduces. Therefore, even in the early stage of the recovery phase, exercise play an important role. Therefore, I thought how exercise can be a medicine in the recovery patients following the various cardiac surgery procedures. As all of us know the phases of the cardiac rehabilitation, we have 4 different phases of cardiac rehabilitation. but my today's talk I will be restricting only to the early stage or the recovery phase in the phase 1. The phase 1 usually stands up to 0 to 7 days. Subsequently, we have a convalescent stage or the recovery stage. Phase 3 is as a training phase, and then the phase 4, we have a long-term maintenance programs at the community level. Most importantly, following the cardiac surgery, all of us know the patients with the cardiac disease, either now treated conservatively or the medically, depends upon the nature of the involvement. According to the global burden of disease, the cardiac or the cardiovascular disease is the third leading cause in India for an increase in the morbidity and the mortality. Now the patients, when there is a atherosclerotic changes, the patients can go for an immediate angioplasty, or suppose if there is an involvement of the one or more vessel, now even the cardiac surgery like the coronary artery bypass remains an important line of management in these patients. So once they undergo the cardiac surgery, the most important thing is there is structural changes can develop in the body, because one is the vascular part of the cardiac system is actually replaced by the or reconstructed or sutured by the other graft like the arterial or the venous graft. As all of us know, this coronary artery bypass grafting, the surgical incisions have an the median sternotomy incisions as well as, and also the graft is taken from either the peripheral vein or from the peripheral artery. This is important. Why we need to know this? When we go for a rehabilitation following the cardiac surgery, physiotherapists are involved in the prevention of the many postoperative complications as well as for the rehabilitation. What exactly we need to do, what not to do, and how to detect the complications is an important thing, and also we work in the team. So when we are prescribing an exercise in these patients, what all the important assessment you need to do and what type of exercise needs to be prescribed to these patients when they are recovering from the cardiac event. The first important thing is the evaluation of the patients in the recovery phase, monitored during the recovery phase, what all the exercise intolerance they have, and what important outcome measures can be used as part of the exercise-based rehabilitation. So the first important thing is that in the recovery phase, normally the patients will have two important changes in the early stage of the post-cardiac surgery event. The one is called the side effects associated with the cardiopulmonary bypass or the heart-lung mission. The second important thing is related to the systemic adaptations, the early systemic adaptations to the surgical procedure. When we say the cardiopulmonary bypass effect means the cardiovascular system itself, one of the common changes we observed is an arrhythmia, cardiac arrhythmia. Cardiac arrhythmia, even though the structure is reconstructed with the graft, because of the longer duration of the CPB or the cardiopulmonary bypass mission, there is a chances of developing an arrhythmia. This is important, needs to be detected before we start any type of exercise in the recovery phase. The second important thing is the respiratory system. Normally, post-cardiac surgery, we usually look for the bypass time. The bypass time, suppose if it is more than 90 minutes, most of the CPB effects will be very persistent. You can expect some of the complications in the early recovery phase. The respiratory system, the most common challenge is an hypoxemia, or even the patients can go with the pulmonary edema. Musculoskeletal system, usually the patients will have a severe fatigue. The chances of accumulations of the lactate because of the blood or the heart-lung mission can't able to purify the good blood supplies to the musculoskeletal system, thereby the fatigue, the pain, or usually the myalgia. This is the most common changes. Neurologically, the patients may also have some amount of disorientations in the early stage. The first important thing, you can detect any of the respiratory associated problems like 2 or 3 important changes needs to be identified in the X-ray. whether the basilar region is the radiolucent or whether it is a radio-opaque. Opaque means if there is a haziness, that's a warning sign of the edema, pulmonary edema, so that when there is a pulmonary edema, it is important for us to rectify that first before we start mobilizing the patient. Normally, this is we divide into the different level as a part of the exercise rehabilitation. The first 2 days we focus on the coronary care unit stabilizations. You may focus mainly on the simple bed activity. Normally by second day or even early, if the patient don't have any complications, by 24 hours we start mobilizing the patient, and monitored ambulations will go up to the 5 days. On 5th day, usually we perform the low-level exercise testing or the 6 minutes walk test to understand the functional capacity of the patient, and then we start prescribing the exercise. Look for these complications, and your purpose of your intervention is to prevent these complications like the long-term bedridden effect, improve the mobility, prevent the respiratory and circulatory complication, access the hemodynamic response to the self-care. Also rule out for the various complications before you start mobilizing the patient. Most common thing, as I mentioned, is the look for any warning sign of heart failure or whether there is any uncontrolled arrhythmia. This is the most two complications will be life-threatening complications if you are not detecting early and treat them properly before we start rehabilitating the patients. Other problems like the orthopedic problems, basically when we start exercising the patient, osteoarthritis or any other associated problem can restrict the functional mobility. Therefore, you need to respect these problems before we treat the patients. So, the first important aspect is challenges in the phase 1 rehab is if there are any abnormal airway clearance. Focus on the various strategies to improve the airway clearance, like the focus on the good chest physiotherapy, focus on improving the mucociliary function, improve or stimulates the cough reflex, and also prevents the obstructions of the airway. And also the most important thing is the pain, post-operative pain is another reason for an abnormal cardiac or the changes in the heart rate, or normally we call it cardiac arrhythmia. The moment you reduce the pain, significantly we can able to reduce the development of the arrhythmia, either letting the patient sit, stand or ambulation. The mean arterial blood pressure reflects the tissue perfusion. So this is a very non-invasive technique where you will be able to assess whether the patient is having a good perfusions to all the vital structures or not. Normal range is 70 to 100 millimeter of mercury. Anything less than 60 millimeter of mercury is warning sign for that there is an inadequate tissue perfusion. The simple method of assessing the mean arterial blood pressure is you measure the diastolic blood pressure plus the 1/3 of the pulse pressure. So there are other formulas are also there for calculating the mean arterial blood pressure, but this is the one of the very simple and the valid clinical tool by which you will be able to know the tissue perfusion of the patient. Here, why I stress this point is, if the tissue perfusion is low, your exercise rehabilitation needs to be delayed. If there is a warning sign that less than 60, if you start mobilizing the patient, ambulating the patient, what happens is that you are increasing the demand. This is another common risk for developing the arrhythmia during the exercise time. The next important aspect is on the 4th or 5th day, we need to do the low-level exercise testing. Most commonly, we perform the 6 minutes walk test. This is 6 minutes walk test is one of the valid tests in the early recovery patients of all the various surgical procedures, not restricting only to the cardiac surgery. Even it is more appropriate in lung surgery, musculoskeletal surgery, joint replacement and other surgical procedures, which will be helpful in understanding the functional capacity of an individual. Every time when you start prescribing the exercise, even in the low intensity exercise, the 1 minute of pulse assessment is very, very important in the cardiac patient. The pulse assessment provides a lot of information of the cardiac dynamics, cardiac function as well as the cardiac structural changes. Never go for a 15 second of measurement and then multiply by 4 and say 1 minute pulse is this much. Always in the early recovery patient, measure the pulse for a 1 minute and look for 3 important changes. One is the rate. Rate reflects the atrial related changes or the atrial contraction. Then the next important thing is you look for the 3 fingers. Usually we use the 3-finger technique. The first one is related to the rate of the pulse rate. The second one is the rhythm. Rhythm reflects the left ventricular function. Then the next important thing is the strength of contraction or the volume of the contraction. This basically related to an ejection from each beat, how much blood is the left ventricle is pumping out of the aorta to the vital structure. Therefore, the 1 minute of pulse assessment is very, very useful to detect various cardiac changes in the early stage. This is look for the brady or the tachycardia. Never ignore this, because sometimes what happens is when the pulse pressure or the pulse rate drops less than 60, even with that sometimes we start mobilizing the patient. But this is a warning sign for the first degree heart block, so that anything less than the resting as well as the exercise pulse rate drops less than 65, you need to be very, very cautious. You need to provide rest to the patients or stop exercising the patient. Thereby you prevent the onset of the bradycardia or the first degree heart block. Then the next important thing is why exercise and the cardiovascular pump failure needs to be assessed. So this is basically when you are performing the exercise test, you look for the recovery of the patients following a 6 minutes walk test. The first minute recovery is very, very important in the cardiac patient. That reflects on the autonomic function of an individual. Therefore, suppose if there is the pulse rate of 20 have been increased from baseline to the post-exercise, when you are giving a 1 minute of recovery, at least there needs to be a 50% of the drop needs to be there. If there is a delay in the drop of the pulse rate or the respiratory rate or the blood pressure, that's a warning sign of cardiac or the autonomic dysfunctions in these patients. And the literature says that almost 15% of the patient in 1 year of time, they die following cardiac event or following the surgery, mainly because of the cardiac arrhythmia. Therefore, in the phase 1, even when you are doing a simple exercise, look for these arrhythmia changes as well as the autonomic changes that needs to be corrected during the next level of your rehabilitation. And also another important thing is auscultation of the basilar region. Suppose if you have a basilar creps, that's a warning sign for 2 things. One is patients can develop a pulmonary edema. That time you will have a basilar creps, or if the patient is having a congestive heart failure, then also we will have a basilar creps. How we can differentiate these two is, if there is a pulmonary edema, you will get only a basilar creps. Whereas if the patient is having a congestive heart failure, along with the basilar creps, you also need to look for the cardiac sound. There is a presence of S3. So look for these symptoms and the signs. As I said, the presence of S3 is a warning sign for the congestive heart failure. The next important aspect is evaluation of the intolerance to the exercise. A simple 6 minutes walk test. Look for all these parameters. How much is the distance covered by an individual? What is the baseline during the exercise? Immediate recovery, heart rate, blood pressure, as well as the rate pressure product. That is an important tool to know the myocardial oxygen consumptions following the recovery. Look for a systolic blood pressure into the heart rate. That reflects the rate pressure product of an individual. And also rule out arrhythmia, ischemia, cardiovascular pump failure, or the dysfunction. So all of us are familiar with the standard practice of the 6 minutes walk test. This all the parameter needs to be measured when we are performing the 6 minutes walk distance. The most important thing is the distance covered by the individual reflects the functional capacity as well as the long-term outcome of an individual. Ideally, post or before the discharge, the patient needs to achieve at least the 65% of the age predicted distance. If there is a less than 65% of the age predicted distance, these patients are prone for developing the either related to the cardiovascular dysfunction related complications in the next 6 months to 1 year. Therefore, an aggressive rehabilitation is required to prevent the complications associated with the cardiovascular dysfunction. So based on this, the good prognosis depends upon the patient will have a New York Heart Association dyspnea scale of 1 or 2. Exercise capacity needs to be more than 6 meds. No evidence of heart failure, free of angina or the ischemia at rest and with exercise, appropriate increase in the BP. These all the things needs to be assessed before, during and after your exercise every day in the phase 1 rehabilitation. If you can able to get these good outcomes as part of your exercise rehabilitation or the exercise based rehabilitation, then the long-term recovery of the patients will be very, very good. So this is the standard recommendations for maintaining the intensity as well as the rating of perceived exertion. And also, as per the recommendation, a simple method is keep a resting heart rate plus 10 to 30 beats per minute during the exercise, and the box scale should be less than 13. There should not be any ECG or the hemodynamically any complications associated with that. By discharge, educate about the inappropriate exercise. That's very, very important, because if they have a median sternotomy, most of the time they do the unilateral activity that itself will increases the risk of the sternal dehiscence or the breaking of the sternal sternotomy incision. Provide safe, progressive exercise program. Thank you all.
Thank you, Dr. Arun. That was a very well presented, even though if it's just 20 minutes, very well presented topic on exercise as a medicine in CABG patients. You have covered on both why medicine or exercise has become a medicine and how it helps in overcoming, not just in post-operative CABG patient, but also in so many other conditions. And we also mentioned the indications for exercise in various these things. And all the 4 phases of cardio rehabilitation after the surgery. Then the importance of coronary artery bypass grafting, both venous as well as arterial. And initial and recent concepts compared to the early days and now present concepts. And also the evaluation, the most important thing, the evaluation, both initial evaluation, cardiac arrhythmias and about respiratory system, that was also very good. And the protocol, more importantly the protocol, you have given it in a very brief but very efficient way. And the post-operative goals, what should be the post-operative goals, and what are the contraindications, that was also mentioned, but very useful. And most importantly, airway clearance, why it is important, and the importance of low-level exercise testing, that is a 6-minute walking distance test, and assessment of patient during, before and after the exercise session, and the importance of the first minute recovery, and the importance of the basilar creps. Moreover, you have also talked about all the rest of the areas, even though normally I think you might need around 5 or 6 hours to complete this topic. So doing it in 20 minutes so beautifully. Thank you so much. That was very, very helpful. Thank you, Dr. Arun.
Thank you, sir. I request the chairperson to present a token of appreciation to our speaker. I request Dr. David Arun Kumar, Principal, Hillside College of Physiotherapy, Bangalore, to present the token of appreciation to the chairperson and the moderator. A kind attention here. I request the delegates not to crowd at the center of the hall. Please settle down. The quiz prelim will be held at the food court diner, ground floor at 3 p.m. today. All the participants may please note this and be present at the venue at 2:45 p.m. and meet Dr. Sydney Ribello, who is the quiz master for the day. The concurrent sessions are happening at the ground floor, so I request the delegates to also attend those sessions and gain valuable updates. Our next topic is manual therapy. Learn the techniques that always work. I call upon the chairperson, Dr. Karvanan, Associate Professor, Mahe, Bangalore campus, and the moderator for the session, Dr. G. Balaji, Professor and Principal, Nargun College of Physiotherapy. It is my pleasure to welcome Dr. Deepak Capri, Director and Senior Consultant Manual Physical Therapist at Capri Institute of Manual Therapy, Delhi, to take over the stage and present his topic.
Can you remove this one?
Dr. Deepak Kumar. He has qualified his Masters in Sports Physiotherapy and Doctorate in Manual Therapy. He is a recipient of fellowship by IAP in the year 2010. He is certified McConnell concept teacher. He is a teacher, author, researcher, clinician, and entrepreneur running chain of physiotherapy clinics in Delhi. He has delivered more than 260 workshops and trained more than 15,000 physios from India and other 52 countries.
Thank you very much. Thanks, really appreciate. Very good morning to you all and respected chairperson and dignitaries on the dais, off the dais. Very good morning. I can see many familiar faces and many friends sitting here. Very good morning. The time frame given to me is 1 hour and this is going to be a live demonstration. So if you people pay attention, I'm going to teach you few practical techniques which you can apply on your patients, manual therapy techniques, and it's not a promise, it's a guarantee. If you apply on those patients, those who need these techniques, they will recover instantly. And we often say pain and your range of motion recovered instantly, that too in a pain-free way. Comfort and capabilities restored instantly, that too in a pain-free way. So my first thing is, why do you need manual therapy? Why there is a need for manual therapy? There are so many gadgets and equipments through which you can treat the pain. But remember, pain is your friend, not your enemy. It tells you there is something wrong with the body. It is the alarm system of our body. And if pain is coming, means there is something wrong. With medicine, with electrotherapy, you can mask the pain for the time being, but you cannot remove it. It will come back once the effect of the electrotherapy or the medicine goes away. So you have to find the cause behind that pain and do something about it. So, for example, if there is a leakage under the wash basin, what will you do? Will you keep mopping that, or you'll call the plumber and get it fixed? Of course, you'll call the plumber and get it fixed. Otherwise, it will keep coming. So you are finding the cause behind the problem using the manual therapy and fixing that cause so that the results are long lasting. You get instant result and they are going to be long lasting. And this is what the patient in today's era want. They don't want to visit physiotherapy clinic again and again for 2 weeks or 3 weeks time. They just want to come once or twice and that should be over. So with the help of manual therapy, you're finding the pathomechanics behind that pain. You're finding the positional fault behind that pain and then fixing it. Next one, you get very fast pain relief. Like in order to stimulate the pain gate mechanism, you need to give TENS or vibration or hot pack minimum for 18 minutes. Then only the pain gate mechanism gets stimulated. But with the help of manual therapy, just 2 minutes are more than enough. Because there is an intense stimulation to the mechanoceptors and the proprioceptors in and around the joint. So you are giving very, very intense stimulation. So that is the pain gate mechanism, and I call it expressway theory because it's going really very fast and you're getting very, very fast result. And I say it's a time-saving, cost-effective techniques. Another physiological effect of manual therapy is increasing the joint range of motion. We know every joint has certain amount of joint play, and this joint play is directly proportional to the range of motion available in your joint. Look at the shoulder joint, it has a very good amount of joint play and it moves in all the directions. But if you look at the sacroiliac joint, very little amount of joint play and you hardly get nutation, counter nutation, a little bit of upslip and downslip or anterior posterior tilt. Hardly 4 degrees of movement you get in sacroiliac joint. So that means it is the joint play which play a very, very major important role in our range of motion. And whenever our patient get immobilized, they get operated, they get rest, or they get traumatized, it is the rest, and because of the rest, it is the joint play which is being lost. So we need to restore the joint play as a first thing. Once you have the joint play, hence you have the range of motion, and then obviously you will need to do strengthening exercise, mobility exercise, and coordination. Everything comes because you have the joint range of motion. If joint range of motion is not there, no matter what you do is useless. So first thing is to have joint range of motion after any medical condition which we physiotherapy, and it is the joint play. Once you restore the joint play, you restore the joint range of motion. And because you are giving the passive accessory movement, it helps in getting the nutrition to the joint. Because when we do the passive accessory movement, there is a movement of the synovial fold and the synovial fluid. We know the cartilage do not have the blood supply. So even if you do the electrotherapy, the cartilage won't get nutrition because there is no blood supply to the cartilage. And you need to restore that nutrition to the cartilage. Otherwise, how will it recover? How the joint will recover? It needs nutrition all the time. So when you do the passive accessory movement and helps in moving the synovial fold and the synovial fluid, the joint get nutrition. So it helps in correcting the positional fault and the pathobiomechanics and give the faster pain relief, cost-effective, time-saving, helps in increasing the joint range of motion by restoring the joint play, and helps in giving the nutrition to the joint. Because you people, I understand there are many students sitting here. Just take this message and your conference is successful. If you are able to understand, this will change your career, what I am saying next line. Remember, medicine can change physiology, not physics. And you being physiotherapist, you are dealing with the physics of the body. Remember, there is no substitute to what you people are doing. No substitute. There is no medicine to improve the muscle power. There is no medicine to increase the range of motion. No medicine to correct the posture. No medicine to correct the gait of the patient. No medicine to correct the incoordination, improve the incoordination. It is you and you, the physiotherapist. You are the one who is responsible for all those things. There is absolutely no substitute to what you people are doing. So feel proud being physio. Congratulations, you are a physiotherapist now. Feel proud. I wish you all the best on this World Physiotherapy Day. So let me start my presentation. Manipulation versus mobilization. Very often when we talk to the referring consultant or to our seniors and we say we are going to mobilize, and they understand we are going to manipulate. There is a huge difference between manipulation and the mobilization. And there is a huge difference between the manipulation we physio do and the orthopedician do. And they get afraid, oh my God, no, don't do manipulation. Excuse me, our manipulations are very, very different. Okay? We don't anesthetize our patient. It's just correcting the positional fault, nothing more than that. And in fact, in this lecture, I'm going to show you the mobilization, because 95% patient will respond beautifully to the mobilization technique. Hardly 5% patient need the manipulation. However, the indication, contraindication, limitations, all are same. But then what is the definition? It's taken from Dina Gardner only, so I'm sure you all must be very much aware. Manipulation is a single controlled unidirectional small amplitude high velocity thrust technique given beyond physiological range but within anatomical range. So yellow one, the yellow range is your active range of motion. Everyone, can you extend your fingers? Everyone, extend your fingers. Can you take it furthermore without touching it? You can't. That's the yellow band. Okay, now push it gently, that's the red band, and if you push a little more, that's the green band. So you have to manipulate in the green band, beyond physiological range but within anatomical range. So what will be the mobilization in that case? Mobilization will be multiple yet controlled, okay, don't say uncontrolled, multiple controlled bidirectional. Small to large amplitude, depending which grade you are doing, initial range, mid-range or end range. Rhythmic oscillation given within physiological range. So mobilization is a multiple, controlled, bidirectional, small amplitude, rhythmic oscillation given within physiological range. So what are the precautions? These are the precautions, red flags and the yellow flags. I'm not going to discuss them in much greater detail because purpose is to demonstrate as many techniques as possible. I'm sure if you want, you can take the photograph of this slide and you can read it later on. So make sure osteopenia, pregnancy, hypermobility, you are extra careful while doing the manual therapy. For bone weakness like tumor, osteoporosis, metabolic bone disease, absolutely red flag. Don't try to do manual therapy on those patients. Then if the person is having vascular problem, like if he is on anticoagulant therapy or suffering from aortic aneurysm or having multi-level of PIVD or cervical myelopathy or having psychological problem, don't do it, because there is a chance person may attempt suicidal attempt. And then you will be one who will be in the soup. So what are the indications? I say if it is not contraindicated, it is indicated. Try it. Any neuromuscular skeletal pain which is mechanical in nature, not pathological, but which is mechanical in nature, you must try it. Any neuromuscular skeletal pain, if not contraindicated, it is indicated.
Thank you, sir. A very good morning to everybody gathered here. We have with us our Honorable Vice Chancellor, Dr. M.K. Ramesh, Rajiv Gandhi University of Health Sciences today. A hearty welcome to you, sir. We will continue the session for another half an hour and we'll have a break for the inaugural ceremony. Thank you.
Thank you very much, sir, for coming. Now I feel more privileged that I'm able to do presentation in front of you. Okay, so what are the other indications for manual therapy? You can reverse the hypomobility. You can reverse it. Post-traumatic stiffness, frozen shoulder. Okay, then you can maintain the mobility. Like you cannot reverse it, but you can maintain it. Osteoarthritis, spondylitic changes, so you can maintain. And sometimes you can't even maintain, you can delay the deterioration. What would be the example for that? Anyone? Ankylosing spondylitis, rheumatoid arthritis. You can delay the deterioration with the help of manual therapy. Of course, for that, you have to examine your patient globally as well as locally. There could be a reason, the problem in the thoracic spine, and you are not able to move the shoulder at all. Very often, physios do come across with this. If both of them are having back pain at L1, L2, what do you think, who is hypomobile and who is hypermobile? If they both have pain at L1 and L1, both are having L1 pain, what do you think, who is hyper, who is hypo? Anyone can answer, or you all can answer. This gentleman is, and she is absolutely wrong. Where is the pain? Pain is at L1 area. Look at L1. It is as flat as she is having. So I'll put both as hypomobile. Don't allow your patient to trick. Okay? You should be able to do the local examination as well as global examination. Then only you will reach the correct diagnosis. Otherwise, majority of the time, you will call it a psychological case. The problem is not with the patient actually. Actually, we are not able to assess patient correctly. We are not able to find the source of pain or the cause behind pain. And we are calling patient as having psychological pain because he is not responding to your treatment. If the patient is not responding to your treatment, there could be only two causes. One is your assessment is wrong. Second is your treatment is wrong. So you have to check, recheck, talk to your seniors. Maybe something you are missing. Okay? Take the help of your seniors. Re-examine your patient. Maybe the pain is coming from different joint, and that's why patient is not responding to you. So make sure you examine your patient globally as well as locally. And before going ahead with the demonstration, live demonstration of various techniques, which will help you a lot in your practice, let me tell you 8 principles of manual therapy we always follow. Earlier we used to treat patient in weight bearing. Now we have done a research where we say the weight bearing doesn't help, your glide will be lost. So now we treat patient in non-weight bearing, and results are much better, much faster as compared to weight bearing. Second principle is passive movement followed by passive pressure. Earlier we used to teach active movement followed by passive pressure. Now it is passive movement followed by passive pressure, because in the same research we realized it is the compressive forces given by the muscle which do not allow your glide to get sustained. Your glide is lost moment the patient start moving actively, because the muscle contraction is there and it gives the compressive forces on the joint surfaces. Your glide is lost. So now we follow passive movement followed by passive pressure. Third one is, when indicated, they are painless. If it is painful, make sure you find the correct treatment plane, angle, direction, pressure, force. And if angle, direction, pressure, force is right, your patient will have instant pain relief then and there. And if patient is saying 10-20% pain relief, sorry, that's a psychological one. Still you need to work on your glide. Instantly patient will save more than 50% pain relief, single sitting within 2 minutes. That's what the manual therapy is. So what was the first principle? Can you speak out? What was the first one? Non-weight bearing. Second one, loud and clear please. Second one is passive movement followed by passive pressure. Third one is, when indicated, they are painless. And the fourth one is given in available and range. Of course, you have to do in available and range. If you're not in available and range, you're wasting your time. and then it is sustained, depending which concept you are following. You are following the Maitland, Cardamom, or Mulligan. One thing will be sustained. For example, if patient is moving arm and your glide is sustained, you call it Mulligan concept. But if patient is fixed in available hand range and you do passive accessory movement, that becomes Cardamom and the Maitland concept. So one thing will be sustained and other will be moving. Don't get confused which concept you are following. You follow the biomechanics, you follow the physiology of the joint, you follow the anatomy, you follow the rational and the common sense. Don't follow any particular thing, because every concept has its own strength and weakness. You need to know things the way it is to be done based on physics of the joint. So one thing will be sustained for sure. Next one is, as I told you, it's going to be time saving. Hardly it takes 2 to 3 minutes time to treat the patient, and you can teach the self-treatment also to the patient. So when you write senior consultant physiotherapist, but actually you are working in the clinic on daily basis, working on the same patient on daily basis, that's not a consultation. That's more of a clinician, not a consultant one. You are doing the daily work. That's not called consultant. Consultant is when patient comes to you, you give the consultation, patient goes away. That is what the consultant is. Not if there is an architect consultant, he just tell you what to do. He doesn't lift the bricks and put it daily on your building. Then he's not a consultant. So when you want to work like a consultant, make sure you teach the self-treatment to the patient, and patient continue his treatment by himself, and then follow the treatment plane rule. What is the treatment plane? It's a straight line joining two ends of the concave surface, and if the concave surface moves, the treatment plane moves. So different joints have different treatment planes, and we are going to give glide in that direction. So if you have the good knowledge of anatomy, manual therapy should become a cakewalk for you. It's just the simple anatomy and the biomechanics, no hi-fi things. So different joints have different treatment planes. These blue lines are the treatment planes, and you have to give glide most probably in that direction, maybe slightly up or down or left or right, because everyone has a anatomical variation. So you have to push it in that direction. Like in the knee joint, you can do medial lateral as well as anterior posterior, and for the sacroiliac joint, you can do posterior medial. When you want to mobilize the C1, C2, you push towards the jaw, but if you're working on the lower cervical, then you push towards the eyeball. Next question comes, how much pressure are we going to give? Is that the pressure? No, of course not. Of course not. The problem comes, the youngster keep pulling or pushing till they feel the glide. And you know when they feel the glide? When it is about to get subluxated. Okay? So don't push it. Talk to the patient how he's feeling and stick to that. If patient is feeling better, that's the pressure you're going to apply, so that you don't end up into this situation, but in this situation. Now I'm starting the practical demonstration of various techniques. In case anyone has back pain or sacroiliitis or knee joint pain or shoulder pain, I'll prefer them to come as a model, and I can help you. I can demonstrate the efficacy. In case you know everyone is fit in this class, we have a model, so I'll demonstrate it on the model. And there are more than 300 techniques. Now I have exactly 40 minutes left with me, and I'll try to cover as many techniques as possible. The first technique is bent leg raise technique. Indication for this technique is if someone is having sciatica or reduced SLR, then you perform this technique. And don't worry, I know many of you will not be able to see what Dr. Tanmay is doing. So I'm going to show the same video, pre-recorded video from our online course on the screen. So you'll be able to see what Dr. Tanmay is doing. So this is called bent leg raise technique. Indication is sciatica or tight hamstring. And with this technique, in 2 minutes time, SLR goes from 20 degree to 90 degree. Anyone having sciatica or tight hamstring who want to be the model? Please come. You want to come? Please move fast so we can demonstrate more techniques. Can you keep the model here? Yeah. Please come.
Dr. Tanmay Kumar, he is a postgraduate physio currently pursuing his doctorate in physiotherapy from Montana University, America. He is very promising and dedicated physiotherapist working in HOD and consultant physiotherapist at Capri Institute of Manual Therapy.
So see the difference. We'll measure the SLR before and after the technique. So that's the SLR he is having. Okay. We should measure it with the measuring tape, which we don't have. So I'm starting the technique there and Tanmay is performing here. Volume please. Excuse me. The sound.
Hand down. Push my hand down and relax. Push it again.
Okay, starting again.
So you take the patient on edge of the bed and imagine this is the affected leg. That is the right side of the leg is the affected one. So in case patient is having too much reduced SLR, so I will do the hold relax technique in the initial range. Push my hand down. Push my hand down and relax. Push it again 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 and relax. And this is how you can come up to this range very comfortably. And then you are going to put the knee joint on your shoulder. Okay? And patient can hold the table there and one hand can be there. Now make sure knee must not get extended. Your shoulder shall be in the popliteal fossa, not under the calf. So you stay in the popliteal fossa and with both hands you are holding the lower end of the femur from the medial as well as the lateral side. And now I am giving the traction along the long axis of the femur and then going there. And constantly talk.
Arrow is the direction of the pull.
Imagine if the patient says, no, it is not fine, he is having pain, I'll ask him to push me back gently. Push me and relax. Push me and relax. Push me and relax. And still if that is not helping, I will go for abduction and external rotation of the hip.
So if the patient is complaining pain, I'll add abduction and external rotation to the hip to avoid the capsular pattern, still maintaining the traction and asking patient to do the hold relax. Of course, this technique will not be done on patient who have gone through total hip replacement or those who are having osteoporotic hip joint. Now see the difference. That was the SLR he was having. Okay. Now that's the SLR. No hot pack, no massage, no electrotherapy. And you get the pain result instantly, that too in the sciatic pain. Anyone having knee joint pain? Knee joint pain right now, anyone? We are doing it for free. We are not going to charge you anything. Anyone? Okay, so this is the technique. This is the model? Yeah. So next technique I'm going to show you is the IDK, internal dearrangement of the knee or osteoarthritis of the knee. No matter how severe the knee joint is, in case your any known to or parents are suffering from the knee joint pain, when you go in holidays, try this technique and your parents will bless you for sure. Anyway, they are blessing. So, but they will be really feel proud that you are the physio and you can help them for sure. No matter how severe the osteoarthritis is, patient will respond. Of course, when it is grade 3, it will be a temporary relief, but if it is mild to moderate, it's going to be long-lasting result. So what we are going to do is, the one therapist or the patient himself will stabilize the thigh, and the therapist will give traction. And along with traction, therapist is also going to rotate internally. Majority of the time it is the internal rotation which is going to work, and sometime it doesn't work, do the external rotation. We have a formula in manual therapy: if verse reverse. What is the formula? If verse, everyone, if verse reverse. Remember that. You have done something, increase the pain, okay, reverse it, pain will get settled down for sure. So one therapist stabilize it, and then another Again, the long axis of the tibia and fibula, that increase the joint space, and then do the internal rotation, and then go for flexion. Make sure you're doing the flexion first, not the extension. Okay, because you're opening the joint space. So when you do the flexion, range of motion will increase, IDK gets settled down. This is the technique I used to do in the beginning of my career, and all the patients responded so beautifully, so beautifully. No matter how bad the knee joint pain is, whether it is your cartilage injury or ACL, PCL, MCL, LCL, patellofemoral pain, no problem. This technique gives instant pain relief, instant pain relief. Or once you gain the flexion, you can work for the extension also. Anyone has shoulder pain right now? Anyone? We can show you the result. You have shoulder pain, please come. Let's see. Move fast, please, so we can show more techniques. Where is the pain? What gives you pain?
Extension.
Can you lift it up? It is painful?
Yeah,
how much pain?
Out of 7.
Okay,
6%.
please. Come there. So let's ask how much pain he's having right now. So what gives you, which, that shoulder? Wait, sit on that side, please. So what gives you pain? Can you show them?
When I extend, so it gives me pain.
Show the range.
This is a range.
This is painful?
Yeah, this is painful.
Can you pull it more?
No, it's painful.
Very painful.
It's very painful.
Okay. So let's see how much we can help him. So, do we have a chair? Okay. Any chair we have?
Sorry to interrupt, sir. There's an announcement to make. I request the participants, whoever have parked the cars at the registration area, to kindly clear from there, as the governor will be arriving shortly. Thank you.
So one person is going to stabilize the scapula, and actually it is one therapist technique. So in video you will see only one therapist technique. So I'll play the video. Meanwhile, we'll treat him. You can see the arrows, and you can see how the second person is doing. Now we don't ask person to do it actively. We ask person to do passively. No matter what is the cause of shoulder pain, patient responds. So I'm taking his help in stabilizing the scapula because I want to give a little stronger glide, and then I'm giving posterior lateral glide to the head of the humerus and maintaining that, and Dr. Tanmay is doing passively, moving shoulder passively, and let's see how he's responding. Okay, is that comfortable to you? So he's fine. If he's fine, that means that's an indication that we can continue. If he was having pain, we should have changed our pressure or the direction or the angle. Okay, let's do for flexion because funding movement was the flexion giving him pain. He is comfortable, so we are continuing. I am sustaining the posterior lateral glide as you see in the video. Okay, just relax now. So let me ask, can you lift it up again? Wow. How's the pain?
4/10. It has reduced.
How much it reduced? If when you came it was 7. So say, imagine if it was 100 when you came here. So how much percentage?
Almost.
Lift it again and check it.
Yeah, almost like 90%.
90%?
Yeah.
Gone or still there?
No, gone.
90% pain gone, only 10% is there. This is the kind of result you get in physio clinic. You need not ask patient and other people to call you doctor or non-doctor. They will call you doctor for sure. You are automatically being called doctor. You need not ask patients. They will call you doctor. Next technique, anyone having back pain?
Sir, last 10 minutes, sir.
Last?
10 minutes.
Sir, they gave me 60 minutes. Will close. Okay, no problem. Anyone having back pain or sacroiliitis? No problem. We'll show you the technique. Please. Is there? Please come. Fast. Move fast, 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 so we can show more techniques. Where is the pain? What gives you pain?
Normal while sitting for long.
Right now you have pain? So ask him how much is the pain right now. 7. Okay, do it. I am showing you the technique now. So, you put the patient in the quadruped position, and wherever he is having pain, you are going to give glide at that particular segment, and then ask patient to go back. In my experience, majority of the time, it is the flexion which is giving problem. And it is the extension which aggravate pain. So in Capri Spine Clinic, we don't teach extension exercise at all. And my patients are happy about it. It is the flexion, which is the functional activity, which is a functional movement, which is being restricted all the time. And we help in opening the flexion range of motion. And he also said, when he sit, he gets pain. So I'm going to open his flexion with the help of snag, that too in the weight bearing, non-weight bearing position. I'm giving snag to him. And then please ask, how is the pain now? Just do the movement. Sitting was giving you pain. Sit down and check.
It's better, he can feel it.
Sit down and check it. How much better? How much better?
4.
Out of what?
100. 40%.
Now you are?
40. In 100.
40% better or worse?
No, 40% better.
40% better. Just 1 minute time. And next one is the sacroiliitis. If person is having sacroiliac pain, now we will not call model, we have less time. Initially, I think we are running behind the schedule. Initially, time given was 1 hour. Now we need to cut down. So the sacroiliitis. This is how you treat the sacroiliitis. Beautiful technique. All the time it works. 99% cases it works. So again, patient in the quadruped position, and you give this glide, posterior medial glide to the sacroiliac joint. So stabilize the sacrum with one hand. Stabilize the sacrum with one hand, and with another hand you are doing the posterior medial glide. And then ask patient to go down and up. By correcting the positional fault at sacroiliac joint, you correct the sacroiliitis, and patient will have instant pain relief. Majority of the time, pain is not coming from L5S1. However, literature says L5S1. I disagree with that. Majority of the time, pain is coming from the sacroiliac joint, and patient respond beautifully. So whenever patient is saying pain in the gluteal area, or if the 14-finger test is positive, do this technique and help your patient instantly then and there. Now, last techniques, I'll show you the traction techniques. This will help you in saving 72,50,000 rupees. That's the cost of decompression machine. So if you learn this technique, you will save 72,50,000. You need not buy that decompression machine or the traction machines. You get beautiful results with the help of this seat belt or the treatment belt, which is easily available anywhere in the market. So I give the segmental traction, place it there, and put the belt on your shoulder. Adjust the appropriate height. Put the belt in such a way that your fingers are inside the belt. So you put the belt there and then put it under the cervical spine. Do the chin tuck. And then take the hip back. Don't take your chest back. If you take the chest back, that will be compression over the facet joint. That will give more pain to the patient. So don't take the chest back. Draw your hip backward. And that is a beautiful traction you will have for the cervical spine. That's the angle of the glide. And along with that, you can do the passive accessory movement also along with traction. You can do the swings and you can do flexion extension while maintaining the traction without straining your back. And you get a beautiful result no matter what is the condition, no matter what is the diagnosis for the sacroiliac joint. But remember, we treat pathomechanical pain, not pathophysiological pain. They are the contraindication, they are red flags. Okay, so if it is a pathomechanical, you do like that and you get the result. Next one is the thoracic traction. So you put the belt at the segment you want to apply traction, like this. And then preparation is same. You just simply put the belt there and ask patient to wrap around your back so that scapula does not come in your way. Put the belt. And again, draw your hip backward. Very simple, same way. Draw your hip backward and you're done. Very effective technique. Just a small belt, you can keep it in your pocket, go work for the home visit. You need not carry the traction machines with you and deliver amazing result. Same way you can do the lumbar one. But in the lumbar one, earlier we were pulling the upper vertebra up. Now we are going to pull the lower vertebra down. Okay? Again, no suffocation, no belt, you are not tying patient. Okay? And hardly 1 or 2 minutes of traction. When you're using the traction machines, you're doing for 10 minutes, 20 minutes. This one is only for 2 minutes and you get the better result. So again, you put the belt. This time you have to increase the length of the belt because you are a little far away from the patient. And then put it at the segment below. You want to give the traction. Put your hands on the knee joint of the patient. Again, draw your hip backward. You draw your hip backward. And again, you get a beautiful result. Very nice result you get. And the next technique I'm going to show you to treat the fixed flexion deformity. You will receive many patients coming with the knee joint pain, and because they are not able to extend the knee completely, the patellar malpositioning is there. Patella is rubbing and hence irritating the fat pad of the patient. And no matter what manual therapy or what treatment you do, patient won't respond till you open the full extension. So this is the technique which will help you in opening the end range extension of the knee joint or treating the FFD, okay, fixed flexion deformity. So you're going to put the foot of the patient on a block there and then put the belt on your shoulder just below the joint line. And make sure the angle is correct and then you push it down. If this is the range of motion, make sure your hand is not on fat pad. That will give pain. Keep it away from the fat pad. So this is stabilizing, this is getting mobilized, and you sustain that anterior glide to the tibia and fibula, and you get beautiful magical result. Very nice result. I doubt anyone having fixed flexion deformity in this hall. Usually you get it after the mid-age or in the old age. And now I'm showing you the last technique, just 5 more minutes. Tennis elbow. Very common condition. You might be coming across. Almost the technique is same. Can you do it on that side so people can see? Okay, anyway, they are seeing it on the screen. So you keep the humerus internally rotated, so that when you're lifting it up, that's the lateral glide. If it is not internally rotated, that becomes anterior glide. So I'm doing the rotation to the head of the humerus. Okay. So internally rotate, the humerus, so that medial epicondyle touching the ground or the plinth, and the lateral epicondyle facing the ceiling. Then you put the belt. I could have shown more techniques. Thank you very much. Come through, Chairman Sir, and if there is anything, I would be happy to answer.
Yeah, it's a good presentation, sir. Very nice inputs. And you had shown the practical demonstration, which was very useful for the students, clinicians, everyone. Again, I thank Deepak sir and Tanmay for sharing their wonderful talk and inputs. Thank you, sir.
Thank you very much. Thank you. Hope it was useful. And when you apply these techniques on the patient, you will get beautiful results and you will remember this conference for sure. Thank you very much. God bless you. And once again, happy World Physiotherapy Day. Thank you very much.
Thank you, sir, for enlightening us with the techniques. That was indeed magical. Physiotherapists are indeed having healing hands. I request the chairperson of the session to present a token of appreciation to our speaker. I request Dr. Rajendra Kachwa, Principal, Narayana Hrudayalaya College of Physiotherapy, to hand over the token of appreciation to our chairperson and the moderator. Thank you. We'll be having the inauguration in a short time. I request everybody to please be seated and maintain silence. A reminder about the quiz prelims, which will be held today at 3 p.m. I request all the participants to assemble at the diner ground floor at 2:45 p.m. and meet Dr. Sidney Ribello.
I request everyone to kindly rise as we have with us our Minister for Medical Education, Dr. Sharan Prakash Patil, sir. A very warm welcome to you, sir. Honorable Governor of Karnataka will be arriving shortly, and then we will be beginning with the inaugural ceremony. We also have with us another personality, Srimati D.A. Kalpaja. We welcome you, ma'am, to this gathering. हाँ सर, हाँ, ओके ओके. All the delegates are requested to maintain the decorum until the inaugural ceremony is completed. I request all the delegates to please maintain silence. The delegates are not allowed to move out of the hall. Kindly be seated and cooperate with us. I request all of you all to kindly rise. A round of applause to our Honorable Governor of Karnataka and the Speaker of the Karnataka Legislative Assembly. I request everyone to kindly rise for the national anthem.
Bye.
It is now time to witness the most awaited inaugural ceremony of Mangalore Physicon-2023, an international physiotherapy conference organized by South Canara Physiotherapy Teachers Association. This 2 days conference is a juncture of international and national speakers who have come from India and abroad just to widen our horizons in the field of physiotherapy. We all have gathered here today to share knowledge, to learn, to connect, and to expertise with fellow physios. It is definitely going to be a great informative session for the delegates attending the conference. This year's theme being Connect to Unlock the Potential of Physiotherapy gives us a clear picture of the extent of the wings of physiotherapy. The way our profession has grown and conquered many aspects of life truly defines our path of progress. We have marked ourselves in all the health systems, and our role is to strengthen life from birth till death. Mangalore Physicon 2023 is planned with this enthusiasm, and the crowd gathered here today is an ample proof of the solidarity of the physio fraternity. Undoubtedly, today we are witnessing a large gathering of professionals who have come here and made this conference a memorable one. Namaste and good noon. On this 8th day of September 2023, I, Professor Vaishali, convener of Mangalore Physicon 2023, take the privilege to stand before you all and host the inaugural ceremony of Mangalore Physicon 2023 on behalf of the organizing chairman, Dr. UT Iftikhar Ali. This day is also marked in the calendar of every physiotherapist as we celebrate the World Physiotherapy Day. It is indeed a blessing and also an excellent platform for us today to represent this mega conference with Honorable Governor and respected ministers with us on the occasion of World Physiotherapy Day. Each new day is a blessing. It is a marvelous opportunity for us to meet and connect with many other physios around the globe. With gratitude to the Almighty, it becomes all the more important to unite God's divine purpose for this day. May I invite students of physiotherapy to invoke God's blessing in a spirit of serenity through a prayer. May I request all of you to please stand for the invocation.
Open the eyes of my heart, Lord. Open the eyes of my heart. I want to see you. I want to see you. Open the eyes of my heart, Lord. Open the eyes of my heart. I want to see you. I want to see you. To see you high and lifted up, shining in the light of glory. Pour out your power and love as we sing holy, holy, holy. To see you high and lifted up, shining in the light of glory. Pour out your power and love as we sing holy, holy, holy. Open the eyes of my heart, Lord. Open the eyes of my heart. I want to see you. I want to see you.
A smile is a welcomed sight that invites people in. Yet, to give a grand welcome to everyone assembled here and to introduce our honorable chief guest and the guests of honor, may I take the pleasure of requesting Dr. Mohammad Sohail, convener of Mangalore Physicon-2023, to welcome the gathering.
Thank you, Dr. Vishali. Namaste. A very good afternoon to everyone. A warm welcome to all present here. Coming together is a beginning. Keeping together is a progress. Working together is a success. Mangalore Physicon-2023 is an international physiotherapy conference, and the platform of this format is intellectual exchange, a dream that was realized in a just days. I, Dr. Mohammad Sohail, convener Mangalore Physicon, very happy to stand here before this august gathering to welcome our Honorable Governor of Karnataka and dignitaries on the dais, off the dais for today's conference, Mangalore Physicon 2023. आज के वर्ल्ड फिजियोथेरेपी डे के अवसर पर हमारे बीच में एक महान शख्सियत श्री तावर चंद गहलोत जी, जो हमारे राज्य कर्नाटक के गवर्नर हैं, उनकी एजुकेशन क्वालिफिकेशन बैचलर ऑफ आर्ट्स फ्रॉम विक्रम यूनिवर्सिटी उज्जैन मध्य प्रदेश से हुई है। उन्हें ऑनरी डिग्री डी लाइट डिग्री अवार्डेड 2016 बाय डॉक्टर B.R. अम्बेडकर यूनिवर्सिटी ऑफ सोशल साइंस अम्बेडकर नगर से मिली है मध्य प्रदेश में। सर का पॉलिटिकल कैरियर बहुत ही उत्कृष्ट रहा है। 1962 से 1977 तक सर भारतीय जनसंघ के मेंबर रह चुके हैं। 1977 और 1980 में सर जनता पार्टी मध्य प्रदेश के वाइस प्रेसिडेंट और जनरल सेक्रेटरी भी रह चुके हैं। 2006 एंड 2014 से सर भारतीय जनता पार्टी के नेशनल जनरल सेक्रेटरी रह चुके हैं। 1999 और 2004 एंड 2004 टू 2009 सर मेंबर ऑफ पार्लियामेंट लोकसभा भी रह चुके हैं। 1999 में विप बीजेपी पार्लियामेंट्री पार्टी इन लोकसभा भी रह चुके हैं सर। 2012 और 7 जुलाई 2021 से सर मेंबर राज्यसभा फ्रॉम मध्य प्रदेश 2 टर्म रह चुके हैं और अभी चल रहा है उनका टर्म। और उसके बाद सिंस 11 जुलाई 2021 से सर हमारे कर्नाटका के द ऑनरेबल गवर्नर हैं। हम फिजियो आज बहुत खुश नसीब हैं कि हमारे बीच में उपस्थित हैं श्री तावर चंद गहलोत जी। सर हम सब फिजियो आपका हमारी फिजियोथेरेपी कॉन्फ्रेंस में हार्दिक दिल से स्वागत करते हैं सर। मैं रिक्वेस्ट करूंगा डॉक्टर यूटी इफ्तिकार अली जी से, जो हमारे ऑर्गेनाइजिंग चेयरमैन हैं, वो आके सर का स्वागत करें फूलों से। सर धन्यवाद सर। To preside over the International Physiotherapy Conference, we have with us today Shri U.T. Kadar Farid ji, Speaker, Karnataka Legislative Assembly. On the behalf of Mangalore Physicon, we welcome you, sir. I request Dr. Abhilash, Organizing Secretary, to do the floral honor. Thank you, sir. I extend a warm welcome to Dr. Sharan Prakash R. Patil, sir, Minister for Medical Education, Skill Development, Entrepreneurship and Livelihood, Government of Karnataka. On the behalf of Mangalore Physicon, we welcome you, sir. I request Dr. Ajay, Organizing Secretary, to do the floor honor. Thank you, sir. It's my pleasure to welcome Dr. M.K. Ramesh, Vice Chancellor, Rajiv Gandhi University of Health Sciences, Bengaluru. We are so delighted to have you with us today. On the behalf of Mangalore Physicon-2023, we welcome you, sir. I request Dr. Sarath, Joint Secretary, to do the floral honor. Thank you, sir. I extend a warm welcome to our guest of honor, Dr. Sanjeev K. Jha, President, the Indian Association of Physiotherapists. On the behalf of Mangalore Physiocon, we welcome you, sir. I request Dr. Suresh Babu Reddy, Vice President, the Indian Association of Physiotherapists, to do the floral honor. Thank you, sir. I extend a warm welcome to our guest of honor, Dr. Ali Irani, Chairperson, International Affairs, the Indian Association of Physiotherapists and former physiotherapist Indian cricket team. On the behalf of Mangalore Physiocon, we welcome you, sir. I request Dr. Sai Shetty to do the floor honor. Last time. Thank you, sir. We have with us Excellency Achiever Awardee, Shrimati D.A. Kalpaja, Chairperson, Vaidevi Institute of Health Sciences and Research Center, Bangalore. On the behalf of Mangalore Physiocon, we welcome you, ma'am. I request Dr. Reshma to do the floor and honor. Thank you, ma'am. I welcome all the eminent speakers, management of physiotherapy colleges, principal, faculty member, media, organizing committee member of Mangalore Physicon 2023. I extremely delight to welcome all our delegates from different colleges from different part of this amazing country and abroad. और इस शुभ अवसर पर आप सभी को वर्ल्ड फिजियोथेरेपी डे की बधाई हो। Thank you. Jai Hind.
Thank you, Dr. Suhail. Hope is being able to see that there is light despite all the darkness. Let us now light the lamp of knowledge to dispel the darkness of ignorance. I request the Honorable Governor of Karnataka and the guest of honor, the President of today's inaugural ceremony, and all the dignitaries on the dais to please come forward and light the ceremonial diya. I also request the gathering to please rise. Thank you for this auspicious inauguration. A book of souvenir is a collection of goodwill of all our well-wishers. As a token of remembrance of this magnificent event, it gives us pride to release the souvenir of Mangalore Physicon-2023 on this auspicious platform. May I now request the Honorable Governor of Karnataka and the respectful dignitaries to release the souvenir of International Physiotherapy Conference, Mangalore Physicon 2023. Thank you, respectful dignitaries. Think like a wise man, but communicate in the language of the people, is the aura of our Minister for Medical Education, Shri Sharan Prakash Patil. To deliver the keynote address and to enlighten us more about the importance of conference, may I now request Sir to come and motivate us.
It's all right. It's all right. Good afternoon, everybody. ಎಲ್ರಿಗೂ ನಮಸ್ಕಾರ. ಇಂದಿನ not too quiet. It's fine. ಇಂದಿನ ಮ್ಯಾಂಗ್ಳೂರ್ ಫಿಸಿಯೋಕಾನ್ ಇಂಟರ್ನ್ಯಾಷನಲ್ ಕಾನ್ಫರೆನ್ಸಿನ ಉದ್ಘಾಟನೆಗೆ ಆಗಮಿಸಿರ್ತಕ್ಕಂಥ ಸನ್ಮಾನ್ಯ ತಾವರ್ ಚಂದ್ ಗೆಹ್ಲೋಟ್ ಜಿ ಅವರೇ ಮತ್ತು ಇಂದಿನ ಸಮಾರಂಭದ ಅಧ್ಯಕ್ಷತೆಯನ್ನು ವಹಿಸಿಕೊಂಡಿರ್ತಕ್ಕಂಥ ಮಾನ್ಯ ಸ್ಪೀಕರ್ ಕರ್ನಾಟಕ ಲೆಜಿಸ್ಲೇಟಿವ್ ಅಸೆಂಬ್ಲಿ UT ಖಾದರ್ ಜಿ ಅವರೇ, ವೇದಿಕೆ ಮೇಲೆ ಆಸೀನರಾಗಿರ್ತಕ್ಕಂಥ ರಾಜೀವ್ ಗಾಂಧಿ ವಿಶ್ವವಿದ್ಯಾಲಯದ ವೈಸ್ ಚಾನ್ಸಲರ್ ಆಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ MK ರಮೇಶ್ ಅವರೇ ಮತ್ತು ಫಾರ್ಮರ್ ಫಿಸಿಯೋ ಆಫ್ ಇಂಡಿಯನ್ ಕ್ರಿಕೆಟ್ ಟೀಮ್ ಡಾಕ್ಟರ್ ಅಲಿ ಇರಾನಿ ಅವರೇ, ಪ್ರೆಸಿಡೆಂಟ್ ಆಫ್ ಇಂಡಿಯನ್ ಅಸೋಸಿಯೇಷನ್ ಆಫ್ ಫಿಸಿಯೋಥೆರಪಿಸ್ಟ್ ಡಾಕ್ಟರ್ ಸಂಜೀವ್ ಜಾ ಅವರೇ, ಮತ್ತು ಇಂದಿನ ಭಾಳ ವಿಶೇಷವಾಗಿ ಎಕ್ಸಲೆನ್ಸಿ ಅಚೀವರ್ಸ್ ಅವಾರ್ಡ್ ವಿಜೇತರಾಗಿರ್ತಕ್ಕಂಥ ಶ್ರೀಮತಿ DA ಕಲ್ಪಜಾಜಿ ಅವರೇ ಮತ್ತು ಈ ಒಂದು ಸಮಾರಂಭದಲ್ಲಿ ಉಪಸ್ಥಿತಕ್ಕಂಥ ಎಲ್ಲ ಕಡೆಯಿಂದ ಆಗಮಿಸಿರ್ತಕ್ಕಂಥ ಆತ್ಮೀಯ ಡೆಲಿಗೇಟ್ಸ್, ladies and gentlemen, today on September 8th, we come together to celebrate World Physiotherapist Day, a day dedicated to honoring the tireless efforts and exceptional contributions of physiotherapists around the world. Physiotherapists are the unsung heroes of healthcare, working diligently to restore mobility, reduce pain, and improve the quality of life for countless individuals. They play a pivotal role in our healthcare system, from assisting in recovery of accident victims to helping patients managing chronic conditions. On this day, we acknowledge the invaluable work of physiotherapists in various settings, including hospitals, clinics, sports facilities, and even in comfort of patients' home. They are the guiding hands that help us gain our strength after injuries and surgeries. The educators who empower us to lead healthier lives and advocates for preventive care. The theme of this year's World Physiotherapist Day is Rehabilitation and Long COVID. This highlights the critical role the physiotherapists play in assisting individuals who are grappling with lingering effects of COVID-19. They provide essential support to help survivors regain their physical and respiratory function, helping them rebuild their lives. But let us not forget that physiotherapists are not just healers of bodies, they are champions of hope. They inspire us to push our limits, to overcome obstacles, and strive for our best possible selves. They remind us that recovery is possible, that pain can be managed, and that a fulfilling life can be regained. As we celebrate World Physiotherapist Day today, let us express our deep gratitude to these dedicated professionals. Let us recognize the difference they make in the lives of individuals and well-being of our communities. Let us commit to supporting and advocating for the continued growth and recognition of the physiotherapist profession. In conclusion, to all the physiotherapists out there, thank you for your unwavering dedication, compassion, and expertise. Your work transforms lives. And on this special day, we celebrate you and your vital role in healthcare. Happy World Physiotherapist Day. Thank you.
We thank you, sir, for sharing the light of your valuable thoughts and experiences with our aspiring delegates and also highlighting the physiotherapy profession. I'm sure everybody would remember and treasure your words on this special day. To pave our path and to encourage us to achieve greater heights in our profession, we have with us our guiding light and the main source of support, Dr. M.K. Ramesh, Vice Chancellor of Rajiv Gandhi University of Health Sciences. May I now request Dr. M.K. Ramesh to deliver a talk on this occasion.
Ellarigu namaskara. Honorable Governor of Karnataka and Chancellor of all the universities, Shri Thaawar Gehlot ji, Honorable Speaker of Karnataka Assembly and the President of today's function, Shri U.T. Khadar ji, our beloved Medical Education Minister and our Chancellor, that's the Chancellor of Rajiv Gandhi, Pro-Chancellor of Rajiv Gandhi Health Sciences, Dr. Sharan Prakash Patil ji, Shri Dr. Ali Hirani, Sanjay Jha, Shrimati Kalpa Jha ji, and other dignitaries, the students, and the renowned physiotherapists. This is the fourth continuous years I am here as a guest. And I must compliment the organizers, and especially Ifti, for organizing such a big function in the same grandeur and the same enthusiasm. So they require a big round of applause. I compliment them. This is an exciting time to be a physiotherapist. 2 years of COVID has taught us, has opened our eyes to the importance of physiotherapy in the medical practice. That's one thing. Another thing is the lifestyle changes. The sedentary lifestyle has leading to many conditions where the requirement of physiotherapist has become inevitable. So I must say, this is an exciting time to be a physiotherapist, and the coming days are the golden therapy. In fact, while sitting there, Dr. Ali Irani was telling, sir, you should open many fellowships in physiotherapy. Yes, it's true. Because the potential of physiotherapy has to be explored to the fullest extent. Tertiary care, yes, we have got good physiotherapy services. But where the lack is in primary care setup. If you look at the primary care setup, the most of the patients, in fact, I can say around more than 20% of the patients, they don't require a doctor's intervention. Most of them are musculoskeletal disorders, which can be handled by the physiotherapist. And in my view, each primary care setup should have a physiotherapist. And when we look at the Western setup, especially in the UK, there are certain courses. In the primary care setup, actually, they are trying to give certain injections. In fact, I was thinking of opening a fellowship, post-MPT fellowship, where they can be trained in intra-articular injections, 8 to 10 months course. So after that, most of these intra-articular injections, the physiotherapist can give. Not only that, in many soft tissue injuries, like shoulder injuries, intrafascial injections, or even steroid injections, most of these things can be done by the physiotherapist. That will lessen the burden on the doctor so that he can concentrate on surgeries. And one more thing, actually, it's called a non-medical prescribing, which is allowed in the UK, wherein the physiotherapists, certain NSAIDs, they can prescribe in their practice, which can easily alleviate the immediate pain of the patients. These things we should look into. And in the primary care, in every hospital now, the pain clinics are coming up. In the pain clinic, again, the spinal pain or spinal injuries, any of these things can be handled by the physiotherapist, so that the surgeons can concentrate on the surgery. In these things, actually, only 5% patients would require surgery, 95% would require only the rehabilitation. And more than that, according to World Health Organization, the universal health coverage, physiotherapy plays a main role because rehabilitation is the main component of the World Health coverage. Because I, as a surgeon, I do a surgery and I go back one day. But my concern will be to get the patient onto his feet at the earliest, so that the patient's pocket is not burdened, and also the economy of our country is not burdened. The main goal is to get the patient onto his work at the earliest. This is where the role of the physiotherapist is very, very important, and I believe such conferences would enhance the skills as well as the confidence of the physiotherapist to serve the society. And in this endeavor, I wish the organizers and the conference all the very best. Thank you. Thank you, Honorable.
Thank you, sir, for your thoughtful reflections on this notable occasion. I'm pretty sure that your words of wisdom have empowered all of us. On the dais, we have our own celebrity of physiotherapy profession, whose experiences have inspired many to choose this profession. May I now take the pleasure of inviting Dr. Ali Irani, Chairperson of IAP International Affairs, to share his ideologies with us.
Respected Governor of Karnataka, Shri Gehlot ji, Kadir Farid ji, Speaker Karnataka, Minister of Medical Health Karnataka, Shri Patil ji, Vice Chancellor Rajiv Gandhi University of Health Science, Shri Ramesh ji, IAP President Dr. Jha, and Madam Kalpaja. Very good morning. Sir, Governor ji, शुक्रिया कहना चाहूँगा आपको, आप पधारे. इस फिजियोथेरेपी कॉन्फ्रेंस में आज बड़ा दिन है हमारे लिए। वर्ल्ड फिजियोथेरेपी डे है। पूरी दुनिया में ये दिन को मनाया जाता है और इस दिन को हम जहाँ तक हो सके लोगों में, आज इंडिया में हर गांव में देखोगे कैंप चालू है। हम फिजियोथेरेपी का सेवा दे रहे हैं। फिजियोथेरेपी का सेवा इतना, उसका महत्व जब पता चला जबकि हम 2.5 साल 3 साल तक पेंडेमिक में फंसे हुए थे इस देश में, और हर पेशेंट जो हम देख रहे थे उसका लंग्स इन्वॉल्व था। और हम वो कौम है जो भागे नहीं, खड़े रहिए पेशेंट के साथ। काफ़ी लोग थे जो हॉस्पिटल में आना से डर लगता था, लेकिन दिन रात ये फिजियोथेरेपिस्ट था जो पेशेंट को बचाता था। हम कोशिश करते थे पेशेंट वेंटिलेटर में ना जाए, अगर गए तो उसको वेंटिलेटर से निकालें और वेंटिलेटर से निकालने के बाद खड़ा करके उसको घर भेजे, और उसके रिहेबिलिटेशन में हम खड़े थे उसके साथ। तो इस वो कौम है जो पूरी दुनिया में अगर कोई फिजियोथेरेपिस्ट की ज़रूरत है, वो लोग पहले इंडियन फिजियोथेरेपी को सिलेक्ट करते हैं। आज 8000 फिजियोथेरेपिस्ट खाली यूएसए और कनाडा में है, 2000 यूरोप में है, 2000 से ज़्यादा ऑस्ट्रेलिया में है। तो क्योंकि हमारा जो कोर्स है वो 4.5 साल का डिग्री कोर्स है, उसके बाद 2 साल और पढ़ते हैं। काफ़ी स्टूडेंट पीएचडी के लिए जाते हैं। जो इस देश का, जो इंडिया का जो फिजियोथेरेपिस्ट है वो पूरे दुनिया में माना जाता है। आज टॉप हॉस्पिटल में दुनिया में देखेंगे आप तो इंडियन फिजियोथेरेपिस्ट हेड ऑफ द डिपार्टमेंट है। आज मेरे लिए अच्छा मौका है कि हेल्थ मिनिस्टर और गवर्नर जी कर्नाटका के यहाँ है। हमारे हर स्टेट में एक काउंसिल है फिजियोथेरेपी का, कर्नाटका में अभी तक नहीं है। तो सर, आपके गुड बुक्स स्पीकर सर, कर्नाटका में फिजियोथेरेपी काउंसिल आना ज़रूरी है कि हमारे इस फील्ड को आगे बढ़ा सके। मैं फिर से सर, हम ट्रीटमेंट खाली नहीं देते, हम प्रिवेंशन भी करते, रोकते हैं। आज अगर आप पॉपुलेशन को देखने जाएंगे, सबको डायबिटीज़ है, सबको ब्लड प्रेशर है, सबको घुटने का प्रॉब्लम है, कमर का दर्द है, गर्दन का दर्द है। अगर इस फिजियोथेरेपिस्ट को छोड़ा जाए, गांव में पोस्ट बढ़ाया जाए, तो हम रोक सकते, इस रोगों को एक्सरसाइज बता के रोक सकते हैं। आज बच्चे जो स्कूल जाते हैं बैग लेके, 12% एवरेज बताता है, 12% लोग के कमर टेढ़ा हो गए वजन का बैग लेके। हर स्कूल में अगर एक फिजियोथेरेपी का पोस्ट आ जावे तो हम ये बच्चों को देख सकते हैं कि आगे चल के इन लोगों को प्रॉब्लम ना आए। तो एक फिजियोथेरेपिस्ट का रोल खाली ट्रीटमेंट करना नहीं है, काफ़ी रोगों को बचाना हमारा काम है। तो शुक्रिया, एक बार फिर से कहूँगा, आप हमारे बीच आए, हमें समझे, और मैं इंतज़ार करूँगा कि आप एक पायदान फिजियोथेरेपी को और आगे ले जाए। शुक्रिया, थैंक यू।
Thank you, sir, for your words which has fueled the whole gathering. Success is a journey, not a destination. With us, we have a man who abides this quote. To speak more about his ongoing journey, may I now request Dr. Sanjeev Jha, President of Indian Association of Physiotherapists, to come forward and share his thoughts.
Honorable His Excellency Sri Thaawar Gehlot, Honorable Sri UT Kadir sir, Honorable Dr. S.P. Patil sir, Health Education Minister, Dr. M.K. Ramesh, Vice Chancellor, Rajiv Gandhi University, Dr. Ali Irani, always a great warrior of physiotherapy, and Mrs. D.A. Kalpaza, Chairperson Vedayi Institute. And most important, Dr. Iftikhar Ali, the organizing chairperson of this conference. Before I start a short talk, Honorable राज्यपाल महोदय से मैं कहना चाहूँगा कि आपके शहर उज्जैन से बिलोंग करता हूँ, आरडी गाड़ी मेडिकल कॉलेज से बिलोंग करता हूँ, आपसे बहुत बार मिला हूँ और सर ने 2014 से 2021 के बीच when he was Honorable Cabinet Minister for Social Justice and Empowerment, all of you please stand and give a huge round of applause for him for giving and passing Indian physiotherapy and physiotherapist as an independent practitioner all over India and giving the diagnostic right to physiotherapists that they can prescribe and diagnose. So sir, आपका तहे दिल से मैं शुक्रिया अदा करता हूँ, थैंक्स बोलता हूँ कि फिजियोथेरेपी को एक नया आयाम, a new horizon, a new dimension is given by your team between 2014 to 2021. And now we can say proudly that we are independent practitioners. Dr. Ramesh is here. I always say my medical fraternity as my big brother. And one day, because many youngsters are here, one day somebody, big brother asked me, Sanjeev, why you are so proud that you are a physiotherapist? Then I said, the only profession which kills pain without pain is physiotherapy. Then I said, the only profession when you come down on this earth with flexion and go from this earth in extension, only profession which keeps you fit is physiotherapy. Then I said, the only profession having lot of research-based evidence and treating almost 5 lakh patients every day is physiotherapy. And that's why I am a proud physiotherapist. Somebody asked me, just now Vaisali madam was saying, that moving physiotherapy ahead. You know, I believe a vision without execution is like a hallucination. I remember 13 years back on the same dais, I said, we will travel and we will finish the task. And what we have done? Now you have independent practice. Now you have teaching cadre. That teaching cadre means only physiotherapists will become dean, director and principal of a physiotherapy college. Now you have no diploma. Physiotherapists are recognized only as a degree as a physiotherapist. Rest all are physiotherapy assistant or technician. So that part is done. Let me be crisp and clear. We have stopped distance education. Let me be crisp and clear. That we are moving towards a new horizon. And when we are saying we are moving towards a new horizon, that means very soon we are going to implement same nation, one profession and one syllabus all over India for physiotherapy. And that is going to come very soon. Just to sum up, we had a big conference in Delhi, and I believe World Physiotherapy President was also there, and we all believe. मैं गवर्नर साहब के लिए भी बोलना चाहता हूँ सर, फिजियोथेरेपी किसी ने कहा कि वेस्टर्न वर्ल्ड से इंडिया में आया, बट आई बिलीव, मैं समझता हूँ कि फिजियोथेरेपी हिंदुस्तान की देन है, हिंदुस्तान से शुरू हुई और हिंदुस्तान ये रास्ता दिखाएगा that physiotherapy will become physiopathy one day, and that is by 2030 we have pledged that we will make physiotherapy as a system of medicine. This journey will keep on going, and I believe all of you will be together with us. And just to sum up, let me finish from this. एक शेर मुझे बार बार ध्यान आता है, यूं ही नहीं मिलती राही को मंजिल, यूं ही नहीं मिलती राही को मंजिल, एक जुनून सा दिल में जगाना होता है। पूछा चिड़िया से कैसे बना आसियां, पूछा चिड़िया से कैसे बना आसियां, बोले उड़ान भरनी पड़ती है बार बार और तिनका तिनका उठाना होता है। तो तिनका तिनका उठाना है। We all have to pick all the goods from everywhere, from all the colleges, from all the institutions, from all the students, and let's everybody pledge this today on World Physiotherapy Day, that the day is going to come when people from across the world will come to India to learn physiotherapy. And that day will be the real physiotherapy day for us. Thank you everyone, and thank you Dr. Iptika, Dr. Sohel, Dr. Reddy, and all the principals for giving me this opportunity. We all will move together, and I am sure we together will win, and together sure we will win. Thank you.
Thank you, sir, for your motivational and thought-provoking words. If your actions inspire others to dream more, learn more, do more, and become more, you are a leader. Patience, persistence, and perspiration is what that makes him unbeatable. It is a moment of pride for me to invite this humble personality, Shri U.T. Khader Farid, Honorable Speaker of Karnataka Legislative Assembly, to deliver the presidential address.
Inaugurator of today's function is Excellency Honorable Governor of Karnataka, Shri Thaawar Gehlot ji. Distinguished guests on the dais and the keynote addressee, my friend, Minister of Medical Education, Dr. Shan Prakash Patil ji. Guest of honor on the dais, Dr. M.K. Ramesh, Dr. Ali Irani, Dr. Sanju Jha, the excellently award achiever, Mrs. D.A. Kalpaja, Chairman of the organizing team, Dr. Iftikhar, and all the team members of this organizing committee, guests and distinguished officers of the dais, all the delegates who are participating in this conference, and all the faculty members of different colleges, chairmen and management committee of different colleges who have supported this physio conference. I like to welcome and thank our Honorable Governor Shri Thaawar Gehlot ji for coming to Mangalore and inaugurating this Physicon conference, which has given a greater confidence to all the physiotherapists who have joined over here. On the people of coastal Karnataka, welcome the Governor. I thank, and I'm sure that whatever demand you have got, the physio students have got, with the guidance of Honorable Governor, our Medical Education Minister, my friend Shan Prakash Patil, will fulfill all your demands and give extra strength for all the physiotherapists and faculty and profession also. I thank all the students who have joined over here. You are very lucky to be one of the noble profession. Our wish is you not only you be a good physiotherapist, you have to be one of the best physiotherapists. And various, I think, opportunity is there in physiotherapists where you can excellent in such a way that everyone will appreciate and everyone will respect and everyone will have confidence in medicine. I like to say in one word, the future is for physiotherapy, I'd like to say. The future is for physiotherapists. And I like to thank all the management committee and college of the chairmen and team of colleges who have started the physiotherapy college, given an opportunity for all the students to take their profession in the physiotherapist. And today, now they are then giving them good education, academic education, and now they are left of the society to the society in their field. And I'm congratulating, thanking all the chairmen, and I would like to remember our Ram Gopal Shetty ji, who is not with us today. I think the coastal belt and Karnataka physiotherapist and management cannot forget Mr. Ram Gopal Shetty ji. Why? Because it was the first college in Karnataka which was started in Mangalore. That was 1989, that's 32 years back. And that time no one knew about physiotherapy. All were going for hotel management. Hotel management was the craze at that time. And there was no colleges at all. Only first college, and that confidence and that vision of Ram Gopal Shetty ji, today hundreds and thousands of colleges have come throughout Karnataka and other parts of the country also. Why we remember is, in nowadays only to start a college is very difficult with the professional teaching staff. In those days, no staffs were still getting from Tamil Nadu, Andhra, Delhi, and the college was established here, and rest all the people started the college. Now today it is one of the best professions and best colleges are there. So I am sure that all the physiotherapists who are working now and all the students, you have got a bright future in the days to come. And I know that Shan Prakash Patel is one of the best and honest and committed minister you have got. When I was health minister, our Sanjay Gandhi was under me. At that time, we had never had a government physiotherapy college. And I started the first, me and Shan Prakash Patel joined together. We started one of the first government physiotherapy college, that is in Sanjay Gandhi Hospital, Bangalore, now which is one of the best physiotherapeutic colleges there. I request the Honorable Minister, not only one, every district, every government hospital should start a physiotherapy college, will benefit the patients and will benefit the students also. After becoming a speaker, and I thought I had a camp for all the MLAs, one of the physiotherapy team was there. I asked them to conduct a free 1 week for medical free physiotherapy camp for all the MLAs and ex-MLAs, and I will give a place in the legislative house. You won't believe, all the MLAs, ministers and ex-MLAs, they give writing, no, this is not enough for 1 week, you extend it for more. And there were demands such that now appointed a permanent physiotherapist for the LH only. For the LH, we have a permanent physiotherapy post was created recently. And I think because the treatment, I need not say too much about the treatment where we are experienced also. I think your profession will have a very good appreciation by the society if you work correctly. So not only be a physiotherapist, you have to be a good physiotherapist. Sometimes when the physiotherapist, when it comes treatment, the pain will less. If the physiotherapist is not perfect, then the pain will be more. So you see that you make the pain less, not at the cost of more. For that you have to be sincere, committed, and have a passion to your profession. Once again, I thank each and everyone for having this conference, sharing your knowledge, getting the views of all the seniors. I think it will update yourself to become the best profession, best physician in the days to come. Once again, thanking our Honorable Governor, the Minister, and all the guests on the dais for making this function a grand success. So thank you one and all. Namaskar.
Thank you, sir, for your words of enlightenment and for your consistent encouragement to the budding physiotherapist. Your words of advice will surely be treasured. One thought of charity can change the life of an individual. Amidst us, we have one such woman who has inspired many others with her exemplary community service in the field of rehab. Srimati D.A. Kalpaja, under the guidance of her beloved late father, Dr. Adi Kesavalu, has been fortunate to help hundreds of people, giving them a new lease of life. Her charitable trust, named Srinivasa Trust, has provided services to the community and its people, mainly in their rehabilitation. Her vision and her capabilities brought barrels to Vaidehi Hospital, through which she has kept a unique approach to charity by reserving 30% of beds in all the departments of Vaidehi Hospital for the needy and delivering free medical services to them and rehabilitate them. Recognizing her achievement and continuous service to the society in rehabilitation, it gives us immense pleasure to honor her with Excellence Achievers Award. I request Madam to kindly come forward and receive this award from the Honorable Governor of Karnataka. May I now request Srimati D.A. Kalpaja ma'am to deliver the speech of acceptance.
Namaste to all of you. I stand here humbly, with all humility, accepting this award from none other than our Honorable Governor of Karnataka, the Speaker of Karnataka Legislative Assembly, Shri U.T. Kader Farid, our Minister of Medical Education and Skill Development, Dr. Sharan Prakash R. Patil, our Vice Chancellor, Rajiv Gandhi University, Dr. M.K. Ramesh, Dr. Ali Irani, former physio of Indian cricket team, Dr. Sanjeev K. Jha, President, Indian Association of Physiotherapists, and me, Mrs. Kalpaja, standing here in front of you to receive this award. I thank all of you to give me this opportunity, to have given me this opportunity to submit a few words. Before I say anything, I thank you all the physiotherapists here, because we tend to forget something on a professional and a personal level. I would like to submit, sir, and make a little different to all the speeches that has been made here today by saying, you are not just the healers. We forget something. You are our answer to what's next. What do I mean by that? There are doctors who treat certain ailments, and then what's next? Physiotherapy is our answer. The reason why I do say that is, yours is the only profession here. I can bravely say that you treat from birth, that is, whether it's a premature born or even before birth till the time of death. So let us not forgive, and let us give them all a big law of applause for being there with us throughout the journey of our life. Thank you for doing this, and I thank Dr. U.T. Ali, the organizing chairman, for giving me this opportunity to be here, because such a forum is needed. We call it physiotherapy, but in the latest new technology, we call it as rehabilitation. As medical is called as medical and allied sciences, physiotherapy now today is branched out into so many varied things. So everybody here deserves to say that, because you are the healers of our pain. Be it a mother or be it a mother of an old person, you are there for us from the time we are born till we are gone. Thank you for giving me this opportunity again. Namaste.
Thank you, ma'am, for your inspiring words. As we celebrate this day, let us take a moment to felicitate our respectful dignitaries. Now is the most awaiting time of the day, It is an honor for us to felicitate Shri Thaawar Gehlot ji, Honorable Governor of Karnataka, who has been generous enough to accept our invitation for the day and have graced us by his honorable presence. Even amidst the festivities, Sir has not only accepted our invite, but also has spent his valuable time with us. We would be extremely happy if you would please accept a small felicitation from the organizing committee. For his time and support, may I request Shri Sharan Prakash Patil Sir, Minister for Medical Education, Government of Karnataka, to kindly accept a small felicitation of gratitude by the Honorable Governor. Okay. May I now take the honor of requesting the Chief Guest to address the gathering, please.
साउथ कैनरिया फिजियोथेरेपी टीचर्स एसोसिएशन के द्वारा आयोजित मैंगलोर फिजियोकॉन 2023 इंटरनेशनल फिजियोथेरेपी कॉन्फ्रेंस में उपस्थित कर्नाटक विधानसभा के स्पीकर आदरणीय श्री यूटी खादर साहब, कर्नाटक सरकार के चिकित्सा शिक्षा और कौशल विकास मंत्री आदरणीय श्री शरण प्रकाश आर पाटिल जी, अचीवर्स उत्कृष्टता पुरस्कार से सम्मानित वैदेही इंस्टीट्यूट ऑफ मेडिकल साइंस एंड रिसर्च सेंटर के अध्यक्ष आदरणीय श्रीमती डी.ए. कल्पजा जी, राजीव गांधी स्वास्थ्य विज्ञान विश्वविद्यालय के वाइस चांसलर डॉक्टर M.K. रमेश जी, इंडियन एसोसिएशन ऑफ फिजियोथेरेपी के अध्यक्ष डॉक्टर संजीव झा जी और अंतर्राष्ट्रीय मामलों के अध्यक्ष एवं भारतीय क्रिकेट टीम के पूर्व फिजियोथेरेपिस्ट आदरणीय अली ईरानी जी, इस कॉन्फ्रेंस के आयोजक चेयरमैन आदरणीय श्री यूटी इफ्तिकार जी, उपस्थित समस्त प्रतिभागी एवं विद्यार्थीगण, सम्माननीय अतिथि महानुभाव और मीडिया के मित्रगण, मैं आप सबको हृदय से सादर प्रणाम करता हूं और आप सबका हार्दिक स्वागत करता हूं। आज विश्व फिजियोथेरेपी दिवस है और इस अवसर पर मैंगलोर फिजियोकॉन 2023 इंटरनेशनल फिजियोथेरेपी कॉन्फ्रेंस का आयोजन किया गया है। इसके लिए आप सभी को बधाई एवं शुभकामनाएं देता हूं। इस साल विश्व फिजियोथेरेपी दिवस की थीम अर्थराइट्स, जो रूमेटाइड, आर्थराइट्स और स्पोडिली आर्थराइट्स से जुड़ी सभी ज़रूर जानकारियों पर फोकस होगा। मुझे खुशी है कि मेडिकल फील्ड के महत्वपूर्ण प्रोफेशनल्स मैंगलोर में एक साथ एकत्रित हुए हैं और आप सब अगले 2 दिन तक कनेक्ट टू अनलॉक पर पोटेंशियल ऑफ फिजियोथेरेपी थीम पर विचार विमर्श करके कुछ अच्छे उपयोगी निष्कर्ष निकालेंगे। फिजियोथेरेपी उपचार पद्धति का एक पुराना रूप है जो किसी प्रकार की चोट, बीमारी या दिव्यांगता से प्रभावित व्यक्तियों में गतिशीलता, शारीरिक शक्ति और कामकाज को फिर से स्थापित करने में सफलता प्रदान करता है और सशक्तिकरण को पुनर्जीवित करता है। प्रसिद्ध भारतीय चिकित्सक सुश्रुत की उचित स्वास्थ्य तकनीक और शारीरिक व्यायाम आज भी बहुत लोकप्रिय है। एक फिजियोथेरेपिस्ट न केवल शारीरिक चोट का इलाज करता है बल्कि रोगी को मनोवैज्ञानिक चुनौती से भी निपटने का साहस देता है। मेरा खुद का इसमें लंबा अनुभव है। मैं 7 साल तक केंद्र सरकार में सामाजिक न्याय और अधिकारिता मंत्री का दायित्व निभाता रहा हूं और इस मंत्रालय में दिव्यांग सशक्तिकरण विभाग भी आता है। मैंने इस कार्यकाल में दिव्यांगों को सशक्तिकरण की दृष्टि से फिजियोथेरेपिस्ट को अत्यधिक महत्व देने का प्रयास किया है। मेरा कर्नाटक के स्वास्थ्य मंत्री जी से आग्रह है कि हर चिकित्सालय में फिजियोथेरेपिस्ट की एक विशेष विंग और वो भी सुदृढ़ तरीके से स्थापित करने का प्रयास करें। फिजियोथेरेपी से कुछ मामलों में चिकित्सीय प्रणाली से सुधार नहीं होने जैसे अनुभव भी मैंने प्राप्त किए हैं। मेरे स्वयं के भतीजे को अस्पताल में, इंदौर हॉस्पिटल में 2-3 जगह दिखाया तो उन्होंने कहा कि इसकी दोनों हिप बदलना पड़ेगी और दोनों नी बदलना पड़ेंगे और ये बदलने के बाद भी 7-8 साल से ज़्यादा की गारंटी नहीं है, जवाबदारी नहीं है। इस बीच हमको पता लगा कि उत्तर प्रदेश में एक उन्नाव स्थान है, वहाँ एक अस्पताल है जो फिजियोथेरेपी पद्धति से चिकित्सा देते हैं। मैंने मेरे भतीजे को वहाँ भिजवाया, 8-8 दिन 2 बार वहाँ गया और इलाज करवाया। आज वो एकदम स्वस्थ है और जिन डॉक्टरों ने ये कहा था कि इनकी दोनों नी और हिप बदलना पड़ेगी, उनको ही जाकर के दिखाने की कोशिश की तो उन्होंने कहा, अरे ये तो एकदम ठीक हो गया, आपने ऐसा क्या किया। तो वो ये उदाहरण मैंने स्वयं ने अनुभव किया है और मुझे भी कुछ परेशानी थी तो इंदौर में एक पिंकी टोपी वाला है, वो भी फिजियोथेरेपिस्ट है, फॉरेन से शिक्षा प्राप्त करके आई है। उनके सहयोग से मुझे भी बहुत लाभ हुआ है और मैं जहाँ निवास करता हूँ उज्जैन जिले में नागदा, वहाँ एक स्नेह नाम की संस्था है जो फिजियोथेरेपिस्ट का काम करती है और बहुत सारे दिव्यांगता प्राप्त लोगों को या पीड़ित परिवार के लोगों को चिकित्सा सुविधा दे करके ठीक करने का काम कर रही है, ये मैंने खुद ने आंखों से देखा है। वर्तमान में फिजियोथेरेपी की लोकप्रियता और स्वीकार्यता बढ़ती जा रही है। फिटनेस को हमारे दैनिक जीवन का अभिन्न अंग बनाने के उद्देश्य से देश के प्रधानमंत्री जी ने भी फिट इंडिया मूवमेंट शुरू किया है, जो शारीरिक सुदृढ़ता प्रदान करने में उपयोगी है। आज के समय में पैरामेडिकल फील्ड काफ़ी बढ़ रहा है। यही वजह है कि फिजियोथेरेपी में कैरियर की संभावनाएं बढ़ी है। ऑर्थोपेडिक क्लिनिकों, अस्पतालों, पुनर्वास केंद्रों, फिटनेस केंद्रों, खेल सुविधाओं और रक्षा प्रतिष्ठानों में योग्य फिजियोथेरेपिस्ट की मांग भी निरंतर बढ़ रही है। विश्व स्तर पर बढ़ते गैर संचारी विकारों के इलाज के लिए आधुनिक वैज्ञानिक सिद्धांतों पर आधारित एक समग्र स्वास्थ्य प्रणाली में सफलता हासिल करने के तरीकों की पहचान के लिए फिजियोथेरेपी से फिजियोपैथी की ओर चलना आज की आवश्यकता है। योग और व्यायाम का भौतिक चिकित्सा से गहरा संबंध है। मैं महसूस करता हूं कि फिजियोथेरेपी के साथ योग और व्यायाम का उपयोग किए जाए तो शरीर की कई समस्याओं का समाधान किया जा सकता है। इसलिए आप फिजियोथेरेपी के साथ साथ योग को भी प्राथमिकता दें, ऐसा मेरा अनुरोध है। मुझे खुशी है कि इस सम्मेलन में विभिन्न विशिष्टताओं के विशेषज्ञ सार्थक चर्चा करेंगे एवं अपने ज्ञान और अनुभव को एक दूसरे के साथ साझा करेंगे। आपने किसी न किसी प्रकार की दिव्यांगता से पीड़ित व्यक्ति की सेवा करने और उनके शारीरिक सशक्तिकरण का जो मार्ग चुना है और समाज को स्वस्थ एवं निरोगी रखने का जो आपका संकल्प है, यह प्रशंसनीय और सराहनीय है। मैं आप सबकी प्रशंसा करता हूं, आपके कामों की सराहना करता हूं। आपके अथक प्रयासों और अटूट प्रतिबद्धता के लिए मैं आभार व्यक्त करता हूं और आप सभी को बधाई एवं शुभकामनाएं देता हूं और आपके उज्जवल भविष्य की कामना करता हूं। मेरी वाणी को यहीं विराम देता हूं। धन्यवाद। जय हिंद, जय भारत।
For always being the most gentle human and helping us throughout, may I request our beloved Shri U.T. Khadar Sir, Honorable Speaker of Karnataka Legislative Assembly, to accept our felicitation of gratitude from the Honorable Governor of Karnataka on behalf of Mangalore Physicon. I request the gathering to please be seated. I request the gathering to please be seated. To extend our hearty gratitude for his constant support and guidance, may I request Honorable Governor to honor M.K. Ramesh, Vice Chancellor RGHS, on behalf of Mangalore Physicon. On behalf of Mangalore Physiocon, I now request our Governor to please honor Dr. Ali Irani, sir, with a memento. And also, I request Governor, sir, to please honor Dr. Sanjeev Jha, IAP President. With this, we conclude the inaugural ceremony of Mangalore Physiocon, and I wish the best to the delegates for the coming 2 days. Mangalore is all set to give you the best of memories and warmth, connect and capture the physio world. Let's move the physio way. Thank you, one and all, for your presence. Let us all rise for the national anthem. Thank you, one and all.
Charge and
I request the delegates to have your food fast and come back. We'll be starting the next session in the 15 minutes time.
Saying what was happening before the program.
This is from here.
Good afternoon to one and all.
The next one. The next to previous.
So now we have here Dr. J. Mohan Krishnan, who is currently working as a physiotherapist, Department of Neurosurgery, Jawaharlal Institute, JIPMER, Pondicherry, India. He has a qualified PhD and diploma in yoga. His area of interest is orthopedic physical therapy and yoga therapy. He is very popular for tremendous research knowledge. He is the editorial board member of Journal of Anandrao Institute of Medical Sciences and International Journal of Yoga, Physiotherapy and Physical Education. He also has peer-reviewed the Indian Journal of Orthopedics, International Journal of Pharma and Biosciences and Physiotherapy, the Journal of Indian Association of Physiotherapy. He has a total of 7 publications in various fields from orthopedic conditions to spinal cord injury. The date of publication ranges from 2016 to 2022. So now we have about scientific session regarding physical therapist and pain by Dr. J. Mohan Krishnan. Over to you, sir.
Thank you. Thanks for the introduction. Good afternoon. Today we are going to see an interesting topic. I think for the next, for all the topics, whatever you have seen and going to be seen for the next forthcoming talks, this is going to be a little contradictory. In the morning, in the inauguration session, we have been seeing people talking about pain relief by physiotherapists. And this is contextual in the sense like physiotherapist is known to treat pain. Yes. So, physiotherapist in the role for pain relief, that's going to be the essence which has to be taken up. But nevertheless, we have to understand, sometimes we tend to cross our limits. Having said this, I'll start my presentation with tributes to my teacher, institution and family. Om Gurubhyo Namaha. At one point of time in everybody's life, you have to really have a check. Somebody has to be there. Till a point of time you had your teacher in the school, college, everything. But once you come to practice, it's very difficult for you, for somebody to come and monitor you, appraise you and give you feedback. That's where the concept of self-appraisal comes into existence. What is self-appraisal? You do something, you feel good, you continue to do that. But you never know whether what you're doing is right or not. Under this context, self-appraisal is an important aspect which will give you a certain amount of growth in you. It's not like what you continue to do, what you know. See, what is the gain out of self-appraisal? By doing self-appraisal, you always tend to grow. What are you going to do? You are going to grow. How? Financially, socially, yes. But ultimately, what is going to be benefited is for the mankind. We physios, we build hospitals, colleges, etc., etc. But for what? Ultimately, the beneficiary is going to be the patient. That's a grassroots level. That's the end customer what you are going to supply. Here, there is one beautiful paper which I came across. It is the relationship between the patient and the therapist. I'm sorry, the doctor and the patient. But we have to take the sense, real essence of this paper from our point of view. What really works ultimately? You have n number of ways by which you can intervene the pain relief. You have got all the basic techniques to the advanced techniques. And every day you see this is getting evolved. But which is right and which is wrong, you have to give a check. But there is something apart from the technical aspect, the conceptual aspect,
the pathology, the physiology, the disease, the place, etc., there is something more which comes into the outcome part of it. If you can closely observe, a patient is given exercise. What do you expect? An improvement in strength, psycho-emotional status, and a general well-being. That's what you want. But how these two, the clinical outcome and the intervention, how does it come into play? It is only because of a strong therapeutic relationship. Here you should understand the outcome is not based on a technique, a concept, or anything else for that matter. What really comes into play is your relationship with the patient. Often we come across this context of placebo and nocebo. What is placebo? Anybody? Placebo? Placebo is something like, it does not have anything to do, but it is said to do so that it has an impact. This placebo was actually invented, not invented, it was put forth for research purpose, especially in pharmacological studies. So what they will do, they will give an intervention, they will give chalk powder, which they call it as a placebo group, and they will start comparing the outcome. So this is considered to be nil effect, and this is considered to be a therapeutic intervention. This they compared and they say, compared to placebo, you get something. But you have to accept at a point of time that this something also can play a role. Now the pain science has revealed that there are so many other factors other than the intervention which can give you some amount of outcome, which has got a cortical influence. This is not just a peripheral, it's not psychological. Some amount of physiological response is also brought from the cortical level, and it can produce pain relieving substances. And this paper beautifully describes the relationship between the doctor and the patient, not just the relationship between the expectation what the patient has towards the therapist or the doctor, because of which there is a central mechanism with which you get the outcome. So it has been found that the mind plays a major role. The mind plays a major role in the outcome. So apart from the intervention, the mind is influenced with so many other factors. That's why nowadays placebo itself is called as an intervention. So what are the things which holds you in the placebo, and what are the things which will give way in the nocebo? See, suppose a patient comes to you, you say, I'm going to treat you. After the treatment, the pain is going to get relieved. This will have a positive impact on the patient, and this will create an expectation, and after the treatment, he will feel satisfied. The reverse is what is called as nocebo. Like you say, I'm going to do this, this may not work for you. This might harm you. Even you do the same thing what you did the earlier one, the patient will not have a response. A positive response will not be there. So giving the patient something, having said that it will work, it's a placebo, and the reverse is called as the nocebo. So what you see here is the professionalism, the mindset, the outlook, the communication, the treatment given, the posology, and the positive environment. Suppose you take a private clinic. In a private clinic, you see all these factors will be covered. You will have a clean atmosphere, the therapist will be well dressed, he will be good looking, he will communicate to you in a proper way, and he will establish a wonderful rapport, and he will create a positive impact on you. The eye contact, the verbal communication, the physical touch, all these will have a positive impact on the individual. That's why you see all these private clinics, the so-called corporate sectors, they will have a very good ambience. People say ambience, what does it do? It does. And research has shown this positive environment can have a positive impact on the treatment outcome. Whether you give medication or exercises, it is immaterial. So, if you want to really create an impact on the patient, you have to govern all these 4 points. So, maintain thorough professionalism, have a clear mindset, and you should know what you're doing. The outlook should be appropriate. There is nothing good, nothing bad. But when you go for treatment, the outlook should be appropriate. The communication skill is the important thing. For a physiotherapist, the verbal communication, the rapport is the main set of things what you need. That's why you see people who come from their own place. Sachin Tendulkar in Mumbai, our Tamil Nadu cricket players in their own state, their own place. Nataraj in Salem. These people do well. Not just because they play, but therapists also tend to do when they are in their own place, own language, own culture, and own people around. This has a positive impact on the individual, on the outcome also. And definitely posology is very important. Okay. Now let me put a question to the crowd. For a chronic low back pain, are you with me? Yes. Chronic low back pain, short wave diathermy, how many days will you give? Or to what duration you will give? Anybody? For a chronic low back pain, short wave diathermy, for how many days it is prescribed? Anybody? 1 week? 10 days? 15 days? What duration, sir? 10 minutes? 15 minutes? 8 minutes? 20 minutes? This is where we lag seriously. For any modality, any intervention, posology is important. The dosage of the treatment is very, very important. So if you are clear with that, I think you can smoothly go ahead. And a positive environment. So, children, you should be very careful when you think about your outlook, which can have an impact on the outcome of the treatment. There is $1 million question, where does this pain science heading to? What is really mattering? What matters? In pain science, nowadays it has been seen that in everyday OPD, I get patients asking for, sir, I have a C5, C6 disc prolapse, radicular pain to the left upper limb, kindly treat. How do they get this? By Googling, by going through all WhatsApp news, all social messages. These things has got a higher impact than anything else. So I just feel that MSK pain, the musculoskeletal pain, can be better handled if we have a social impact through this sort of, what I should say, the Facebook, this, WhatsApp, rather than me communicating to you directly. And again, talking about mindset, that's the pradhanam. Today, our Honorable Governor of Karnataka was talking about the yoga. Physiotherapists should equip themselves with yoga. Why? Because this yogic approach can give you a greater amount of basic impact or intervention through the mind. Okay, we call it as Adi Vyadi. So you try to attend to any ailment through psychological intervention. That is what is called as the mind intervention. Okay, you have to question yourself often about your proficiency. Proficiency, when you start your career, you will be doing everything. After a period of time, you will get into some lesser things. And after a period of time, you will be concentrating on only one smallest thing. For example, I started general practice, I went on to orthopedics, and now I stick on to shoulder and knee. So that's how you should improve your proficiency, and you should not be doing everything. And of course, knowledge is everlasting. You need to keep it updated every day. So you have to question yourself about your knowledge, and these things are key. Finding the answer, how do you get it? How do you get the answers? You have to go for a discussion. discussion with experts, review of literatures, and educate yourself. See, education is not just going to be a undergrad or a postgrad or a doctorate. It has to be constantly should evolve. You have to do all the related things which you are specializing in. They call it as domainship. Okay, you should be known for a specific region in the body. You should not be known for everything. You cannot be a jack of all arts. You should localize and create your own domain through intervene. So try to specialize in that specific field, get into the depth of it. Self-appraisal again will give you novelty, like you should be giving a good amount of treatment. And standardization. What is standardization? Again, you should be rendering a standard exercise and treatment prescription which is suitable for everybody. It should be universal. It is not that it works for you but not for others. It works for them but not for you. It has to be a standardized protocol, and your practice should establish a standardized protocol. Either you should be practicing it or you should be bringing a standardized protocol. And nowadays I see there is high subjectivity, both in assessment, treatment selection, modality selection, and techniques. This subjectivity should not be there in order to promote a profession ahead. So you should think of objectivity in evaluating your treatment, the protocols, the outcomes. After doing all this, what are you going to gain out of it? Simple. You have to help this mankind, the grassroots level. These grassroots level individuals are your breadwinners. If you are going to win your patients ethically, rightfully, without exploiting them, you are likely to make the difference. And one area which is grey, where we have to explore more, is palliative care, the oncology part of the treatment. You can do wonders. It's a grey area which is very difficult to approach, but it's full of potential. And believe me, you cannot, maybe I'm contradicting to today's morning classes, you cannot do well or do progress or promote your profession if you are going to stand alone. You have to have a teamwork. Let it be orthopedics, let it be neurology, cardiorespiratory, OG, sports, whatever you are in. Please understand, as a students, you should be putting a team effort and not an individualized effort. It cannot happen. And professional governing bodies should really mind it. Okay, coming to the end of the presentation, manual therapy. What is manual therapy actually doing? Manual therapy facilitates a wonderful way of communicating to the patients. When you treat a patient, when you touch and talk to them, when you touch and treat them, it has got the highest impact on their outcome. I mean it. So the more you try to establish a verbal communication with a proper eye contact and a physical contact through manual therapy, you can produce good amount of results. But here I have a news of contradiction. Manual therapy at times can produce a devastating outcome. So it's always has an element of risk. So governing bodies has to incorporate this manual therapy skills in students and instill a ethical practice and not a bizarre practice. They should not go fancy all the new techniques, whatever is coming to the market, and later blame the technique. You should have a scientific background with the contextual factors to select your manual therapy techniques. So students, you should be very careful when selecting about manual therapy. What is evidence-based practice? People say evidence-based practice, EBP. You should be practicing based on evidence. But it's very difficult always to practice just what is there on the evidence. Sometimes it is experience which speaks first and putting it into practice. But I believe in this experience over a period of time should definitely turn into an evidence. That is, for example, you start practicing something, you see that it is working well, work on it and put it as a paper, create an evidence. If you are not able to do what is there in the evidence, create your own evidence in the rightful way, in the ethical way. Having said this, we are evolving. We started with a model of biomedical model. The doctor was the god. The patient was just on the receiving end. He will say, get it done, do this. The patient will do. Slowly we start evolving. Slowly the biopsychosocial model came, and the societal impact, the family role came into existence. And now you can see that the spirituality getting into it, that is the mind part is coming to it. It is not true in the sense of spirituality, but the mind part is coming into the existence in the treatment. So the biopsycho spiritual model is coming into existence, and who knows how it is going to evolve later. Having said this, I complete my presentation. Students always try to have a scientific background, a conceptual model, and an ethical practice for us to survive and to flourish and to promote the profession. Thank you.
Thank you, Dr. Mohanakrishnan, for a wonderful presentation. In a regular pattern, it's totally different from a regular pattern of listening what is pain and management. You have given a reorientation to the whole group, taking through a journey of research and importance of evidence-based practice, and giving importance on coming spirituality into the final outcome. And it's good to listen to you over the 20 minutes of lecture. And you have throughout your talk, you are giving more importance on professionalism and communication skills, which can make a lot of changes in patients' outcome. That is more important and is more relevant nowadays when we are spending more time with patients in the clinical aspect. That shows your clinical experience and for your last 10, 15 years of time in Jipmer. Thanks for sharing that important value to our students.
Thank you, sir. Thank you.
Any questions?
Thank you, sir, for sharing the core of patient care, that is dealing with pain. I request the chairperson of the session to present a token of appreciation to our speaker. I request Dr. K. Narasingha Rao, Principal, St. John's College of Physiotherapy, and the member of BOS RGHS to hand over the token of appreciation to the chairperson and moderator for the session. Our next session is Cracking the Code, an animated radiological guide to differentiating osteoarthritis and rheumatoid arthritis. I request the chairperson, Dr. Manjunatha H., Principal, Divine Grace Group of Institution, Bangalore, and the moderator, Dr. I. Suleiman, Professor, Dr. Ambedkar College of Physiotherapy, Bangalore, to please come over. With round applause, I would like to invite on stage Dr. C. Prabhu, Dean and Principal, MVM College of Physiotherapy and Allied Health Sciences, Bangalore, Karnataka. Sir is also the founder of the Institute of Digital Teachings, Bangalore. Welcome.
Good afternoon, everyone. The next session by Dr. Prabhu. He is a distinguished professional with a wealth of experience in the field of physiotherapy and education. He currently holds the position of Dean and Principal at the MEM College of Physiotherapy and Allied Health Sciences in Bangalore. His qualification, Master of Physiotherapy in Neurology. Dr. Prabhu's impressive career spans over 24 years, combining both teaching and clinical expertise. Notably, he is recognized as an expert in creating educational animations for the entire field of neurology and radiology. He is known as India's only medical teaching animator. He has been an academic council member of NTR Health University in Andhra Pradesh. He is a registrar guide for Rajiv Gandhi University of Health Science in Bangalore. In summary, Professor Dr. Prabhu is an accomplished educator and administrator in the field of physiotherapy with a strong background in neurology.
How to connect?
His contributions to the medical education through animations and leadership in academic make him a notable figure in the physiotherapy field. Sir, over to you, sir.
Good afternoon, everyone. Now we see about the difference between OA and RA. We are seeing X-ray here. I request everyone to identify what's the right answer here. What is seen in this hip X-ray? I request to join in this website. Just take your mobile. Type slido.com or scan the QR code. Don't worry, your name will not come unless until you enter. Take a mobile. Type A7, excellent, very nice, you joined. S. Agmal, excellent. Wow, very nice. Take a mobile, all of you backside, who's there? Hello? Excellent. Type slido.com. Type slido.com. You have seen that X-ray. I think for 3,000 to 4,000 people are here. I want everyone to participate. Join at slido.com. Okay, excellent. So what is the right answer? So the answer is here. Choose the one right answer in that X-ray film. Whether it's a sclerosis, a synovial cyst, osteophyte, or all the above. Hello? Okay, I'll come back again, once again. You're seeing here, please see this X-ray. Here 4 options are there. Whether it is a sclerosis, cyst, osteophyte, all the above. I'll go to the slido.com once again. And now you can give the answer. I request everyone to give the answer. Let's check whether it's a right answer or wrong answer. Yes, start giving the answer. There's some people gives osteophyte. Yeah, 62%. I request others also, go to the slido.com and give the answer. Some of you say sclerosis. Some of you say cyst, and many of you say it's cyst. But only 10% says it is the all the above answer. Am I right? So, at this, the 10 or 15 minutes of presentation, you should be able to identify what is a sclerosis, what is a cyst, osteophyte, and erosion. Without radiology, without your assessment, without the MRI, CT, or X-ray, you cannot become a direct access practitioner. It's extremely important if you want a direct access practitioner. Okay, this is the basic, and you get these cases every day. All the patient comes to your clinic with a rheumatoid arthritis or with the osteoarthritis. So this 10 minutes, please use it to understand about what is RA and what is OA. So the right answer is all the above. So we have the top rankers. We give a big claps to the people. Preeti Mishra, Pratik, and Preeti Mishra has given answer is in 4 seconds time. Okay, 4 seconds time, and you can see the rest of the people. So now we come to the basics. First we look at what is the RA and OA. First we look at, consider this as a joint, okay, and outside you can see the periosteum. We can consider this as a periosteum. It may not be looking, so consider periosteum, and you have the cartilage. Okay, look at the cartilage. So here you can see the joint capsule. Just below the capsule, you can see the synovial membrane. Okay, the synovial membrane produces the synovial fluid. Okay, the synovial membrane produces the synovial fluid. So what happens in rheumatoid arthritis? In rheumatoid arthritis, the inflammation of the synovial membrane happens. Okay, after that, and it becomes bigger and thickening happens. When it thickens, it produces more synovial fluid. Okay, the more synovial fluid, and this thickening, you'll be seeing in X-ray as the pannus. Okay, that's called as the thickening of the synovial membrane. In X-ray, we call it as the pannus. Cloudy nature we identify in the synovial membrane. So this synovial membrane, what happens? It produces more and more synovial fluid, and toxins in the synovial fluid starts to destroy the cartilage and nearby bone. So that's what we call it as the erosion. Look at here. The toxin inside the synovial membrane, it starts to destroy the cartilage and also the bone. Okay, also the bone. That's what we call it as the erosion. Okay, erosion we call it as. So now we'll look into the OA. So that's what we see with the rheumatoid arthritis. What happens with the osteoarthritis? Osteoarthritis, it's very simple. You see the cartilage and you see the synovial membrane, all these things. But what happens due to the heavy weight or any primary lesions, and the cartilage starts to destruction. We all think that osteoarthritis is a degenerative disease. Yes, it is a degenerative disease. It is only the cartilage goes for the degeneration. But the rest, the bone goes for the regeneration. The more bone formation occurs. Okay, that more bone formation is called as you see a full osteoarthritis case, and the more bone formation occurs. So that's called as the sclerosis. That is called as the sclerosis. There is a major difference between what you see in X-ray. One is the erosion in rheumatoid arthritis, but here in OA, you see the more bone formation. That's the osteoarthritis. Okay, and along with that, you see the osteophyte also. We directly go into the X-ray. Okay, look at here. So what is a joint space reduction? Joint space means it is about the cartilage. If there is a degeneration of the cartilage, then there is a joint space reduction. You can see one side there is a joint space narrowing, okay, and other side it is a widening. So same thing you can identify in the X-ray. You can see there is a narrow joint on the lateral side and the widen the medial side. So this is what we see in the X-ray, widening one. The next, what you see in the X-ray, a subchondral sclerosis. Hello, what is a subchondral sclerosis? It is about the more bone formation. It is about, look at here, more. Wherever the force is there, wherever the pressure is there will be a more bone formation occurs. That's called as the subchondral sclerosis. So look at here, where is the subchondral sclerosis? You can see there is a white patch. Look at here, what you see as a white, it's the subchondral sclerosis. It is about more bone. But in rheumatoid arthritis, it's about the erosion. It's about the erosion. So next is about in OA, you see the osteophytes. It is about the small outgrowth, okay, outgrowth. It's not about a sclerosis inside. If the bone comes outside, okay, if the bone comes outside, you call it as a osteophyte. Lateral and the medial side, you can see the osteophyte. Look at this X-ray. You have an osteophyte outside. You don't call this as a sclerosis, even though there is a more bone formation. You call it as the osteophyte formation. So whether the tibial spine or the lateral side or the medial side, we see about the sclerosis. Next, extremely important. If you see a cyst in your X-ray, it could be a rheumatoid arthritis or it may be osteoarthritis. Both can be possible. Look at here. Could you find out where is the cyst? Anyone? Could you able to find where is the cyst? You can see a cyst, a small cyst. So here again, you can see a small cyst. If this cyst touches the joint space, that could be the rheumatoid arthritis. But if it is inside the bone, and that's the osteoarthritis. That's the osteoarthritis. I'll show the difference. So you need to identify where is the cyst. Okay? And could you identify where is the cyst in this hip X-ray? You can find this is the hip X-ray cyst you can identify. And also you can see the other factors like osteophyte over here, and you can see the sclerosis. So this is what the first X-ray has shown to you. And what happens? This is the intra-articular loose bodies. When the osteophytes are very hardened, very thick, what happens? And smaller fragments comes out of that. The breakdown of the osteophyte happens, and this fragments comes into the joint space. So that's called as the intra-articular loose bodies. Look at this X-ray. You can find the intra-articular loose bodies inside the bone. So this is not the fibula what you see in the normal bones. This is about a breakdown of the osteophytes. It comes into the inside the intra-articular area. So that's about the OA. Next, look into the RA. Here you can see a normal cartilage. And what happens here? You can check the normal cartilage, how it looks. The joint space is called as the normal cartilage. Okay, normal cartilage we see. So the RA starts with osteopenia. So what is osteopenia? It is a reduction of the bone cells. Okay, reduction of the bone cells, or you call it as the starting stage of erosion. or a starting stage of osteoporosis. Okay, osteoporosis. But later, it is about a destructive feature. Destructive feature, what we see. Look at here. And this erosion happens near to the joint space, but not touching the joint space. Sorry, it touches the joint space. But OA, it is inside the bone. Look at here, X-ray. And you can identify the erosion. So when you identify erosion, it is about the inflammatory arthritis, not directly going to the rheumatoid arthritis, it's about inflammatory arthritis. So this is the major difference between degenerative arthritis and also inflammatory arthritis. You need to find out, okay? So this is the major difference between OA and RA. And here you can say this is the subcortical cyst, but the previous one, it is touching the joint area. It's not a subcortical cyst, it's about a marginal cyst in the rheumatoid arthritis. Okay, so with that, we complete the basic fundamentals how to identify the OA and RA. If you have any questions, you can ask me. We have a very short presentation, but we have enough content on the OA and RA, how to differentiate. If you have any question, you can ask me.
Thank you, Dr. Prabhu, sir. It was a wonderful presentation, cracking down the differences in RA and OA, and also some specific points you made so that how the clinician can use their radiological skill for their diagnosis and confirmation purpose. Thank you very much, sir. Anybody, any audience have a questions? You can rise. I think no question. Thank you very much. Thank you, sir.
Thank you, sir.
Wait. You should pull it.
Thank you, sir, for the knowledge shared with us. I request the chairperson to present the token of appreciation to our speaker.
Shall I give it to you, sir?
Super.
Okay.
Start time now.
Okay. Thank you. Thanks a lot, sir. Thank you very much. Thank you. Thank you.
I request Dr. M.R. Shivkumar, Associate Professor, Enapoya Physiotherapy College, to hand over the token of appreciation to the chairperson and the moderator of the session. There's a small announcement regarding the quiz prelim round, which is going to happen at 3 p.m. now. So if any participants are here, please go down near the diner and meet Dr. Sidney Ribello. Our next session is the missing thing in shoulder rehab. I request the chairperson of the session, Ms. Charishma De Silva, Professor and HOD, Physiotherapy Department, Father Muller's Medical College, Mangalore, and the moderator, Dr. N. Jovia George, Principal, Indira College of Physiotherapy, Mangalore, to please come onto the stage. It is an absolute honor to bring to stage Dr. David Arun Kumar, Principal, Hillside College of Physiotherapy, Bangalore, Vice President, IAP, Karnataka. So we welcome you. Sir, yes.
Sir is a Dean and Principal in Hillside College of Physiotherapy and Allied Health Sciences, Bangalore. Head of the Department, Vasadevi Hospital, Bangalore. Senior Consultant, Advanced Physiotherapy Center, Bangalore, and Chief Instructor in the same place. The position and the memberships which Sir hold is Vice President of Indian Association of Physiotherapists, Treasurer in the Bangalore Physiotherapy Network, Life Member of Manual Therapy Foundation of India, and the Life Member of Mulligan Concept Practitioners as well. Sir is a well-known physiotherapist with more than 26 years of clinical and teaching experience. Sir has done his master's in orthopedics in the Advanced Orthopedics and Musculoskeletal System from Dr. MGR University, Chennai. Sir has completed various certifications, including the Orthopedic Manual Therapy from Manipal University, Craniosacral Therapy from John Upler's University, which is in the USA, Mulligan Concept in New Zealand. Sir is also a licensed dry needling practitioner in India. Sir is currently pursuing his PhD from Maharaja Vinayaka Global University, which is a NAC accredited from Jaipur. Sir has published numerous papers. Sir is also certified practitioners with therapeutic taping techniques and dry needling techniques. We are immensely glad to see you here. Sir has expressed his area of interest in chronic pain management, Mulligan therapy, Cyrix manipulative therapy in the various joints and dysfunctions, cervicogenic headache and dizziness, myofascial pain syndromes. Sir has conducted numerous health awareness programs in Bangalore, and Sir has conducted numerous lectures and series in various places in and around Bangalore. Sir has presented papers in more than 10 national physiotherapy conferences. Sir, we are extremely glad, sir, you made time for us here.
Thank you.
The session is about to start, sir.
Yeah. Very good afternoon to all of you here. I know post-lunch, it's very difficult to sit and hear something on shoulder rehab. I hope I am audible at the back of the auditorium. First of all, I would like to thank the organizers, Ifti sir, and the scientific committee. Few things that we rather miss while we rehab a shoulder, post-operative shoulder. First of all, let's see the most regular cases that we see in our OPDs, that is rotator cuff repair, your Bankart's and Hill-Sachs repair, that is the anterior stability repairs. And we see cases of reverse arthroplasty of shoulder. We see cases of Latarjet repair, nowadays very famous, to fix the anterior instability. All these cases, after the surgery is done, they are referred to a physiotherapy department. Based on the surgeon's protocol, we go ahead and do the rehabilitation of the shoulders. Before I talk about the missing things, these are simple ones that we miss, which will definitely help us all to get a complete rehab of any shoulder, not only an athletic shoulder, not only a sporting person's shoulder back, but also a homemaker who comes to us, or a middle-aged male person, a retired person who comes to us for shoulder rehab post-operatively with residual issues persistent with him. So let's just quickly see what are the major regular rehab protocols that we have. We have 4 major phases. One is the early phase, second one is the intermediate phase, third is the advanced phase, and fourth is the return to activity phase. I'll quickly go through this. In the early phase, it will be between 1 to 2 weeks, sometimes it's 3 weeks. We concentrate on decreasing the pain and inflammation using ice packs or cryotherapy or rest. and sometimes NSAIDs. And we concentrate on passive and active assisted movements to increase the range of motion. Little bit of strengthening using isometrics. And sometimes for an athletic shoulder, we usually start with rhythmic stabilization also. The second phase, that is the intermediate phase, which ranges between 2 to 6 weeks, sometimes 8 weeks. We progress to the range of motion of 90 degrees at least, passively, pain-free. Then we initiate the isotonic strengthening of the muscles, emphasizing the scapular stabilizers most importantly. And then to some extent, we start with neuromuscular control exercises like initiating proprioceptive exercises, and we start doing rhythmic stabilization drills. Then is the third phase, the advanced phase, 6 to 12 weeks, sometimes 14 weeks. We continue with ice or any pain relieving modalities if required, if there is any pain. We continue with isotonic strengthening, progressive resistance, emphasize on PNF, endurance exercises, initiate plyometric training during this period. This is advanced phase. And then if the person meets the criteria of getting into the next phase, then we go to the return to activity phase, that is at least 12 weeks and above. We start exercising as in, we do the exercise of the advanced phase. Along with that, we progress with isotonic strengthening exercises and start with the short activities of, if the person is a sporting athlete or a sports person, we start with short activities off the field or sometimes on the field also. Everything is set, the protocols are set, early phase, intermediate phase, advanced phase and return to activities phase. When we do all these things, what are we missing then? When we actually see a patient in our department during our rehab, are we stuck with any of this? After doing all these things, say the patient comes to 6 to 10 weeks to us, are we still stuck with persistent restriction of end range flexion, end range internal and external rotation, persistent lack of strength, persistent shrug sign? I believe all of you know this shrug sign. And for some people, persistent pain. First of all, let's see. I'm going to speak about three missing things in shoulder rehab. The first missing thing is we always forget the proximal to distal activation pattern, which is very, very important. It has been described and researched and published in 2000 itself by Kibler, and again he keeps on publishing. That is, I'm not talking about the open kinematic chain or closed kinematic chain exercises. Of course, upper limb open kinematic and closed kinematic chains exercises are very important. I am talking about this, the activation of the trunk muscles, the hip muscles and the leg muscles, which are actually the foundations for the shoulder functions. Very, very important. This is the first thing we miss in a shoulder rehab. Let's quickly see what is the kinetic chain exercise. The kinetic chain refers to the sequential task-specific activation of body segments during functional movements. Sequential task-specific activation of body segments means when you try to do something with your hand, there is a sequential activation of many muscles in your trunk, in your hip, your glutes starts firing, your back muscles, your posterior trunk muscle starts firing, then only your scapular stabilizer starts firing, then comes your shoulder muscles. So that's how it actually works. And during sporting and non-sporting activities, the shoulder complex always works as an integral part of the whole musculoskeletal system. It does not work in isolation. So Richardson says in 2020, it says, integrating kinetic chain exercises into shoulder rehab will reduce the demands on the rotator cuff and increase the strength to perform. So these are some of the literature that I have put. quickly we'll go through that. Legs and trunk generate 50 to 55% of the total kinetic energy required for shoulder functions. Inclusion of lower extremity and trunk motion into shoulder rehabilitation programs will optimize efficient energy transfer. These are the literatures that are already available there, but we always miss and concentrate only on the shoulder, shoulder and shoulder. There's something called as kinetic chain. There's a chain, we call it as T-reins, Tom Mayers has said, which is connected through fascia. Anterior also there is a chain and the posterior also. Let's just check this chain on the right hand side, the B side. This chain, see this muscle is connected to thoracolumbar fascia and to the glutes and to the thigh muscles. So when a shoulder is working, this has to be optimally firing and working. So very important and not to be missed. The first thing which is not to be missed in a shoulder rehab is to always use kinetic chain exercises of spine and lower limbs, include hip mobility and stability exercises, knee stability exercises along with the shoulder, very important. Shoulder exercises with concurrent glutes contractions, and it can start before surgery also. If a surgery is planned, you can start these exercises before that, and it can be done post-operative with the arm sling also, because in the first 1 or 2 weeks, nothing is allowed by the surgeon for a physiotherapist to do. So it will only be the cardmans and scapular shrugs or squeezes and nothing else, elbow and wrist movements. So during this period, it is good for us to activate the trunk and the lower limb muscles, so that when the athlete or a patient or a non-athlete patient starts performing the shoulder exercises, he will have enough kinetic chain and kinetic energy. These are the few exercises that can be included. There are plenty of them, there are hundreds of them. These are only a few ones. Single leg stance can start. You can start with single leg squats. Simple ones. Emphasizing on the knee, not to valgus or varus movements. Then you can include forward step down, lateral step downs. These are simple ones which activates your core, your glutes, your thighs, things like that. And then some exercise, for example, scapular muscle activation exercise can be done in this position without the support. If a person is holding on to something, the trunk is not working, the glute is not working. If the patient is not holding and doing the horizontal abduction or the rowing or the extension, the trunk muscles, the glute muscles are all concurrently acting and working, so that the kinetic energy is optimized. So what is the second thing that is missing? The first thing was the kinetic chain to include the spine, your trunk muscles, your lower limb muscles and the hip muscles. The second thing which we usually miss is the very important force transferring muscle, which we don't give importance to, whether it's flexibility or the strength. And this muscle helps not only in sporting activities, 100% it works, it helps. It helps also in daily activities at home, like picking up from the floor, grabbing something from the cabinet, or chopping or stirring, anything. So very important muscle for a non-athlete also. And that's the latissimus dorsi, which is very important muscle. You can see that is a shoulder muscle. It attaches from T6 to S5. All the vertebrae are attached through thoracolumbar fascia, of course. And the insertion is on the intertubercular groove on the humerus. So such a huge muscle seldom recognized in the shoulder rehab, especially its flexibility. Without 100% flexibility of latissimus dorsi, you will not get forward flexion. Total forward flexion, you will not get it. I will show you that. So this is the origin insertion. The most neglected muscle, as I told you. The action is internal rotation, adduction, extension of arm. So if you have any restriction in external rotation, abduction and flexion of the arm, try to see this muscle also along with other muscles. Very, very important and rarely touched muscle. So I'll just show you a supine forward flexion in a normal person. Looks something like this. So see, this is how much he can extend. If he goes further down, his trunk is elevating up. Can you notice that? I think I'll repeat it. See, once he goes down, his trunk is elevated. See? So this is because the latissimus dorsi's extensibility is compromised. So the end range flexion, which we usually try to bring it up using the scapular mobilization and so many other manual therapies, you can as well do the MFR and simple stretches of your latissimus dorsi, which will give you good results. And these are the simple ones, simple stretches of your latissimus dorsi, which you can do and inculcate in patients, not only in sports people or young people, even the older population also can do these exercises. Which is the third most important missing muscle, especially in the frozen shoulders and the post-operative rehab, is the subscapularis muscle. This subscapularis muscle, all of you know, it's a part of rotator cuff. It is one of the largest muscle of the rotator cuff. Rarely recognized in our shoulder rehab because, in fact, in the orthopedic circles, orthopedicians say it is a forgotten muscle. In orthopedic circles, subscapularis is called as a forgotten muscle, and in physiotherapy circles also is the most neglected muscle. Why it is most neglected? Because not of the primary function, of the secondary function, which is also primary when it comes to shoulder rehab, because subscapularis is a humeral head centralizer by depressing the head during the abduction and elevation. When a person abducts his arm or forward elevates his arm, your head of the humerus needs to sit in the glenoid cavity without translating forward or translating upward. Yeah, just come. So this is very important, especially when you have after the operation or surgery, post-operative rehab, abduction is very less. The patient cannot abduct without shrugging. We call it as the shrug sign. That's because the head of the humerus is not sitting properly or it is not centralized in the glenoid cavity. The work of this muscle along with co-contraction of the infraspinatus keeps the head in its place in the glenoid cavity while you abduct or elevate the shoulder. Very, very important muscle, because during an abduction, 30% is contributed by the subscapularis muscle. We always concentrate on deltoids and supraspinatus muscle, but see, subscapularis contributes more than supraspinatus muscle. And it's not only subscapularis is not only active in the regular flexion, abduction, scaption and internal rotation exercises, it's also active in other movements like side lying abduction, standing extension from 90 to 0 degree, military presses, D2 diagonal pattern flexion extension, PNF scapular clock and all the other scapular movements. So we all come across this problem when we rehabilitate a shoulder, that is the shrug sign. The patient, when you ask him to abduct or elevate, he starts using his shoulder girdle. That's because your scapularis is tight or it has a myofascial trigger points or it is not working. So to test whether the subscapularis muscle is the culprit here, we have 3 tests, that is Gerber's lift-off test. Just take your hand behind your back and try to lift off from your back. And the belly press test, very simple ones. You ask a patient to press his belly. If he has a problem with his subscapularis, he will try and press like this way. He will use the elbow to press the belly. And this is another test, bare head test. This is also a test which can identify any pain or any discomfort in your subscapularis. This is a normal test on the left. If the patient has pain, he will use your elbow and try to press. So these are simple tests. So techniques to relieve shrug sign, that is to get a good abduction and elevation without any shrug. Normally we use Maitland Mulligan joint mobilization, soft tissue mobilizations like capsular stretches, etc. If it's not recovering, please try and use this either MFR of subscapularis or dry needling or trigger point release. So this is how you approach the subscapularis. You abduct it as much as possible and laterally displace the scapula by pulling it gently out, and you can palpate the lateral border of your scapula. I'm just making it easy by marking it. And then the thoracic cage, that is the ribs. There is the muscle. On the ventral aspect of your scapula, you will have the muscle. You can dig deep a little bit. It will be very tender to palpate. If the person has pain or anything, try and palpate, and you can use MFR techniques like kneading or trigger point release, or if you want, you can use dry needling also to release it. So these are some of the exercises. This is a scapular clock exercise. This is very, very important to mobilize your scapula as well as activate all your scapular muscles. This is protraction, retraction, elevation, depression, and your scapular clock rotation. Yeah, I'm done. And these are few simple exercises, PNF exercises, D1, D2, which activates your subscaps. Simple ones. Though it is very simple, we actually miss it while we, this is the last slide, ma'am. The take-home message for today is follow regular customized rehab protocols in consultation with your surgeon always, because the surgeon knows what he has done in the operation theatre. Don't go by the book. Always have an open channel with the surgeon. Talk to him, discuss with him what you are planning to do, and never forget to integrate trunk, hips and legs during shoulder rehab. Preserve the latissimus dorsi flexibility intact all the time, and never forget to release and activate subscapularis. Thank you. Any questions?
Check. Thank you, Dr. David, for that very informative session. Hearty congratulations to you. You have very innovatively explained the missing components of the shoulder rehabilitation, right from making us understand the dynamics of lower limb muscles being the foundation of shoulder complex. The forum is now open for questions for the audience. I request any questions from the audience to please put it forward.
No questions.
Thank you. Thank you so much.
Thank you, guys. Thank you for sitting and hearing me now.
I request the chairperson to present a token of appreciation to our speaker. I request Dr. S. Padmakumar, Professor, Yanapaya Physiotherapy College, to hand over the token of appreciation to the chairperson and moderator of the session. I would now like to call upon Dr. Nigat to come forward and continue the sessions for the rest, which are about 3 sessions which are pending. This is Professor Smita signing off for the day.
A very pleasant and calm afternoon to one and all present here. Myself, Nigat Fatima, Associate Professor in Apaya Physiotherapy College, Mangalore. So I would like to request the next chairperson, Dr. Vijaya Krishna Kumar, Principal, Dr. Ambedkar College of Physiotherapy, Bangalore, and the moderator, Dr. Sajjad A.R. Ibrahim, Associate Professor, Enapaya Physiotherapy College, Mangalore, onto the stage. I am also very delighted to welcome the speaker of the session, Dr. R. Vasantan, Professor and Principal, the Oxford College of Physiotherapy, Bangalore, for his topic, Contemporary Motor Control Perspectives of Synergy and Dyssynergy in Stroke. Welcome you, sir.
Good afternoon, one and all. So the next session for the day is from Professor R. Vasantan. With a vast 22 years of experience in the field of teaching, Sir is currently serving as a principal at the Oxford College of Physiotherapy, Bangalore. He is a co-author of the book Stroke Rehabilitation, a functional activity-based approach, and is a co-founding member of the Center for Evidence-Based Neurorehabilitation. He was a stroke expert panel member and Indian collaborator in the Global Burden of Disease project. He has presented his research works in Canada and the UK. He is currently working on his research titled Application of Behavior Change, Principles to Promote Upper Extremity Use in Stroke Patients. He has been an invited speaker in multiple workshops, and he is a resource person for multiple topics such as functional task-oriented stroke rehabilitation and evidence-based practice. He has conducted his workshops all over India. Around 25 workshops he has already been conducting, and over to you, sir.
Thank you so much for inviting me. It's not reflecting there. I'd like to take this opportunity to thank the organizers of Mangalore Physiocon for inviting me to give this talk. So we are going to look into synergy and dyssynergy in stroke. So I hope all of you are very familiar with the concept of synergy, and it has been there for a very long time with us, and we have been trying and spending energy in relieving patients of the abnormal synergy patterns. Right? So today we are going to slightly take a different look on it. First I'll be talking about the older perspective, and then I'll move on to what is the newer perspective. So in the older perspective, that is how we see it is synergy is a group activation of muscles, and we do have different types of synergy in stroke patients. We all know that we have a flexor synergy pattern where the patient, whenever he tries to perform an activity, his upper limb goes on to a flexion, or sometimes it might also go into extension, but in the lower limb we have a extensor synergy where all the lower limb muscles are stiff and they are going to remain stiff, and all the joints are into extension. Now the characteristic of this particular synergy pattern is that the movements are very stereotypical. So each and every time we try to perform a particular activity, it always goes into one particular pattern. And the patient tries hard to do all the activities by using this one particular pattern. And recovery in our neurophysiotherapy is considered as we have to take the patient out of this abnormal synergy and into a normal synergistic pattern. So there are some problems when we try to approach the patient in this particular way. So what we do is, say for example, if our upper limb is going to a flexion synergy, we try to pull it out. So we try to correct the flexor movement in the fingers. We try to develop an extensor pattern. We try to reduce spasticity and tightness in the arm, and we also provide splinting in order to accomplish this. But during this particular time, majority of our energy and time goes in treating this one single particular problem in upper limb. However, this is a huge opportunity cost which we are missing in giving the right treatment. Now, part of the treatment becomes passive. We give stretching and splinting, and part of the treatment is directed towards giving them musculoskeletal type of exercises where we ask them to reach out to in different directions. We ask them to try extending the wrist, opening the fingers, which are all part of musculoskeletal treatment strategies. Right? Now, given that this is what we do, has this treatment proven effective in achieving the goal, that is trying to build a normal movement pattern? So the training which people try is called as restitution of the function of the brain, which is trying to regain the normal pattern of movement from the abnormal pattern of movement. And what is the result of studies which have tried approaching the upper limb with this particular perspective? We have 3 different forms of training. The first one is training to improve the synergy pattern. So a lot of exercises like Bobat, Brunstrom have been used in order to improve the synergy pattern. And these treatments have been found to improve the synergy pattern, but not necessarily the functions. Second is training to improve the function by addressing the synergies. Now, this particular approach of trying to improve the function through addressing synergies has been proven to be less effective in improving the functions, but rather better in addressing the synergies. The last approach at the current point of time we take is to improve the functions. Now, this particular approach has been very helpful in improving function, but unfortunately it might not change the synergy pattern what is there. Right? So in summary, if you look at all the current approaches which are there to rehabilitate the upper limb out of the synergy, can either fall into 2 categories. Category number 1 is trying to take the patient out of the abnormal synergy and into a normal synergy. And category 2 is to ignore the abnormal synergy and start training the function irrespective of whatever way the movement goes on. That's how the treatment has been. So that's the story so far. And so let's look into what are some of the newer perspectives that have come out of synergy, and do we have an option to intervene at a very different level than what we have been doing till on. Now, according to the latest motor control perspectives, we have that synergy is coordination of multiple elemental variables in varied combinations to stabilize a particular functional task performance variable. So there are 3 components in this which is very important. Number 1 is the function. That is, any synergy comes in order to help a person in performing a function. Second is, it is brought about by combination of multiple variables which are called as elemental variables. And finally, all the elemental variables come together in order to achieve one particular thing which is called as a performance variable. Now, I'll try to explain it with some examples, but before that, what is the major characteristics of this synergy is, number 1, it is task dependent. That is, it is related to the function that we are performing. Second one is sharing, which is numerous elemental variables come together to contribute to it. Unlike the previous one where we thought only a few components are there, there are multiple components which seem to be there. And the last characteristic is the flexibility and stability. That is, the elemental variables are very flexible and the performance variables are very stable. So let's look into what is this one by one. First is a functional goal. So we know that any function which is being performed is brought about by interaction between 3 things. One is the task that the person is performing. Second one is the environment in which the task is being performed. And third is the person who is performing it. For example, if you have to drink water, then the goal of it is to see to that the water is being emptied into the mouth without spilling. So lifting the task is to lift the glass to the mouth. And the environment here is a glass and the content, right? Now the same thing, if you look for, say, writing. Whenever we write, it is very important that the person who is reading it should understand it, so there should be a legibility in writing. So the environment here is the paper and pen, and the task is to move the pen in different directions. So now we see here a clear difference between what we previously thought was a synergy and what is this. In the previous synergy, irrespective of any activity, it is flexion and extension synergy. But here we see that for different tasks, there are different goals. Okay, right? So now let's come to what are the multiple elements that might be helping in order to accomplish this goal. Now say for example, I'll come again with the same example of lifting a glass of water. So when you try to lift it, the major work here is the center of mass of the object is there and the gravity is pulling it. So in order to lift it, the fingers which are crossing it should be pulling it in the upward direction. So you can see the 4 fingers and the thumb pulling it in the upward direction, so it is stabilizing, and that's why you're able to lift it. Now this is called as a kinetic synergy because it's related to force, and the total force generated by the fingers and the thumb should be more than the mass and the gravity exerted by the object on the hand, right? So this lift force can be brought about by elbow or the grip force. By gripping it more, you can stabilize more force. Now, not only this, there is also a kinematic synergy. So if you look into it, the center of mass of the object is here, and look at the position of the fingers. Now if you see here, the position of the fingers are like this, and if you can try to connect this, you can see that the center of mass is located at the exact center, and all the fingers are enclosing that center of mass. It is something like you are standing and your center of gravity is below you, and both the feet are trying to enclose it, right? So there is a kinematic synergy with the center of mass within the space of enclosure, within the space of enclosure. So we see that there is a kinetic synergy and kinematic synergy, which is coming together in order to lift the glass. Now, we did a small experiment in order to see, right, how does the force coordinate with each other when we are trying to lift different kinds of glasses. So we took 4 different glasses, very lightweight to heavyweight, and then we saw how much force they are exerting through the fingers. And you can see on the left side the graph which shows that for the lighter one, a very less compression force was used, and as the weight of the object increased, you can see that the force also started increasing. So this clearly tells us that the forces are coordinating in order to achieve the purpose and make the person successful in a task. Now, if you look at the kinematic synergies again, you see here, this person is holding the glass and with the 4 fingers. So what is happening over here is the thumb is exerting a force in one direction and all the other 4 fingers are exerting in the opposite direction. So this is a pentapod grip. But the same activity can also be accomplished by a tripod grasp, something like that, where the 2 fingers are not contributing, and also sometimes by a bipod grasp. Now this is what we call as kinematic synergy. That is, there are multiple synergies which are there, and the patient can use any of these synergies in order to accomplish the task goal, right? So a second example is of writing. For example, if you need to write a letter A, then we should be capable of moving the fingers in different direction. For example, for the letter A, we have to move up and then down and then a lateral stroke. Similarly, for the letter B, we use all these different types of strokes. So what are the kinematic synergies which are there in writing these letters in order to bring out a beautiful handwriting? Okay, right? So here I have a video of a person performing the same activity, but in 2 different ways. The first one is they are trying to write it using the normal method in which we write. Okay, right? And what we have done is we asked the same person to write it in a different way, where we ask them to just hold the fingers without any finger movement. You need to write it, right? And to our surprise, the person was able to write it even without any of the movement fingers. Okay, right? So we see that it's not just the fingers which help in writing. You can see that the different components are helping. So what we did was, we took the kinematic position graph of the fingers as well as the elbow, and we plotted it. And you can see that in the first task where the person was asked to write it, you can see that the two graphs of the finger and the elbow moving in different directions. But when the person is trying to write without moving the fingers, you can see that the movement of the pen, which is given in blue, and the movement of the wrist, both of it is having a very, very close relationship. So we identify that the brain uses different strategies, not just what we are aware of and what we think of, and all these are called as the strategies which the brain uses. So coming to the next part of the definition, I said that when you tell about a synergy, it is combination of multiple elemental variables which come together. So what we know is, if you have to drink a glass of water and you have to lift it, you do have two synergies, kinetic and kinematic, which we saw previously. And if you need to write, or the person has to move the pen around the paper, you do have different kinematic synergies, which we saw in the previous slides. Okay, right? Clear? Now, how does the brain organize all of this? The brain, what it does is it tries to stabilize a particular performance variable. Performance variable is the one which leads to success in that. That is, if you are trying to lift a glass of water, then the water should not spill and you should be able to take it, right? So this is the goal of it. And it is not that it will use only the fingers. It could use the fingers, it could use the wrist, it could use the elbow, it could use the shoulder, and it could perform it in n number of ways. So there is a lot of flexibility among elemental variables. So what we did was, we did a second experiment where we asked multiple people to perform two activities. One is lift a glass of water using we closed the bottle and then we gave them. Second one was, we filled the second glass up to the rim and we asked them to lift it and place it. Now, what we did was, we asked them, we did not tell them this is the way you need to take it. We kept it open and you can do it in any particular way. So what we see here is graph. It might not be very clear, but what we saw was where were the persons holding the glass while they were lifting when you had a bottle closed, and where were you holding when there was a liquid which might spill even if you tilt a little bit. And we plotted the graph around the glass, and we found out what is the spread of the fingers when they were doing multiple attempts. And what we saw was, you can see here, for the closed bottle, all the fingers, that is from the thumb to the little finger, they all have been moving in different directions and in different places. So you see that the magnitude of spread of the fingers is big and the variation is very high. But when you have to take it without spilling the water, you see that all of the people who have done it during multiple times, they all try to hold in one specific position very tightly. So we see that the performance variable, which is holding the water and without spilling it, all the elemental variables are working very tightly. So from this new perspective, we start understanding that synergy is nothing but a coordination of multiple variables in order to help you in achieving some goal. And the characteristics of it is functional, so it's different from activity to activity, and it coordinates not only the muscles but different forces across your arm. And there is one component which the brain is trying to stabilize, and this is what we need to understand. And multiple methods are there, or multiple strategies are there in order to achieve this performance variable. So in future, when we are looking into people and when we are trying to look at what synergies they have, we should not look into whether they are having a flexion synergy and try to extend it, but we need to try and explore what are the different synergies which could be there for different activity. And at the current point of time, there is very less research in this area, and we are really not aware of what are the performance variables that the brain is trying to control. So with that, I would like to conclude my speech. Thank you for giving me the opportunity. I also would like to specifically mention a few of my students who have helped me in coming out with this, in testing these ideas. So I thank Ratipriya and Sweta and Subiksha for this. Thank you.
Thank you, sir. Thank you for your wonderful presentations. It was one of the important, like in stroke recovery patients, it was very important for like synergies actually. Anyway, any questions? Thank you, sir.
So it was indeed an informative session. So now I request the chairperson and the moderator to hand over a token of appreciation to our speaker, Dr. R. Vasantan. Now I would like to invite the chairperson for next session, that is Dr. Vinod Babu, Principal, Gautam College of Physiotherapy, Bangalore, and the moderator for the session, Dr. K. Narsinga Rao, Principal, St. John's College of Physiotherapy, Bangalore, BOS member of RGOHS. On to the stage. The speaker of the session is Dr. K. Ganeshan, HOD, Department of Physiotherapy and Sports Rehabilitation, Orthopedic Specialty Center, Coimbatore, for its topic, Quadriceps, Textbook to Clinical Practice. I welcome you, sir.
Very good afternoon, one and all. The next session speaker is Mr. Ganeshan, who is a highly experienced sports physiotherapist with over 20 years of experience in the field. He holds certifications as an instructor in pilates and kinesiology taping, and he has conducted numerous courses both in India as well as in abroad. He is the founder and lead instructor of Movement Solutions. Currently, he serves as the head of the Department of Physiotherapy and Sports Rehabilitation at Abhinav Bindra Targeting Performance and Ortho 1, an orthopedic specialty center in Coimbatore. So his work is under the guidance of Dr. David V. Rajan, a pioneer in knee and shoulder arthroscopy. He has contributed to the sports world as a team physiotherapist for the Chennai Cheetahs in the World Series hockey and has been associated with I-League football through Chennai City Football Club. Additionally, he served as a board member for the Department of Sports Science at Ramachandra Medical College. In summary, Ganeshan is a seasoned sports physiotherapist, certified instructor, and educator with a vast wealth of experience both nationally and internationally. I welcome you, sir.
Thank you.
Over to you.
Check. Thank you. Good afternoon, everyone. My talk is going to be more on the clinical aspect, so I'm just going to quickly run it. I'll have few pictures and videos of patients. So if you miss it, you're going to not understand the next subsequent ones. So that's my team. The current place where I work, it's a small setup which we call ourselves as a super specialty center, which is primarily focused on arthroscopy surgeries. And that's my work initially with the hockey team in the World Series hockey. And it was a proud moment for me to be inducted in the European body for the kinesiology taping as the first participant and instructor. And this is with the kinetic chains to work with Thomas Myers. And I had the privilege to be visiting Qatar, the FIFA accredited football center, where I was invited to give a lecture to the physios over there. And this is my association with the I-League Football Club. And I run a company called Movement Solutions, where we do teaching and upgradation of physiotherapy department in various hospitals and clinical setups. So coming on to my talk, from quadriceps textbook to clinical practice. So quadriceps, everybody knows some of the exercises and clinically what we do. So looking at the knee joint as such, it is one of the commonest joint which is going to have problems, and athletic population are going to have at least 50% of the athletes will have some knee pain in some form. So if you go by the knee joint by location, this is how you can locate what clinical diagnosis you can have, depending upon whether it is going to be anterior based, medial based, lateral based and posterior. So these are the clinical common conditions you will find in the textbooks, which will have various implications. So whenever you have any of these implications, you will have to address the quadriceps. So quadriceps, we all know it's 4 muscles. The rectus femoris is alone the 2 joint muscle which comes from above the hip joint. Rest of all the quadriceps are a single joint muscle, primarily having a good capacity of liver 2. Now coming on to the quadriceps in functional relationship, you're going to have to look from the structural aspect. So whenever you have quadriceps deficiency, please look at the lumbar spine starting from L1 to L5. Then look for the altered lumbopelvic hip complex. So they might have not be able to do a pelvic tilt, or they might be able to have a hiking of the pelvis. Then look for unilateral flat feet and then foot pronation. So both are 2 different things, so look for them. And in functional, look what kind of a long standing they do, whether their weight bearing is more shifted posterior or anterior or lateral. Then look at the way they do the stair climbing. You will find a lot of the people, when they climb up the stair, they will be bending forward. So that is a hip dominant climbing. And then if they are involved with jumping sports, look at the jumping methodology they follow. Arthrogenic muscle inhibition. Quadriceps has got something called as arthrogenic muscle inhibition. This is where the quadriceps muscle just shuts off. It is not able to recruit. Now various reasons are neural inhibition, resting motor threshold, or altered spinal reflexes. Now these can be in various conditions of patients, in both conservative and as well as in post-surgical. Now these are studies where they indicate that a person who goes an arthroscopy or an arthroplasty, where they do a knee replacement or an ACL surgery or a meniscus surgery, tend to have deficit in the quadriceps muscle strength even up to 6 months to 1 year. And one of the problem can also be the effect of tourniquet. So these days surgeons are very particular that the duration of the tourniquet is going to go lesser so that they can prevent this. Then what kind of a block they use? For surgery they will use a nerve block. It could be a femoral block or an adductor block, and based on that also you will find that the initial recovery of the quadriceps is very poor. This is called as the quadriceps activation battery. Now this can be also used as one of the research topic if anybody is interested. Now how do you check whether the quadriceps is actually functioning? You can take 3 different points over here. So the first thing is whether the person is able to do an isometric quadriceps contraction, which is visibly you are able to see. The next one is whether the patient is able to do a straight leg raise. Now if you see here, there is a slight bend on the first video, so that will not be acceptable. It has to be a straight one. Then comes your quadriceps extension. If the person is able to sit and then do a full complete extension without a leg, then it is a proper activation of the quadriceps. You could do a scoring for them, giving points, and then you can see which are the components it is actually improving. Now this is clinically used for us for all the patients who are doing their lower limb injuries, whether it is conservative or post-operative. Now how can you manage this arthrogenic muscle inhibition? One is cryotherapy. What I am using here is a game ready. Now you can use a simple ice pack which is applied for about 10 minutes, and then you ask the patient to do an SLR, they will be able to do. The physiology behind is that the pain will suppress the pain and it is going to inhibit the pain receptors, which will immediately allow the motor component to recruit. The second one is you can use a muscle stimulator where the muscle firing pattern is less. So you use a muscle stimulator and then get the muscles back into action. The third one is again tense. This can be used just to inhibit the pain, and then you will be able to get the muscle back into action. Now all 3 methods have been proven and various papers done to show that it works on different people. So in clinical practice, what we have been able to see is that we have to identify the patient who suits what. I cannot be giving cryo, TENS and stimulation to all the patient. So you will be able to select which patient fit into which category, and you will be able to do that. So overall, the arthrogenic muscle inhibition is one of the key factors in all knee cases. It has to be identified rather than straight away start strengthening with isometrics. So whenever you have a problem with quadriceps, you will have to look into the patella because they are closely related in function. And the common problem with the inhibition of the quadriceps will be your impingement and the bursal problem involving the Hoffman's pad. Now these are the sensitive structures in the knee which gives pain and allows the inhibition to prolong. Now patella instability is a common problem. Many of the patients or people don't even know they have a patella instability until unless it goes in for a subluxation or dislocation. So you will have to have the Q angle coming into consideration. Now this is a bony landmark. So as a physiotherapist, I will also be looking at the rectus femoris and the quadriceps and the functional line what I earlier mentioned. So you can see this is a patient's patellar dislocation. You can see how much lateral it goes. Now this is a patient who never complained of pain. His only problem is what should I do with my knee? You can see the X-ray over here. Usually we see for the trochlear notch. So if the trochlea is more parallel, then you need to do a surgical revision where you scoop the notch so that it stays in place. Now this patient, the patella just goes out and comes back, no pain. But there is going to be a lot of wear and tear which is going to cause him a problem at a later stage. Okay, isometrics. If you have been giving isometrics where you put a towel underneath your knee and do your isometrics, please, we need to change that. That is not the way you have to do your isometrics. Because when you put a towel underneath, you have already got your knee into a slight flexion. And if you ask them to press it down, you can always use the hamstrings and the gastroc to push it down. If you have a surface EMG, put it on your patient and do that, and you will realize that you're making a mistake by telling them to put a towel underneath and do the isometrics. Now I'm checking for this patient where I do the isometrics in both supine and in standing. And you will be able to see in this video what the patients were able to. You can see that the quadriceps, the patella easily glides laterally. there is no straight or no medialization. That means this patient's more and more lateral component is overfiring on the quadriceps. You can see in standing also how much you can see that the lateralization of the patella goes on. This is atrophy. This is atrophy in 1 month time for this patient. And you can see we are trying to get the contraction, and you will be able to see that it is more of the lateral component contracting rather than the medial component. And this is the patient, we are putting him on standing. Once the patient is allowed to do full weight bearing, I'm checking whether he can maintain the quadriceps. You can see here that there is a lag, and you can see that the leg tends to go forward. His quadriceps is not able to control it. So there is recruitment but no control. And this is walking with an FFD. Now fixed flexion deformity is a deformity. Extension lag will also be like an FFD. Only by clinically examining the end range you will be able to determine whether it is an FFD which needs more stretching or it needs more quadriceps contraction. And if you don't correct the gait with an FFD, it is going to start putting load on the patellar tendon, ACL graft, your meniscus and anterior knee pain. So this is an MRI of a patient who has quadriceps atrophy. This guy had a very bad injury long back, 10-15 years back, and you can see in the MRI anteriorly there is no muscle mass. Whatever you see posterior is the hamstring, there is no muscle mass. This guy is able to walk purely by using the fascia and the connective tissue what is available. This is a rectus femoris tear on an athlete. Now when they have a tear and you can see there is a bump over here, the patient has got fear that what if the tear becomes big. No, all we had to do was initially control the pain by ice, and then we just started back him on strengthening exercise. And you can see he can do all functional activity. And if you see rectus femoris, if you get the muscle functioning back at high capacity, it is not going to further tear. Taping can help in some cases of tracking or manipulating the patella, but not in the video where I showed there was so much of lateralization. So the kinesiology taping will be used to also stimulate the muscle to have better function. Knee braces, they can be used intermittently on selective patients. So if you are using something like a prophylactic knee braces, that can be used only during an event to help them prevent injuries. Functional braces, not major good studies, and they have limitations in their flexibility and they allowing the full range of motion. And if you see, most of the braces tend to inhibit the quadriceps function. You will find patients telling, if I put the kneecap, I feel better. It's only a proprioceptive factor and it will allow the quadriceps to inhibit. Assessment methods, you can do any of the scores or the assessment methods, the VAS score, flexibility by goniometer for the range of motion, look for patella alignment using an X-ray or a caliper. Motor function, there are many tests. Step down test is one. You can do a star extrusion test. You can do a Kujala scoring. Muscle activity, manual muscle testing, electromyography and isokinetic. What we use in my department is a manual muscle testing and isokinetic testing. So this is a isokinetic testing. It's not visible here, but you can see over here we have flexion and extension deficit. So when we have the person measure, a lot of the people pain is because the quadriceps is less efficient. So the muscle is less efficient, it is put on work, it provokes pain. So coming on to exercise, your quadriceps exercise has to be based on what you want to achieve. For pain management you want to do, or you're going to get the quadriceps back into activation, you want to restore the range of motion of the knee joint, then look for any altered pattern like how we saw on the patella. Then whether you want to improve the strength for rehab or you want to improve the strength for fitness, and then you are going to look for sports specific or functional specific. Before you start the quadriceps or the knee exercises, please go back and revise your primary function of each muscles. Understand whether it's a one joint muscle or a two joint muscle, range of motion, what is the nerve supply and what is the amount of pain the patient already has, and in what position you want to start, whether it's going to be supine, whether it's going to be prone, or in standing and sitting. Okay, so coming on to pain and exercise, you can use the scale over here to understand what is your pain and what is your exercise benefit. Now, if you see on the scale, it clearly says if you are going to improve the strength, it has to be from moderate to extremely hard. Only if you do at that level, you are going to get any improvement. Putting a sandbag of 1 kg on your quadriceps and asking them to do leg extension is not going to yield anything. So, if you have patients who has a pain score of maybe 5 and 6, please still exercise. It is still safe. And if you want to exercise for the benefits of the zone, this is the zone you need to do. So up to 7, 8, you need to make them do exercise even if they have pain. And if you're going to do strengthening exercises, stick to initial 8 repetitions for strength. Only if you are going for long-term sports, then you need 15 repetitions. And please never induce motor fatigue. If the patient is able to do only 5 repetitions, stick to 5 repetitions. Now these are quadriceps activation using a muscle stimulator directly or as an open kinematic. If you want to work on the VMO specific, please induce the adductors also because of the vectors that is associated with the VMO. Posterior capsular stretch inhibits the quadriceps. So get the calf stretch and the posterior capsular stretch before going on to the quadriceps. Open kinematic, close kinematic. On any rehab, please start with the open kinematic because that is the one that is going to give you strength. Close kinematic is only functional and has co-contraction. Ultimately, when you do a testing for a patient, it is going to be open kinematic testing. So no matter if somebody says I can do 140 kgs of deadlift, if he can't do 20 kgs of leg extension, it is of no use. So these are leg presses studies which have shown that how much they are able to help on the quadriceps. I'm going to skip them. This is another way to do the close kinematic quadriceps where you just put them. Instead of doing the isometrics in supine lying, please do them in standing. That is more functional. Progress squatting, because it's a functional one, supported. It has, every squat is just not quadriceps alone. There is a amount of gluteus muscle that is involved. This is squats in supported in various methods. I'm using a chair and a supporter with a TRX. And the tape is done to help on the pain. And this is progression of the squats. Every time somebody is able to do a squat, please put them on a unstable surface and induce neuromuscular balance because that is going to again functionally help them. Open kinematic. This is rectus femoris specific. You can see the person is lying down, so I get the hip into complete extension. This will specifically target the rectus femoris, but the load is going to be less. If I put high load, then it is going to use the other quadriceps muscle. This is using the resistance band. I'm using here short lever, progressing it to below knee and long lever. The same thing can be done with the gym machine. So the take-home message is educate the patient on your plan. So that means every therapist, before you treat, you should have your plan ready for the patient and then educate them what you're going to do. Assess periodically the foot, the knee and the core. Look for the orthogenic muscle inhibition in quadriceps in all lower limb cases. Individual muscle first and then progress to functional. Activate the muscle first and then go into strengthening. Knee braces has its limitation. Exercise is the primary one and work on both open kinematic and close kinematic. Thank you.
Thank you, Dr. Ganesh, for your excellent and knowledgeable session about quadriceps. So any questions from the audience? As usual, I think no questions may come across. I have one question to the audience as well as one question to Dr. Ganesh. Yes, audience, delegates, all of you are attentive here. How many of you are having patellar pain or patellar stuck or patellar symptom? Even budding physios also may be having this issue. Because this patellar symptom itself will cause you lazy to get up from bed, get up from chair or even move around. Can you raise your hand? How many of you have some kind of small issues related to the patella? Please, all of you. Everyone, please pay attention here. The question is to the audience from our side. How many of you may have some issue with your patella? like pain, stocking, or uneasiness in moving. There are few of them are responding. Dr. Ganesh, I have a question to you.
Yes, sir.
So we may come across this kind of symptoms, popping off or stocking of patella, which we see even in normal individuals, not on patients who are post-injury or post-fracture. Even though the normal individuals who having the full range of motion as well as quadriceps flexibility is in good condition, still some normal individuals, they feel popping off or stocking of patella. What could be your inputs in relation to the quadriceps?
People who say I have a sound coming on my knee, that's a common thing,
Yeah.
which either they put it as popping or cracking or sound. Okay, it is not at all a problem. It's only a problem because of fear. Any crepitus or sound that is coming from the knee flexion extension is normal. Some people will have sound where the patient will only hear. Some patients sound only when you put your hand you will hear. For some people, when you stand nearby you will hear. Just assure the patient that sound is not a problem. It is just a increased sensitivity that the patient is able to hear. And he is always focusing over there, he keeps hearing them. If you hear it, you tell them, yes, I am able to hear it. It is just the gliding of the structures. Maybe there is less water content around them. There is more fibrosis. Assure them it is nothing there. Please don't go and try to say, I will release this one, I will do that. Sometimes 3 months down the line, they just settle. Tell them only if it comes with pain, then you address it. Even if it pains, there is no relation between the sound and the pain. These all are proven. Only thing is it is fear, and we try to see and correct something which is nothing in our control. So nothing to worry with that.
Excellent answer, sir. Thank you very much for your excellent inputs.
Thank you.
Please, all of you, give a big round of applause to Mr. Ganesh. He is the one who gave us a big changes, what we are supposed to care for knee in considering the quadriceps, which you may commonly come across only giving isometrics or isotonic exercises. There are various other options he has given us with evidence. Thank you very much, sir, for being here today and giving a great knowledge here to all of us.
Thank you.
It was an insightful explanation by the speaker. Now I call upon the chairperson and moderator to hand over the token of appreciation to our speaker, Dr. K. Ganeshan. And I'm also glad to invite Dr. R. Vasanthan, that is Professor and Principal, Oxford College of Physiotherapy, Bangalore, to hand over the token of appreciation to the chairperson and the moderator. Thank you, sir. So I would like to request the next chairperson, Dr. Vijay Samuel Raj, HOD the Department of Sports Science and Associate Professor, JSS College of Physiotherapy, Mysore, and the moderator for the session, Dr. Vinod Kumar KC, Professor, College of Physiotherapy and Dayanand Sagar University, Bangalore, onto the stage. And the speaker of the session is Dr. M. Vijay Kumar, Professor, Sports Physiotherapy, Dr. D.Y. Patil College of Physiotherapy, Pune, Maharashtra, for the topic Functional Evaluation for Lower Limb, What, When and Why. I welcome you, sir.
Good afternoon, one and all. It's my immense pleasure to introduce the next session by Dr. M. Vijay Kumar. Dr. M. Vijay Kumar is an highly qualified and experienced professional in the field of physiotherapy. He holds a bachelor degree of physiotherapy from Dr. MGR Medical University, Chennai, and master degree in sports physiotherapy from Alagappa University. His impressive list of qualification includes a fellowship diploma in sports medicine rehabilitation from London Academy of Sports and Health Sciences, as well as postgraduate diploma in field sports injury and rehabilitation and fitness and wellness management from Tamil Nadu Physical Education and Sports University, Chennai. Currently pursuing his PhD at Dr. D.Y. Patil Vidyapeeth, Pimpri, Pune. Sir Dr. Vijay Kumar, extensive experience spans over 24 years with over 22 years of academic experience. Post-graduation studies. In summary, Dr. M. Vijay Kumar is highly accomplished physiotherapist and educator with a strong academic and research background, as well as a significant experience leadership roles within his field of physiotherapy. It's over to you, sir.
Yeah. Thank you, sir. So, at the outset, I'd like to extend my sincere thanks to the organizing committee of Physicon-2023. Let me take another 20 more minutes from your side for a small presentation on functional evaluation of lower limb in sports, what, when and why. Yeah, most of us are aware that there is an injury. When you have an injury, definitely you have a medical management, and these days things are getting changed. We go with the surgical management. We go with the physiotherapy management by and large as the first context, and we have a functional rehabilitation going back to the activities of daily livings, and by and large, our rehabilitation stops over here. As soon as you receive or you reach your ADL qualities, you reach your functional qualities of your daily livings, you stop it up, and there are few incidences where we go in for advanced life or advanced management and sports management. And to be very frank enough and say, we have been successfully doing the sports rehabilitation for the past almost 1.5 decades, very strongly enough. This advanced life on sports after lower limb surgeries or an injury is been successful because of one group of people, that's we as physios or we as sports physios. Gone are those days, decades back, 2 decades back, where everything is being handled by a physician or a surgeon or exercise physiologist, or probably a coach who takes care of everything. Now the exercise physiologists, fitness trainers and physical therapists has come down to play, wherein they have made unprecedented challenges and heights of successes in sports. But however, the secret of success is always on 4 categories. 1, it is always a consistent and continuous work of a physical therapist, a graded assessment and a graded management protocol, a quantitative evaluation to find out any minimal changes that is found to be existing in the individual's prognosis, and by default, everything is taken care by a functional assessment and a functional training. So functional assessment and functional training is proven to be a most important and component of a rehabilitation in sports, getting him back. So in the early 80s, it was clinical testing and probably a strength power testing, which is usually being taken care by physicians and coaches. And the early 2000s, exercise physiologists came down to play, clinicians came down to play, and physios came to play, wherein physios weren't having so much of
consistent and context of work to encourage or to increase the quality of or potential output of a sportsman. But in the last 15 years, where from 2008-9 and till now, for the past 15 years, physios are dominating those areas of finding out an individual, how fit he is, whether he is fit enough to get back to the sports, if not, whether he can be trained on what grounds and what is the lacunae for them. So functional assessment has got various definitions to be taken for, but almost for the past 1.5 months I was searching down for what is an apt definition for a functional assessment means. Unfortunately, I could not find that is going to be very convincing for me on to say what actually could be called as functional assessment is. So I tried to frame something like this. It's a quantitative measure of integrated movements. So it's a quantitative measure of an integrated movement, not of one single movement, it's integrated movement, including your range of motion, strength, stability, balance, speed, agility, power and endurance, also including a stress and shear loads of a joint, which is being usually missed out by physicians and clinicians and surgeons, and associated with as a whole through mental readiness. That's what probably I could gather up information to coin it as a proper definition to an extent from my side to be called as a functional assessment. Right. So when you go for functional assessment, what is literature was telling us quite back. Almost 2 decades back, literature was saying that if you have an injury, if you have a surgery, go back to your sports, and it found that more than half the injuries are not being treated well, and more than half of them would not get back to the sports. That was very poor performances. And the research is saying that your strength of an individual, even when you have an injury, you may have a strength, you may have an improvement in your control, you may have an improvement in your eccentric or concentric control, whatever you may have individually improved your balance, individually improved your stability, individually as a segment improved in the other components, but by and large, even if you are segmentally improving them, unless you are combining them to get them into its function, things are not going to work. It's proved. And naturally, this area came down to picture. What could be done to check as a holistic component? So they added up something called as functional testing, where you test the function, multiple components, wherein you combine strength and speed, combine strength and agility, combine strength and change of directions, where you go for a combination of multiple components so that you can find whether he fits into that, and depending upon that particular score he is going to get, he can be taken back to the sports or not. So functional testing is gaining a lot of importance and impact on your return to sports guidelines and categories. And naturally, that's what it says. To be very surprised to say, thanks to Ganeshan sir, who was giving a prelude on what it's going to be when it comes down to your rehabilitations. This says, even after 6 months or 9 months of a follow-up following ACL rehabilitation, mind it, 6 months or 9 months also following ACL rehabilitation, there is hardly 3.2% of people who are able to get back to the normal levels of sports of your strength and endurance or your functional categories, and only 11.3% of your patients or a sportsman could get back to your functional quality in 9 months of rehabilitation. And we all say, textbook says, till 9 months you had to rehabilitate, get him back to the sports after 6 or after 9 months. But research tells us, even after 9 months, only 11.2% of people are able to get back to your level of functional and quality of status. And following a 3 years period of follow-up by various researchers from abroad, they found that 65 to 79% of people could return to the previous injuries. However, 12 to 23% of people had to quit. It means almost 1/4 of your individuals who are involving into injuries are quitting the sports. Imagine, if sports is a career to somebody and 25% of them are going to quit of the career, that's a huge loss for the individual. And only 45 to 55% of people could demonstrate more than 90% of your hop test and other functional tests, and only around 50% of people could able to demonstrate the peak strength of your quads and probably your hamstrings. So, what all we rehabilitate, it's found to be insufficient even till 3rd year of a rehabilitation. So something is wrong. We are rehabilitating for almost 3 months, 6 months, 9 months, year and 3 years, and still it is found to be insufficient for the sportsman to get back to the sports and play to that previous level of pre-injury status. So what's wrong over there? That's what it's a question over here. So looking down for the scenario of a status of meta-analysis, it found that almost studies related to your functional rehabilitation is found to be looking for around 3,200 odd studies. Only around 11, okay, and 8 articles are found to be showing full qualified quantitative data on how it can be rehabilitated properly for getting him back to the sports at the end of 9 or 1 year or 3 years. That says that how weak the literature is for us. And we are talking about evidence-based practices in these days, and this is what evidence we have. Out of 3,000 odd articles, we have only 8 articles saying that, giving us full information that's required for further rehabilitative processes for the individuals. So the literature is still very low and it's very poor. But still, we are clearing them to get back to the sports. Injury happens, the fellow goes back to the sports. Still we are clearing them. And they don't perform well, and if they perform, if something happens, who is responsible for it? By and large, is the physios or the coaches or we who are working with the team or being found to be held responsible. Say like, how did you give them the clearance when he's not able to play out well? So the physios or the physicians or the coaches are being held responsible for it. So what is the problem is? So looking for what could be wrong. Could be a wrong probably in a rehab, could be a problem in rehab in assessment, could be a problem in your functional assessments, could be a failure in your advanced assessment or a management, could be a problem in your functional assessments, or could be a problem in your return to sports guidelines. There could be so many problems that could be there which has probably not caused the individual to be performing well. Among this problem in the rehab, I don't think it's because the last decade, the last 1 or 2 decades, physios are exuberantly doing a greater job, and rehab has been giving us a fantastic outcome. So rehab is by and large, it can be considered as one of the major criteria that could be limiting him for going back to the sports. Probably not the functional assessments. I think probably it's the reassessment. How often do we reassess the individual on the functional categories, on how to interpret them, and do we are in the finding out an option if the score of functional rehabilitation assessment is found to be less, what is going wrong, where it is going wrong, how much it is going wrong, which particular muscle is found to be not functioning well, which particular group is not supporting him well, whether your control for eccentric or concentric is properly happening or not, whether your firing mechanical sequence is happening or not, whether your proprioception is actually coordinating well within or not, are you having a good joint proprioception or a good joint impact loading component available or not. There are so many components that we missed it up in the rehabilitations of reassessments, and that's where we find that the failure of limitations of advanced and quantitative assessment is one which always finds to be a major important cause why failure in getting back to the sports is always a major cause. And the most important component is this: interpretation and guidance of specific training following your advanced functional evaluation. So all the functional evaluations, I hope all the physios over here will be doing functional evaluation. There is no physios who will say, I don't do a hub test, I don't do an Illinois test, I don't do a T test, I don't do a proprioception test, I don't do the, everybody does it. But after doing that, what do we interpret is the question. The question is, the interpretation has to be perfectly done, and probably we either don't do it or we don't do it perfectly. So ultimately decision making comes down to what to be done. So we need to have a strong clinical assessment which is more functional in nature. We need to have a strong clinical interpretation on those assessment results. That is where is a major area that we are lacking as a gray area is off. We need to have a clarity in assessment guidelines and progression guidelines. Although there are guidelines given for progression for injury and rehabilitation, there are no strong guidelines given for rehabilitation for a sport specific on stage wise and as and when he or she improves into the sports. That's found to be a little lacunae, and definitely there is a lacunae in evidence-based practices. So this is all we do it up. We do a lot of symmetrical power, we do a lot of this, but unfortunately what is it? There's a strong evidence, of course, but the evidence is, the volume is more, but how to use, which test to use, when to use, from whom, how to interpret, and what's the criteria, and what is the deficit guidelines. Now this is a huge lacunae in the literatures. There are a lot of, these are the two commonest scales, the scores available for assessing a functional assessment. They use all these tests, but unfortunately we don't have an interpretation criteria for all those components. So with my experiences and based upon total literature, I have found that probably this could be the criteria that you are looking for before you put them into a test. Most of us take an individual to a T-test, but we just don't find what is the prerequisites. Literature have proved and the experience have proved that if you want to take a T-test, the patient should be able to have 80% limb symmetry index. None of us, I don't think most of us do get it as an important component of your evaluations. The patient should be able to do at least more than 5 kilometers running on a treadmill without losing his balance or losing his step balances. We don't. There has to be 1:1 quadriceps strength and a fantastic strength of eccentric control to be continued throughout your sports, RDS. I don't think we are doing it consistently. At the same for a Illinois test. So the limb symmetry index plays a major important role. But how do you do limb symmetry index? We do it with a hop test. But for a hop test to be doing it, when do we do it? I have seen physios who are doing a hop test at 10th week or 11th week of post-operative ACLs. But is it permitted? Literatures are saying that it is not. It needs at least 12 to 16 weeks of time for a ligament to become a bit of strong, at least 70% of its strength to go in to take up a loading of on a hop. So naturally it has to be done only after 12th to 16th week. It's to be preferred, provided you have 70% of your strength of your normal limb and definitely in 1:1 quadriceps hams ratio, which we usually don't actually give it an importance at all. These are all the guidelines that you have to follow it up, whether you're going to have a single leg hop test or triple hop test or a crossover hop test. So if we follow these guidelines, probably getting him fit for a testing itself is being screened. Then after testing is being done. If at all he is showing some lacunae here and there, we can find where he is going to be lacking off, and accordingly we'll be able to fix up a time. So 2 more minutes I'll be taking it more from your side. For a single leg vertical jump test, of course it is being found that if you are doing a single leg vertical jump test or probably a broad jump test following any ID case, which is below 12 weeks, is not to be done. But we are doing vertical jump test or probably a broad jump test in 8th week and 12th week because the patient says, I'm comfortable, I am good. The patient says, I'm comfortable, I'm good. The sportsman says, I'm fit enough. But is his body, is his joint, is his ligament, is his meniscus fit enough to take up the load, to take up a jump is a question. So naturally it is no, and hence we have to wait and for. We're supposed to be 16 weeks for an ankle fracture to take a vertical jump test. I don't think we wait for it. Okay, so we are not waiting. So rather we are saying we are actually making them to come into your testing protocol well before they are fit enough to come into the testing protocols, and we land on to be a failure, and we just clear them that he is able to do it up, he will improve as days goes by, and naturally the improvement doesn't happen and the failure comes down at the end as a non-performer at the end of the day. We don't. How many of us do one CT SAB and CMTC SAB? Of course it is not at all done because equipmentization is a big important thing, so we don't do it up. So based on all these informations of in search of literatures we identified that this could be a proper or probably a possible guideline to be taken before we put somebody into a functional testing, rather than just blindly taking them for a functional testing after 8, 10 or 12 weeks. Let us follow all these guidelines to the best we could do it up so that our testing becomes perfect, so that you are making sure that the individual is fit enough to come for your testing, and then the testing becomes perfect and the outcome of the testing can be taken further for your informations and management for the protocols. That's about your broad down for your SBTs and SCBTs and YBTs. There are so many things that you are looking for before you go for SCBTs and YBTs. For a grade 1, grade 2 and grade 3 injury, when to go in for your test to be taken up, or probably a yo-yos. So these guidelines, I sincerely feel that we don't strictly follow them before you go for a functional testing to be taken for a patient or a sportsman to be considered, whether he can be taken back or returned to sports could be planned or could be permitted for him. So what is the need is this. We need to have a proper assessment and should be helping us for a proper focus on your specificity in your thing that's going to be lacunae. So the present scenario is there is enormous volume of data available, but the evidence of strength of evidence is low. There's a fair to less evidence of clarity and administration of those particular components. The evaluation of test, the duration of admission, when to administer the particular test, and the cutoff scores, the combined test batteries. We don't have a strong guideline for the combined test of batteries. We need to have a specific rehabilitation outcome for a full, complete functional test is a huge lacunae. Prediction of poor performance is less. That is still to be worked up. And of course, we need to have a perfect combination of batteries of tests to find how and when and what can be done to make sure the individual goes back to the sports. So the feed for everybody is this. We have data, but the data is still not enough. Data is not strong. So I request all the people who are interested in sports or sports physiotherapy, are interested in taking sports as a career in physical therapy. We have a huge arena for this where you can take up a lot of research area on this, when, what, when not, when what should be done, and what will happen if it is being done. If something goes wrong, what has gone wrong, and how it has to be identified, how it has to be probably interpreted, and it can be taken up for guidelines. So with this, I feel and I hope that by 2020, probably we as Indian physios will be able to provide maximum amount of data for the Western world also related to research in sports as concerned. That's all. Thank you very much.
Thank you, Dr. M. Vijayakumar. So it was a wonderful presentation because most of us ignore this with functional assessment. When it comes, we'll concentrate on range of motion alone or just the strength. So it's very important that we need to consider the functional movement. Me being a sports physiotherapist, it's very important part where we need to assess the function. And also the functional training plays a very important role. Rather than training an individual muscle, it's also important to train the function. So right now we'll take up the questions. If audience have a questions, if anyone has a questions, you can just raise your hands. Okay. So, sir, I just have a clarification with functional movement screening and your functional assessment and your strengths. If you could highlight that, I think it will be good for the audience to understand these differences.
Okay, can you repeat me again, please?
The functional movement screening as an evaluation tool.
Fine.
And as well as the functional evaluation.
Fine. So when you say about functional movement screening, we take up a particular movement in per se. Probably if it is going to be a movement of action of throwing, or a movement of action of bending, or a movement of action of hopping, or a movement of any one single movement, we observe it in terms of kinetics and kinematics throughout the movement, starting from the initiation of a movement to the completion of the movement, and we find what is the normality in terms of a kinetics and kinematics, and find what is abnormalities, the angular changes, the peak torque values, and the peak force values. That's why we see it up in our functional screening. And we'll find if there is anything lacunae over there, we say there could be a predictor for you to go into an injury. So functional screening usually gives us information about predictions for injuries. But we come down for functional assessments, it is telling you about your overall capability of multiple components involved into it. A simple, as I said, we take a simple functional assessment as a hop. It tells you about your capability of your readiness mentally, your pain capability, your joint force impact, strength capability of a joint, your concentric muscle force that could be created by your quads, and of course your gluteus maximus, eccentric control of your hamstrings when you're going to land down, again the eccentric control of your quads when you're going to land, and then your stability when you're going to land. Okay, so all these components are involved. So it involves the strength, the stability, proprioception, eccentric and concentric. So this is what is being seen in the functional evaluation. So a functional evaluation is quite vast. It's more than what we think about a functional movement screening as.
Yes. Thank you, sir.
Thank you, sir.
Just to add on, as sir was mentioning, the functional assessment or functional assessment, it's very important that we have to look into symmetry and as well as asymmetry. For example, if you're doing a hop test, it's very important that you look into the symmetry of the knee and ankle and before you proceed further with that. So just to add on, and sir has mentioned about the evidence-based, which is a need. Thank you for highlighting that, sir. Thank you. Thank you.
Truly enlightened with this session, sir. Now I request the chairperson and the moderator of the session to hand over the token of appreciation to our speaker, Dr. M. Vijayakumar. I also request Dr. M. Renuka Devi, Professor and Vice Principal and HOD of the Department of Cardiopulmonary Science, JSS College of Mysore, to come onto the stage to hand over the token of appreciation to the chairperson and moderator of the session. So before the next session, I would request the participants to be seated on place, maintain silence, and please don't move around. Please be seated, maintain silence, and don't move around in between. So let's welcome the next chairperson of the session, Dr. Rajendra Keshwa, Principal, Narayana Hridalaya College of Physiotherapy, Bangalore, and the moderator, Dr. Shri Raghunath S., HOD and Associate Professor, RV College of Physiotherapy, Bangalore. The speaker of the session is Dr. Senthil Kumaran D., Additional Professor, Department of Physiotherapy, MCHP, Mahe, Manipal, Karnataka, for its topic, Game-Based Rehabilitation Following Stroke. Welcome you, sir.
Hello. Good evening, one and all. At the outset, I would like to thank the organizers for giving me an opportunity to moderate this session. I'd like to introduce Dr. Senthil Kumaran, a highly accomplished figure in the field of physiotherapy and academia. Dr. Kumaran is holding both MPT and PhD from Manipal Academy of Higher Education, and recognized as a fellow FAMER, currently serves as an additional professor within the Department of Physiotherapy at Manipal College of Health Professionals, Mahe, Karnataka. With a remarkable 25 years teaching career, he has held esteemed positions at various institutions and 17 years of clinical experience. Throughout his illustrious journey, Dr. Kumaran has garnered significant acclaim for his exceptional contributions. He received the prestigious World Physiotherapy Congress 2023 and played a pivotal role in Mahe's attainment of A++ accreditation by NAC in 2022. His innovative project, Arm-Amble Game-Based Arm Training Rehab Service, earned him esteemed IPIT Seed Investment Award in 2019. Give him a round of applause, please. Dr. Kumaran's wide-ranging research interest encompasses stroke rehabilitation, virtual reality, kinematic analysis, and interprofessional education, resulting in prolific research record with numerous publication grants and copyrights. His dedications extends to mentoring figure researchers, have supervised numerous PhD theses, PG dissertations. Beyond academia, he actively contributes to administrative roles, serving as an external expert member on various boards of studies and holding key positions such as quality management representative and IQSE coordinator at Mahe. His esteemed membership in professional organizations like World Physiotherapy, World Stroke Organization, and Indian Association of Physiotherapists underscores his commitment to advancing the field. I welcome you, sir. Over to you.
Thank you. Dear students, please maintain silence. Please don't move around, sit. See, speakers have come from different part of the country. They have prepared, they have put a lot of hard work. They have come here to speak their experience. Please respect them, listen to them. Don't move around. Maintain professional dignity, please. It's a humble request. Over to you, sir.
Okay. Thank you. Good evening, everyone. Good evening, everyone. I understand now it's already 4:30. You guys are listening from morning. Maybe I'll keep very short my presentation. So what I'm going to discuss now is about game-based rehabilitation following stroke. You all would have used games, right? Every one of us would have used games, because nowadays we spend most of our time with the mobile, right? So we play games. So this is one of the emerging options, therapeutic options for the patients to use. So I'm going to briefly tell about game-based rehabilitation, what we did in Manipal, that our experiences I'm going to share. So we all know stroke, it affects all parts of the body, it affects all domains of ICF, body structure and function gets affected, activities gets affected, and participation gets affected. And it's a leading cause of long-term adult disability. All of you will agree with me. Now, approximately 50% live with the disabilities, which leads to dependency. And out of all three areas, like for example, upper limb, lower limb, and trunk, we all know upper limb motor dysfunction is highly prevalent, up to the extent of 50 to 80% in the subacute stage, and then 40 to 50% in the chronic stage of a stroke. This is based on the time duration, we divide the stroke into different phases, subacute and chronic. Now within the subacute again early and then late. So we all know upper limb motor function, how much it is prevalent. That is most prevalent. And if you see, only 5 to 34% regain their function. And compared to the lower limb or trunk recovery, upper limb recovery is very less. We all know the reasons, because of the cortical representation. That's the main reason. And activities of the daily living sometimes can be done with the other limb, like the normal limb, thus leading to a phenomena called learned non-use. See, for example, in the lower limb, they have to use the lower limb for standing or walking. So they are forced to use. Whereas in case of upper extremity, anytime you ask the patient to reach for a glass, they start with their normal limb. They don't use their affected limb. So they have the option of using the other limb, which leads to learned non-use. So upper limb motor rehabilitation is very important for improving the quality of life and thus improving the independence in ADL. Now, therapeutic options, based on the current evidence, we have only task-based exercise program. Anything that you do with the task, it is effective. And that too, it has to be done yearly. Yearly means at least immediately after the stroke, within the first 6 months of the stroke, because this is a window where the recovery will be maximum, because the spontaneous recovery is there, so that whatever you do, it will accelerate the improvement in terms of a function. So early rehabilitation is important. So when you do early rehabilitation, if you incorporate some of the recreational activity, patient will feel more interested and motivated and then do the exercise. Because one of the major problem with the stroke patient is adherence. They don't do exercises regularly. So when you incorporate the recreational activity component, patient might feel interested and then they might do exercise. So game-based rehabilitation is one option which is user-friendly, everyone likes, it is safe, it definitely motivates because you have some targets, you have some avatars, and then it is enjoyable, and of course it's affordable also. And also, most importantly, it uses the principle of neuroplasticity and motor learning into rehabilitation. In terms of providing intensity, required intensity, creating interest, creating motivation, making the patient to adhere to the therapy, or also safety and affordability. So there are many RCTs are there, but we don't have any pooled evidence. So what we did is, we did a review. This is a review, what we published, to look at the effect of game-based rehabilitation in patients with stroke. So these are the strategy, like databases we used. These are the keywords, and these are the criteria that we have used to include the study. I wanted to focus on only two things from this review. One is, we looked at the games what are used for rehabilitation. So out of these 42 studies which we included, almost 24% only use functional games. 64% of the games were like non-functional, like just like we all play, right? Commercial, like Snake or Fruit Catcher. All these things are non-functional, just for fun aspect. But there were 24% of the games that were only functional, and remaining 12% were the mixed one. And when we use game-based rehabilitation or virtual reality, we provide in the form of immersive, non-immersive, and then mixed. Immersive in the sense where you see yourself, non-immersive is you don't see any part, and then mixed is semi-immersive is half immersive and then sometimes non-immersive. So this is what we found. But what we find is, in this review, there was some significant improvement with the game-based rehabilitation on upper limb function when we looked at the Fogel-Meyer assessment score. Similarly, when we looked at the activity, we did not find any change in ARAT scores, like activity, action research arm test. So what we looked at the methodology, it is actually most of the studies were having some concerns. Only 7 studies had high quality. So the main conclusion of this review was there were studies implementing the functional games which mimics the ADL was very less, which led to our innovation that is called ARMable, which we collaborated with Indian Institute of Technology, Hyderabad, and then we were part of the development of this device, where there is a monitor, gaming console is there, and then height adjustable actuators will be there. So here we had both the games, fun-based games, and then functional games also. Let us see some of the functional games like which we had in this device. Like what you see here is called champion cleaner. We all do regularly at home, like cleaning the windows or cleaning the table. So this is one game where the patient is supposed to hold the handles, and then in the monitor there will be a cursor, and then they are supposed to clean the windows. Similarly, we had one more, something called delicious dosa. Like this is context based because everyone will do at home. So this is something like a context specific. So where the patient has to hold and then make kind of a dosa, and then they will do the complete the movement. Similarly, one more like making chapati. It's called roll the roti, where they are supposed to move and then mix. These are some of the things which we made, which mimics the activities of daily living, so that the patient will feel little motivated to do because it's something close to their activities of daily living. There was one more like strike the mosquito, where they have to actually, So mosquito will appear on the screen, and then they are supposed to move the handles and then hit the target. So all these games are functional, and then the patient will get the targets. There are difficulty levels are there, so the patient will get into the higher levels of difficulty, so that the patient will do repeatedly, and then they have motivation also. So apart from that, we had, as I said, some of the functional games, like commercial games like bouncing the ball or fresh fruit catcher. All these games also which we had, because in between the ADL, we made the patient to do these kind of games. And not only that, later we had some of the additional advantages where you can tilt the board so that you increase the resistance, or you attach the TheraBand so that you can increase the resistance for the movement as a later progression, and then the patient will be trained in the same game based but at the advanced level. The same thing can be done in a standing also. So we had lot of other handles also to give more of activity frame. Like for example, we had a single handle where the patients can use a single handle. Initially start with the bimanual, then you go for a single handle. The patient can hold the single unilateral handle and then trace and then do the movement. Or something like we had attachment, like where you can attach the plate and then the patient can do something like, when we ask for food, or you reach forward, then you wash and then you tilt, all those things. We kept some of the handles where they can actually hold the mug, reaching for a glass or drinking water, something like that. So these were some of the additional things that we made to give more of functional perspective and to their daily activities framework. Also, along with that, we had developed one game also for assessment, which captures the intensity of the training. Like for example, how much time they are doing, or at the end, to assess their movement capacity, we had developed some games which captures the time taken or the velocity or the trajectories, all those things also. We had some of the games which give some ideas. So when we say altogether, this particular game-based rehabilitation, you can provide repetitive rehabilitation, because in the initial stages, if they are not able to use single hand, you can start with the bilateral and then go for unilateral. Of course, you can give intensive training because variety of games are there. So you can use any of the options. You can select based on the patient's interest, and definitely timely. We started using this even from the day 1 or 2 also you can use. Patient should be able to sit with the support. So you can use even from the early stages. If required, sometimes therapist also can give some assistance. And it is highly relevant because all the games were context-specific functional games. We all know relevance is important for neuroplasticity. And definitely patient will feel motivated because all these are functional games. And I said there are some progression, difficulty level we saw, so it is challenging also. Patient will not do the same exercise within their comfort zone. And patient will also get the feedback because there were targets. Immediately they get the rewards, or even they get the real-time performance feedback. Apart from that, we also had one assessment game through which we can assess the performance of the patient from the beginning and then the end. And definitely adherence will improve because it is functional, fun. Early only you can start. Sometimes the patient can do without the therapist also. And recently we have incorporated tele-rehab component also, so that the patient can do sitting at the home and then therapist can monitor from the hospital itself. So once we developed this device, we did a preliminary study which we published also. So this is a pilot study which we did with the participants of only 6 patients we did, and we compared with the conventional therapy. Outcome measures were again the same, Fugel-Meyer and activity domain action research arm test. Along with that, we even measured the distance covered by the upper limb using that particular game. So what we found in this particular thing is the patient spend most of the time when they do the exercise, and then the total distance covered by the arm was almost like ranging from 1,000 to 5,000 meters. Like how we have a 6-minute walk test for the lower extremity, which gives a measurement of their capacity. Something similar we thought we will use a capacity of the upper limb movement, so that we measured the complete time that they spend with the therapy games. So that is how we did this. So finally, with the preliminary study, we found statistically significant improvement in both the domain, but that is not the end for any researcher. You cannot say anything effective with your preliminary study. So we went ahead with the RCT. We gave the term of acronym Entertain Trial, which again we published. And then right now we have completed, it's a multi-center study. We recruited 120 participants from 4 centers across India. And right now we are doing the analysis, and then we have even submitted for a journal which is under review. So once if it completes or once it is published, we'll be able to share the findings of that RCT also. So we are also waiting to hear from the journal people. Once we receive, then we can share with you. So to conclude the game-based rehabilitation, definitely game-based rehabilitation can provide intensive therapy, repetitive therapy, definitely relevance when you select the games which mimics the ADL, and patient will feel motivated to do. And when you have a different level of difficulties, it definitely can provide a challenging environment also, and the patient receives the feedback when they do the games. No, that's why we all start playing and then get addicted to the games. We don't even know how much time we spend. So something like that, patient also will feel little motivated when they do the therapy. So future, maybe gamification is the future. Right now it's called extended reality. A lot of advances are happening in this particular field. As I said, once we complete our RCT, we'll be able to share the findings of that also. So the whole work, whatever I presented, is not my work alone. The group of people who worked for this is all my collaborators, my PhD scholars, and then some of the interns published the preliminary study, my research scholars, and then we got funding for this study, and our collaborator from the industry aspects also. We also got the funding from BABLE, that is Industry Grant, and Society of Indian Physiotherapists. So I thank all the people, those who supported us to complete the study. And I thank the organizers for providing me an opportunity, Mangalore Physicon. Thank you so much.
First of all, I would like to thank the organizing committee for giving me a chance to chair such a wonderful session, sir. It was indeed pleasure listening to you. And the way you said, most of us who are working in clinicals, they have seen the difficulty level, especially while treating the stroke patient who are having difficulty in upper limb rehabilitation, most of us. So definitely this approach, the gamification, the use of technology can help us, as you say, it will be the future of rehabilitation. So, and also the point you have said that it's not, can be used as treatment, but also can be used to assess the kinetic and kinematic parameters of motor control. So I think that's also something wonderful which can be included. So ultimately, thank you so much for such a wonderful presentation. Any questions from audience?
Thank you.
I have some small doubts, sir.
Yeah.
Is there any baseline parameters we take to whomever we are including for this rehabilitation in terms of GRAPE or something like that?
Obviously, every patient we have to assess some baseline measures. For example, in our study, what we did from the clinical measure aspect is we used Fugel-Bayer assessment, and then for activity we use action research arm test. There are many more measures also are there. Also from the kinematic aspect, what we did is initially we made the patient to do that assessment game. Some of the patients or most of the patients were not able to do. So we noted down them like not able to even move the thing. And then with the training, we made them to do the assessment game, and then we saw the difference. So it is like when you include a patient not able to walk, and with the training they were able to take few steps. Something like that in this also we observed. Initially when we recruited the patient, they were not able to even move. So we went with the bimanual, and then we gave some assistance. And then with the 6 weeks of training, at the end when we did the assessment game, they were able to move, and then they were able to achieve something. So definitely we have to measure at the baseline. Then only we will come to know whether it is effective or not.
Thank you, sir. Thank you so much.
Thank you, everyone.
So it was another informative session by Dr. Senthil Kumaran. Now I request the chairperson and the moderator to hand over the token of appreciation to our speaker, Dr. Senthil Kumaran D. I also request Dr. Nitin Chandra Kini, Principal, Vikas College of Physiotherapy, Mangalore, to hand over the token of appreciation to our moderator and chairperson of the session. Thank you, sir. So we are moving on to the last session of this scientific session for today. That is, the chairperson for the session is Dr. Sai Mahendran, Associate Professor, Gautam College of Physiotherapy, Bangalore. And the moderator for the session is Dr. Sharath, Associate Professor, Sridevi College of Physiotherapy, Mangalore. And I also welcome the speaker for the last session today, Dr. Mayura Kudva, physiotherapist and founder director, Physio4U, Bangalore, Karnataka, for the topic Unlocking the Potential of Conservative Scoliosis Treatment, Principles and Practice. Before the session, I request all the students to be seated and please maintain silence.
Good evening, everyone. It takes an immense pleasure to introduce you to our next speaker, Dr. Mayura Koduva. She is an experienced physiotherapist with a focus on treating spinal deformities, particularly scoliosis and kyphosis. After her graduation from Father Muller's Mangalore, she founded the Physio4U in Bangalore, India, to provide focused rehabilitation services to patients with a range of neurological, orthopedic, pediatric, sport, and geriatric rehabilitation requirements. Dr. Koduva has completed several certifications in evidence-based methods for managing scoliosis, including the Scratch method from Germany, SEAS approach from Italy, Lyon method from France. She is also certified in dry needling therapy and orthopedic manual therapy. Dr. Koduva is committed to early detection and management of scoliosis and has initiated spine check practices at schools to identify the condition in growing children. She has successfully managed mild to moderate adolescent scoliosis and adult scoliosis with physiotherapy-specific exercises and collaborated with orthotics to provide the best possible correction in braces. Dr. Koduva is fluent in multiple foreign languages. Thank you, ma'am. Over to you.
Thank you. Good evening, one and all. At first, I would like to thank the organizing committee and scientific committee to give me a chance to share my experience here. Today, I hope to encourage the young physios to explore different paths or conditions which are normally not attempted or by the physiotherapist or considered that it is not possible. So when I stepped into this path, the situation was somewhat same in our country. So when do you call it scoliosis? As per the Spine Research Society, when the Cobb angle is about 10 degrees Celsius, 10 degrees or the forward bending, you find an angle of trunk rotation of more than 5 degrees, it is defined as scoliosis. Or you could put it as a three-dimensional torsional deformity of the spine. So not just a lateral deviation, but a torsional deformity of the spine and eventually the trunk. So when we say three-dimensional, you see a lateral curvature in the frontal plane, axial rotation in the horizontal, or reduction of the normal curvatures in the sagittal plane. So here again you can see a lateral deviation, rotation, and the reduction of normal curves in the sagittal plane. So the natural history of scoliosis can be well described with the vicious bone circle of Ian Stokes. So it starts with a mild curvature, which leads to more asymmetrical loading, more and more asymmetrical, leading to more asymmetrical growth, wedging of the vertebrae, leading to disc wedging, and finally structural scoliosis. So how do we work on this? Is we reverse the forces. So in the conservative way, we work by creating a virtuous cycle. So creating opposite forces in all planes. So reversing the asymmetrical loading, reversing the asymmetrical growth and wedging. So to correct the, so here and another image you can see, it is mostly seen that there is a relative anterior spinal overgrowth in the growth spurt, so which initiates this kind of changes in the body. So to treat a three-dimensional deformity, you have to do a three-dimensional, you have to choose a three-dimensional approach. A backward bending is definitely not in somebody with a hypokyphosis, or a lateral bending as we used to in the earlier days will either not help or could worsen the deformity. So a three-dimensional approach, like in the fifth image you can see where there's an elongation, rib corrections, and breathing and all. So this is over a period of a year. This is the results over a period of a year in a lumbar scoliosis. And when I started, patients used to come without referral. They were not told for physiotherapy. They would hunt for alternative therapies and come, and sometimes against their spine surgeons or against their orthopedic surgeons' wish, they would come. Finally, after seeing the results, now the ortho also have started referring, even sometimes post-surgical cases. So when it is mild, so it is correctable, and it is likely that most of the structural deformities start as a functional curvature and only then become structural. So catching them young is the main, this. As a pictorial representation here, you can see that when it is mild to moderate, it is much correctable, and when it is moderate to severe, is much more harder. So when is it too late? When the curve angle has crossed 50 degrees at the end of the growth phase, the curve can progress in the adulthood. So goal is to maintain it less than 30 degrees. Yeah, so what I'm trying to say is our first role, or the potential as we talk as physios, our first role is to promote awareness and catch them young, get ahead of the curve, and screen for scoliosis. So, which can be done either in today's day easily by promoting on social media or presenting in several forums like this, or especially trying to work towards getting a screen check done at the school, like it is done in developed countries. So how do we do the screen check? Is super easy by checking the body asymmetry and the aesthetics. So this is a scoring developed by Italian Esico. So here you check the shoulder asymmetries or the scapula unevenness and hemithorax and the waistline asymmetries. So when you find asymmetries along with the forward bending test, if you find a rotation of 5 degrees or more, it is towards scoliosis. However, in a growing child, curve of 4 degree also to be kept on maintenance. Also a plumb line to be checked for a truncal shift. The x-rays have to be taken in standing always, a whole spine, to check for any compensatory curves as well, not just limited to thoracic or lumbar, including the cervical and pelvis, to check for the rotation and for the Risser grade, which guides us how to go about the treatment. So whether to start, when to stop, when to go with what level of treatment is guided by the Risser score here. So Risser 0 to 3 is a very progressive phase, and Risser 5 is slowly, and 5, once you reach 5, you stop the therapy. You can stop the therapy or bracing. So how do we go about treating scoliosis? So each one of us professionals have our own tool to deal with this. So physios, as physios, we go with the exercises, the orthotists with the bracing, and the surgeons, of course, with surgery and fusion. So none of us are above the other. It goes hand in hand. So only exercise or only bracing will not help. Maybe when it is very, very mild, only exercise might help. But once it crosses 20 degree, teamwork of the orthotist and the physios has to be done, where the exercise helps in building the muscle memory and the brace helps in holding the posture through the day. So here you can see 2 examples. So the first one where it was very minimal and only we got correction with exercise. The second one, you can see how the bracing has almost corrected the thoracic curve, more than 50%. So SOSOT is our Society of Scoliosis, Orthopedic and Rehab Treatment, conservative. They guide us on the conservative management. Here you can see the SRS, that is Spine Research Society, the Surgeon Society, and the SOSOT guidelines. So there is a little difference, but there is quite a consensus. So if the society asks us to start the therapy much earlier than the Surgeons Committee. So the SOSOT has also provided us with the levels of treatment. So first under observation, then exercises, elastic braces, then rigid braces, casting or surgery. The SOSOT has also developed a practical approach scheme to make it easy for us to choose the minimum strength and the maximum strength of exercise that can, or treatment that can be done. So for a RISA 0 with a 20 degree observation to part-time rigid bracing. So, or for a RISA 0 with a 45 degrees full-time rigid bracing or surgery. So the treatment is also mentioned. Also for the adult patients. So physiotherapy scoliosis specific exercises. These are the few schools which are approved by SOSOT. So they have provided evidence, Lyon method, Schroth from Germany, Schroth from Spain, SES, side shift, Dobomet from Poland, and FITS. So the criteria of physiotherapy scoliosis specific exercises being curve pattern, they have to be curve pattern specific, have to have 3D autocorrection, with which you stabilize the corrected posture, and finally apply it in activities of daily living. So this is how we counter the forces that are working on the spine. So the first one being gravity working on the curve, you treat with elongation. The concavities are, you breathe less into the concavities, so you teach them repetitive breathing and also breathing into the concavities. And also the third picture here is talking about the derotation that we do. And also it is done in many postures, from in lying, sitting, standing, kneeling, walking, many postures. So you build the proprioception and you make their corrective posture the habitual posture. So Schroth is one method where we divide the body into blocks, and here we teach them how to position to correct their prominences, corrective breathing, stabilize, and also give, see, this is one position in which they are exercising, correcting their prominences, stabilizing, and another position over here. This is the corrective breathing that you do. Exercises are done in brace and followed in with ADL activities. SACE is a method where they do not use props to correct, but active self-correction is promoted and stabilize the spine with different exercises, maintaining the active self-correction, so most manageable correction. Dobomed is a method from Poland. Here you put them in closed kinematic positions, initially lower, then higher positions, where the shoulder girdle and pelvic girdle is stabilized, and work on breathing. So breathing into the concavity you can see in the first picture, to breathing out from the convexity you can see. So these are the kind of positions they are put into. Lastly, the side shift is a method from UK. It's a simpler method but more repetitive. Their way is to repeat it many times in a day. So with every action that you do, they call it think shift. So for some thoracolumbar curves and lumbar curves, you do a hitch, and for a thoracic curve or double major curve, a hitch and a shift. So these are some of the results that we got at our center. So here is a lumbar curve. Here is a adult, but we have got good truncal correction or coronal balance here as well as here. So in this curve we have got a good coronal balance once again, though the rotation, because it was a little more severe. Here you can see over a period of 1 time. So you have to be you have to be the facilitator for the patient here. It is more, the results are more dependent on the patient and the parents' cooperation, because it goes over a period of 3-4 years from the time they detect to end of growth phase. So here his X-ray, you can see that how even the coronal imbalance plus the rotation has been corrected. That's in a year of wearing brace 20 hours, 22 hours a day, and with exercises, consistent exercises. This is one of the post-surgical cases who had a little bit of residual deformity, was corrected. Also, it even can be done in adults, unoperable, so you can still do it. So these are some of my teachers globally, and thank you once again. So I would like to add that working on this, I have a lot of cases that come to me from across India, not just Bangalore where I work, from across India, from Mangalore, from Chandigarh, from all over. So I'm not proud about that. I wish at least some of you learn these methods, and hopefully in future we have therapists to deal with scoliosis in every town and city. Yeah. Thank you.
Thank you, ma'am, for enlightening all of us with your, the new concept which you have developed by doing on so many patients, as you are told, and you focused on a certain set of, the protocols which you have followed and other things. So, any questions? Any questions from the audience?
They are waiting for the next event, I think. So
All may be busy with the
yes.
eagerly waiting for the culturals, I think so.
Yes. And happy World Physiotherapy Day to you.
And just before concluding, ma'am, just one thing. So, along with the exercises and other protocol, the way of breathing which has to be concentrated by the patient, the corrections which they have to attain, should it be, means we have to concentrate that also along with it? Or we can teach them later? Should it be carried along with the protocol or later?
Little by little from day one, little by little.
Okay.
Yes.
Because once the correction comes, the expansion, I think it may be occurring. The spine curvature when it is recovering.
Yes.
So it will be better when you are starting it, I think.
Yes,
So.
it has to be maintained. So
Because you may be seeing a lot of cases, that's why I asked you.
So the therapy is not limited to the 1 hour of exercise, but through the day several times.
Okay.
Inside the brace as well.
Oh.
Yeah.
Thank you, ma'am.
Thank you, ma'am.
Thank you for giving your time for this insightful talk, ma'am. So now I request the chairperson and the moderator of the session to hand over the token of appreciation to our speaker, Dr. Mayura Kudva. I am also glad to request Dr. Smita, Professor, Enapaya Physiotherapy College, Mangalore, to hand over the token of appreciation to our moderator and chairperson of the session. So with this, we are coming to the end of the scientific session for today. So myself, Nigat Fatima, signing off the session for today. Thank you all for your time and patience.
Good evening, everyone. I know you are eagerly waiting for the culturals, but before that, we have a surprise for you. My name is Divya Gupta. I have an experience of over 14 years, including clinicals and academics, and currently associated with CBS Publishers and Distributors as a project manager and editorial head for the physiotherapy segment. Let me present to you the company and its new initiative, PhysioBrid. Next. Volume. Pause. Volume, please.
Instruct the patient to supinate the forearm against resistance.
I request Dr. Gladson Jose, Principal, M.B. Shetty College of Physiotherapy, Dr. S. Rajasekar, Dean, Institute of Physiotherapy, Srinivas University, Dr. Luraraj, Principal, Ennepoya Physiotherapy College, Ennepoya deemed to be University, and Dr. Sarath, Associate Professor, Sri Devi College of Physiotherapy, Mangalore, to come on stage and release the BD Chaurasia Special Physiotherapy Edition. and Dr. Vaishali, Board of Studies, Sir, Chairman, Chairman, Board of Studies, RGUHS. On the occasion of World Physiotherapy Day, BD Chaurasia's Human Anatomy's Special Physiotherapy Edition. This is a set of Volume 1 and 2 with a free companion booklet specially designed for physiotherapy students. I thank the organizers for providing us this opportunity.
Check. Check. All. Check. Check, check, hello. Check, check, hello, hello. Check, check. Check, check, hello. Hello.
Institute of Trauma and Orthopedics. So I call them here on stage as they occupy. Please applaud for them, ladies and gentlemen. Here we have Sanjay Gandhi, Institute of Trauma and Orthopedics. A bright good evening to everyone. Firstly, happy World's Physiotherapy to all the physios. Myself, Megashri K.N., MPT in Sports Science from Sanjay Gandhi College of Physiotherapy. Sanjay Gandhi College of Physiotherapy is the only government of colleges in Karnataka. We all are getting benefited from this government institute in all the aspects like well exposure in the clinical sites. We want to tribute our performance to the Dr. U.T. Kadar sir, Honorable Speaker, Government of Karnataka, and Dr. U.T. Iftikhar sir, Organizing Chairman, who is instrumental in getting this instrumentation in function. We all are grateful to you, sir. The word Shiva means deathless, changeless, timeless, formless, all-pervading absolute essence of the universe. Well, let us start this performance with the Lord Shiva's blessing. Put your hands together for this wonderful performance from Sanjay Gandhi College of Physiotherapy.
शंकरा तेरे जाप के बिना चले ये सांस किस तरह मेरा कर्म तू ही जान क्या बुरा है क्या भला तेरे रास्ते पे मैं तो आंख मूंद के चला तेरे नाम की जोत ने सारा हर लिया तमस मेरा नमो नमो शंकरा भोलेनाथ शंकरा जय त्रिलोकनाथ शंभो हे शिवाय शंकरा नमो नमो शंकरा भोलेनाथ शंकरा रुद्रदेव हे महेश्वरा जोगी 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 शंभो शंकर हर हर महादेव ಗಂಗೆ ಅವನ ತಲೆ ಮೇಲೆ ನಗರ ಹಾವಿನ ಸರಮಾಲೆ ಕೈಯಲ್ಲಿ ಬೆತ್ತದ ಕೋಲು ಮೈಯೆಲ್ಲ ವಿಭೂತಿ ಸಾಲು ಯಾರೋ ಅವನ್ ಯಾರೋ ಜೋಗಯ್ಯ 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 ಗಂಗೆಯ ಅವನ ತಲೆ ಮೇಲೆ ನಗರ ಹಾವೆ ಸರಮಾಲೆ ಕೈಯಲ್ಲಿ ಬೆತ್ತದ ಕೋಲು ಮೈಯೆಲ್ಲ ವಿಭೂತಿ ಸಾಲು ಯಾರೋ ಅವನ್ ಯಾರೋ ಜೋಗಯ್ಯ 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 ಜೋಗಯ್ಯ
పదమిరీశా శివని వేదనగా అవని వేదనగా పలికెను పదము పరేశా నీలకంఠరా చాలి పొందరా కరుణతో నను గనరా పదనిదేశా శివని వేదనగా వని వేదనగా పలికెను పదము పరేశా
An incredible performance. Surely you have set the stage for all the upcoming performances right here. Thank you so much, Sanjay Gandhi Institute of Trauma and Orthopedics. Thank you once again. Ladies and gentlemen, right now we are going to have the inaugural ceremony. So I request Dr. Vaishali, the convener of Physicon, to please escort the dignitaries here onto the desk. Ladies and gentlemen, let us give a standing ovation to all the dignitaries as they take on the stage. We have Dr. Sanjeev Keja, the President of IAP, Dr. Suresh Babu Reddy, Vice President of IAP. As our judges, we have Dr. Ali Irani, the President of IAP International Affairs and the Head of Department of Physiotherapy at Nanavati Max Super Specialty Hospital. And along with them, we have two other special judges here with us today. Ladies and gentlemen, that's none other than Mrs. Zulu, who has come all the way from New Delhi, who is a well-wisher of Mangalore Physicon, as well as we have the well-known choreographer of the most awaited and the most loved movie by everyone all around the world, that was Kantara. And the choreographer, Mr. Praveen, is right here amongst us. Ladies and gentlemen, please give them a huge round of applause as they come forward and take the seats amidst us. everyone here has come with a lot of enthusiasm. And I must say, all of you deserve a suitable welcome. And who better to represent the whole physiotherapy fraternity? बच्चा बच्चा फिजियोथेरेपी का हर एक बच्चे की जुबान पे है इनका नाम. I'm speaking of none other than the man who doesn't require any introduction, that is Dr. Ali Irani. Ladies and gentlemen, put your hands together and welcome him as he comes forward to welcome each and every one of you.
Good evening. The noises that I saw looks the inauguration of the conference has started now. I'm sure you all were waiting for this evening. It's an evening in all conferences what we see in Mangalore for the last more than 20 years that I'm seeing. The evening part is one of the best because all the colleges compete, and we are back again here today with more than 10 colleges competing. And by the end of the evening, you will see the result. I'm sure you all will cheer for all the colleges together. Yeah. Because please understand, they have worked hard. Some for a month, some for 2 months. They have worked hard to come before you all, and a big crowd of almost 4,000 physiotherapists here. And I'm sure the judges are going to be fair enough to them. They don't know your colleges. Your colleges will be called by the numbers. So whatever marks that they give, at the end when the result will be announced, then the college names will be known to you all, which college has won. And I'm sure the support, the encouragement will be from all of you all. We start the evening. Again, I am grateful to all the organizers, Iftikhar Ali, Sohail, Vaishali, and all the teachers, Canara Teachers Association, thanking IAP President Dr. Jha, Vice President Dr. Reddy being here, the judges which have come from outside Mangalore to judge performances here today, and all the South Canara Teachers Association, all the principals, teachers. I know you all have brought the students from all over Karnataka to be here today. Wishing all the colleges all the best. Thank you.
Thank you, Dr. Ali Rani, for that warm welcome. And now we would like to florally welcome each and everyone who are here on stage. And for that, first and foremost, I would like to welcome Dr. Sanjeev K. Jha, the President of IAP. And to do the honors, I request Dr. Aisha LV to please come forward with the bouquet and florally welcome him. Thank you, sir. It's an honor to have you with us. We have Dr. Shruti Satyan, who would come forward to florally welcome Dr. Ali Irani, the President of IAP International Affairs and the HOD of Nanavati Super Speciality. To welcome Mrs. Zulu, we have Dr. Mehchura, who would come on stage to welcome her with a floral bouquet. I now request Dr. Shahnaz to please come forward and florally welcome Mr. Praveen, the choreographer of Kantara. Ladies and gentlemen, the applaud is not enough. Come on, please put your hands together for everyone here on stage. It's now time to enkindle the truth that we have right here and inaugurate this ceremony. Ladies and gentlemen, we have with us a very kind soul, a God's gift, a specially able child, Muhammad Ruwaid. And I request the volunteers to please get him here on stage for the inauguration ceremony. I request the dignitaries to light the jyot along with Muhammad Ruhaid right there. Yes, he represents all the lives which we have made a difference in. We physios have touched the lives of him and such children everywhere around the world. Thank you, dignitaries. I request the dignitaries to present Master Ruhaid with a memento at this moment. Here we have Master Ruhaid being felicitated on this occasion. A special welcome and honor to those who are running the show. I request Dr. Aisha to please come forward and florally welcome Dr. Vaishali and Dr. Suresh Babu Reddy at this occasion. I request Dr. Shruti to join along. It's an honor to have our guests right here with us today, especially the judges. Let me take a moment and speak about our first judge, that's Mr. Praveen, who is the choreographer of Kantara. He's the General Secretary of Dakshina Kannada District, Karnataka Dance Sport Association, All India Dance Sports Federation, and of International Dance Sport Federation of Asia. Ladies and gentlemen, please put your hands together as Dr. Sanjeev Kecha presents Mr. Praveen with a memento on this occasion. Please put your hands together. We have with us a special judge, another one who has a very keen interest in music, art, dance, and all forms of it. and she is a very ardent supporter of Mangalore Physiocon. I'm speaking of none other than Mrs. Zulu, who has come all the way from New Delhi. She is a proud mother of Ms. Najma, who is in the Indian Embassy of Poland. We would like to honor her by giving her a memento, and I request Dr. Ali Irani to present her and honor her with a memento. And with this, we come to the end of the inaugural ceremony. The cultural events will begin shortly. I request the dignitaries to please take their honored seats below the desk. Thank you.
Thank you, Jasmine. Before you go for the cultural events, I request the organizing committee members who did the tireless job from this morning to maintain discipline and the quorum in the auditorium. And it was all appreciated from the morning session, from the chief guest to the governor. It was one of the best conference ever they have visited and seen. So I wish you students to see today and tomorrow a fruitful event. Thank you for cooperation. This conference, whatever has happened, all because of you delegates. Thank you one and all.
Well, Professor Dr. Sidney here has washed off his hands by handing over the results to me here. So, are you all ready for the results of the preliminary round of quiz? Yes? Where are the quiz participants at? Please raise your hands. Okay, so out of the 20 colleges who participated in the quiz, 6 of them have qualified, and now I'm going to announce the names. Are you all ready? So team number 1 is Ahiya Saji and Abhilash K from Dr. M.V. Shetty College of Physiotherapy. Congratulations. Team number 2 is selected Kiara D'Souza and Abel Jacob from Father Muller College of Physiotherapy. Team 3, Mithun Mohan Bhavish Anchan from Mangala College of Physiotherapy. Team 4 is Mikdad Ashraf and Ajit Pereira from Father Muller College of Physiotherapy. Team 5 is Shruti and Arjun from Sridevi College of Physiotherapy. Team 6 is Ashwin T and Sebastian Matthew from Dr. M.V. Shetty College of Physiotherapy. Congratulations, and this is in no order of scoring. Don't worry, you all have qualified for the finale that is going to be held right here on the in the auditorium tomorrow. So please be present here at sharp 11:30 a.m. Tomorrow at 11:30 a.m. at this auditorium, so do not miss it. Thank you. Well, yesterday was a very tough competition. 24 colleges all around from Mangalore had given a cutthroat competition to each other. And I'm sure, along with some pleasant time, they gave a difficult time to the judges in selecting who were the winners. So here are the 10 teams who are selected to perform here today. Yenapoya Physiotherapy College, Vikas College of Physiotherapy, PA Institute of Physiotherapy, Srinivas College of Physiotherapy, Dr. M.V. Shetty College of Physiotherapy, Kripanidhi College of Physiotherapy, Kanachur Institute of Physiotherapy, Sridevi College of Physiotherapy, Indira College of Physiotherapy, and last but not least, Padma Shri Institute of Physiotherapy. So all of these teams are going to perform as a team, and not only that, we are going to have some solo performances, special performances right here. We have the judges all set to judge these performances. So ladies and gentlemen, please hold on to your seat to enjoy the cultural evening today. Let me brief you all with the rules and regulations. There are a few points that you have to keep note while performing here on stage. Bonus points for originality of materials, special effects, overall excellence of presentation. Keep note. Any events with fire particles are not permitted on stage. 1 point will be deducted from each judge sheet for every 30 seconds of overtime. So please be within the limit. Disqualified if crossing time limit over allotted time by 2 minutes or more. No extra time will be provided for stage setting and clearance. Displaying any religious issues and antisocial issues are strictly not allowed. Vulgarity of any kind will lead to disqualification. Language for communication will be either Hindi or English. Especially, please note, no disclosing the college name. If you have it in your script, take it off right now. No disclosure of the college name, and please abide by these rules that I've announced just now. Thank you. And here we begin with the first performance for this evening. Chess number 1, you may take the stage. Chess number 2, please be ready.
കണ്ട് താമസിച്ചേ കാളകേറ പൊന്മലയിൽ കാളകളി കണ്ട് താമസിച്ചേ ആടുകേറ മാമലയിൽ ആടുകളി കണ്ട് താമസിച്ചേ കുയിലുകേറ പൊന്മലയിൽ കുയിലുകളി കണ്ട് താമസിച്ചേ കൊക്കുകേറ പൊന്മലയിൽ കൊക്കുകളി കണ്ട് താമസിച്ചേ കുതിരകേറ മാമലയിൽ കുതിരകളി കണ്ട് താമസിച്ചേ വന്നുദിച്ചേ നിന്നുദിച്ചേ ആദിത്യ ഭഗവാൻ കുട്ടലിലും നെല്ലും കെട്ടിയെടുത്തുകൊണ്ടോരായിരം കുലക്കയ്യും വീശി വരും കാരണോരെ പേരുമയും ഭൂമിയിലെ പുലയോരെ കഥ പറ പുലമകൾ സരസ്വതി നാവിലാണ് കഥ അഴകിയ നസികാളി കുഞ്ഞളരി കുറുമ്പയും ആണിഞ്ചനും കരിമ്പനും കൊച്ചുറുമ്പൻ കാവലനും കട്ടതട്ടി ചാലുകീരി ഉഴുതിട്ട കഥയിലെ വിത്തെറിഞ്ഞ മുളപ്പിച്ചു ഞാറുന്ന കഥയിലെ വീഴ്പ്പും കളിക്കൂട്ട ഒരു പണി അലക്കൊമ്പൻ പുകൾ പെറ്റ പഴങ്കാല കനികൾ കൊടുക്കും കഥ വെള്ളം കേറും വേലികളിൽ നിന്നെ കോഴി പോലെ വന്നു ചുട്ടുപോ കാളികളിരിച്ചുണ്ട തോറും ചിരിക്കഥ തണ്ടിലാണ് ചുണക്കഥ അന്നിക്കേറുവാടമേരിക്കുന്ന മുട്ടിപ്പാട്ട് പാടി കിളിയാട്ടി നരിയാട്ടി രാവിടത്തും പോരം കഥ ചെല്ലിപ്പുല്ലും പച്ചപ്രാന്റെ കള്ളക്കണ്ണും പറിച്ചെറിഞ്ഞില്ല പടി കടന്നു പൊങ്ങി പുല കള്ളിക്കഥ പേരുവയ ഭൂമികളിൽ പല ഭൂമി കൊയ്തെടുത്ത് വരുങ്കാല കാണുന്നൊറ്റ പുലയോരെ പഴങ്കഥ പറ 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 ഉള്ളതമരെന്ന് ചൊന്ന് കാലകണ്ട വരമ്പത്ത് കീഴിത്താളെറിഞ്ഞു പോന്ന കുലങ്ങൾ പഴങ്കഥ പറ പറ കഥ പറ ആദി ഭഗവാനെ പറ പറ കഥ പറ ഐക്യര കാരണോരെ പറ 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 കഥ പറ 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 കഥ പറ 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 കഥ പറ 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 കഥ പറ ഭഗവാനും വന്നുദിക്കാൻ ഇത്ര താമസിച്ചേ
വന്നുദിച്ചേ നിന്നുദിച്ചേ ആദിത്യ ഭഗവാനോ ഇന്നെന്നെ ഭഗവാനോ വന്നുദിക്കാൻ ഇത്ര താമസിച്ചേ
Judges, please note that was chess number 101. The time taken was 6 minutes and 5 seconds. Chess number 102 may take the stage. Chess number 103, please be ready.
Check. Check. Check.
A small announcement. Those who haven't taken the chess numbers, that's 107, 108, 109, 1010 and 1011. Please come here to the front desk at the MC desk and collect your chess numbers immediately.
Check, check. Good evening, ladies and gentlemen. Music gives soul to the universe, flight to the mind, wings to your imagination, and life to everything. Here we are presenting to you a culmination of diverse languages as one.
Mic 1, check, 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 check.
Mic 2, check, 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 check.
Mic 3, check, check.
Mic 4, mic 4, mic 4, check, 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 check.
Check, check, check.
Check,
Check.
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 Judges, kindly note, this was a sound check.
Power, current power. घनन घनन घन घनन घनन घन घनन घनन घन घनन घन घनन घनन घिर घिर आए बदरा घन घन घोर कार चाहे बदरा धमक धमक देखो बजरा दे चमके चमक चमक देखो बिजुरिया चमके मन धड़काए बदरवा मन धड़काए बदरवा मन 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 धड़काए बदरवा तंग तेरे के मन बह के तेरे कह के खुद को मेरे दिल की बात जाने कायनात तेरे दिल की खबर बस मुझको तंग तेरे के मन बह के तेरे कह के खुद को मेरे दिल की बात जाने कायनात तेरे दिल की खबर बस मुझको दम दरे 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 दम ये चांद सा रोशन चेहरा सुल्फों का रंग सुनहरा ये झील सी नीली आंखें तेरा जहन में गहरा था ये फिक्र क्या उसकी जिसने तुम्हें बनाया क्या उसकी जिसने तुम्हें बनाया
Judges, that was
Thank you.
chess number 102 for you. They have taken 7 minutes and 54 seconds. Chess number 103, please take the stage. Chess number 104, please be ready.
Ask them to give their this thing pen drive to the sound system prior itself. Just make an announcement. Some people might be asleep.
Participants, please give your pen drives with the audio at the front desk over there before the performance begins.
Breaking news. A shocking incident has happened at street of Mangalore. Last night, a 20-year-old girl has been brutally raped and murdered.
अभी सूत्रों से पता चला है कि एक 20 वर्षीय छात्रा को कुछ युवाओं ने बेरहमी से बलात्कार कर मार दिया गया है।
The social media is going wild. The streets are lit up with fire by the protesters. The police has informed the victim's family that the culprit will be caught within 2 days.
We want justice! We want justice! We want justice! We want justice!
After 2 days of the incident, her soul came back to see whether she got justice or not. But what she saw was a busy world.
Please protest for me. Nobody is fighting for my justice. I never got my justice. Everybody forget about me. Nobody is protesting for me. This isn't just for me, but for the upcoming generation. No soul should feel the pain that I have felt. How can you forget about us in just 2 days?
कारी कारी रहना सारी सांधेरे क्यों लाई रोशनी के पाँव में ये बेड़ियाँ सी क्यों आई उजियारे कैसे अंगारे जैसे छाँव झैली धूप मैली क्यों है तितलियों के पंखों पर रख दिए गए पत्थर है खुदा तुम है कहाँ रेशमी लिबासों को चीरते हैं कुछ खंजर है खुदा तुम है कहाँ क्या रीत चल पड़ी है क्या आग चल पड़ी है क्यों चीखता है सुरमई धुआं क्या
Audio poi, connection poi, nikka. From income, so many errors are happening in the LED. Always problem with that. LED is having a lot of issues here. ಇಲ್ಲ.
Since there was a technical issue, the chess number will get to redo their performance. They will do it from the top. Chess number 103, your time starts now. Okay. Here we are taking a break.
Chess number 104.
Chess number 103 will perform later. The next number, chess number 104, please be ready on stage.
What is happening? Audio track issues. That's same thing. Yesterday also they had some wire issue. Till now they didn't correct. So he's telling me yesterday it was not.
I request chess number 104 to please be ready on stage.
Chess number 104. What is happening there? They are wire